All right, a very good morning to all of you. So, see, the question you are asking is more true for molar pregnancy rather than for ectopic. In ectopic, if it's not methotrexate, we go ahead for a surgical management. We don't give actinomycin D, right? The question you are asking is more true for molar, so you're getting confused between the two topics, right? And somebody is writing area stellar reaction. Area stellar reaction is nothing. It is seen in cases of pregnancy, any kind of pregnancy. It may be ectopic, it may be intrauterine, it may be any kind of pregnancy. So what area stellar reaction is that if you take a sample from the endometrium, it resembles that of a malignancy. So the appearance of the endometrium resembles that of malignancy. So area stellar reaction is not specific to ectopic. It can be seen in any condition in which there is pregnancy, right? Right. Somebody is typing, Dhule is typing, have a nice day, ma'am. We'll have a nice day together, right? I can't have a nice day alone. So if we have a nice day, we're going to have a nice day together. Kolhapur is asking, what is the meaning of a blighted ovum? A blighted, as I told you yesterday, I think I did mention what a blighted ovum is. So when you talk about blighted ovum, it means that the G-sac has come up, but the G-sac has come up, but inside the G-sac there is no yolk sac and no cardiac activity. So when the G-sac does not develop a yolk sac, it is called as a blighted ovum. That is what a blighted ovum means. So now can we start with what I want to start? OMG, what is that? For all MCQs, please put them on the club. Let's not waste time on the MCQs. Then you will again later say, ma'am, course mein ye reh gaya, wo reh gaya. Hai na? For all questions that you want to ask, then that you can do by putting the question on the club and tagging it to me. I ensure that I'll answer your questions. All your queries will be answered, so don't worry about that. Right? I'm not going to repeat anything right now. Right now I'm going to go ahead. The treatment of conval block in simple words I said is tubal cannulation, right? The treatment is tubal cannulation. It is effective in 50% cases. If not effective, then for all other cases which are not treated by tubal cannulation in a conval block, the answer is IVF. I'm not checking notepad because I'm not writing anything on the notepad, so hold on. Rotak, I said, if you talk about serum progesterone levels in ectopic, all we can say is that there will be less than 5. So, whenever the level comes less than 5, we don't know whether it is a non-viable pregnancy or it is an ectopic pregnancy, right? Or it may be even somewhere between 5 and 25, but it is definitely never more than 25. So, usually, less than 5 we say is a non-viable. Between 5 and 25 can be seen in ectopic. And the last thing I said was if it is more than 25, then it is a viable intrauterine pregnancy. And alright, so we start the day with a compliment, and Kolhapur says that I teach very nicely. Alright, I'm glad that you're liking it. That's what we are here for. So there's no purpose if you don't like the teaching, right? All right, on that note, we start. Okay, guys, I'm listening to all of you. We are trying to keep all of you happy, but as they say, it is very difficult to keep everybody happy, right? So some of you would still be pissed off with me. Okay, now we talk about infertility was what we were saying. Yes, so we were talking about infertility, and what we are going to talk today, we talked about the ovarian factor infertility, and we talked about the tubal factor infertility. The next thing we talk about is cervical factor infertility. Although there is not much about cervical factor infertility. But when we say Cervical factor infertility, basically what we are concerned with is presence of anti-sperm antibodies in the cervical mucus. Presence of anti-sperm antibodies in cervical mucus is what we are concerned about. Other than this, the causes of cervical factor infertility could be varied. It could be cervicitis. It could be an abnormal position of the cervix. It may be exposure to the drug diethylstilbestrol, right? But for us, the most important thing is presence of anti-sperm antibodies. And the various tests which we do to detect the presence of anti-sperm antibodies are like this. So the first test is called as the postcoital test. Now, postcoital test, again, these are old, it's a very old test. We are not doing postcoital test at all nowadays. But since it was done once upon a time, there may be questions which are trying to ask you about the postcoital test. So as I said, what we are trying to look for is the presence or absence of anti-sperm antibodies. Now this test, the most important thing about the test is the timing of the test. Right? The timing of the test. The test should be done between day 12 to day 14 of the cycle. So it has to be done close to ovulation. The couple is asked to have intercourse, and then after a few hours, the woman reports to the laboratory. We take a sample of cervical mucus and then we examine it under microscope. Now what happens is actually the sperms in the cervical mucus, normally show progressive motility, right? Progressive motility means a forward motility. So they're always moving forward. That is what is called as progressive motility. But in case there are anti-sperm antibodies in the cervical mucus, these anti-sperm antibodies will coat the sperm as soon as the sperm is there, and in the presence of these antibodies, the sperms will no longer show progressive motility. In fact, they show a characteristic feature called as shaky motility. So they are just present at one place and they keep shaking. So there is no forward movement of these sperms, and thereby it tells us about the presence of anti-sperm antibodies. The other things which we can know from the postcoital test is we can also know about the cervical mucus, right? So we can know whether it is thin, it is thick, is it copious. So we can know about the cervical mucus. We can have some idea about the motility, right? And we can also have some idea about the sperm count. But please understand that for motility and sperm count, postcoital test is not the ideal test. The ideal test to know about motility and sperm count is the semen analysis. But yes, you can get a fair idea from the postcoital test itself. Now, the other tests, the names of which you should know and which are again done for presence of anti-sperm antibodies. Now, presence of anti-sperm antibodies is nothing but immunological infertility. So these antibodies can be present in the cervical mucus, or these antibodies can itself be present in the semen of the male, right? So whenever there are autoantibodies or antibodies in the cervical mucus, we call it as an immunological infertility. And so one test that I've told you about the immunological infertility is the postcoital test. The second test, the name of which you should know, is called as the Miller-Kozrock test. Just the names that are important. We take a slide, we take a sample of the cervical mucus from the female, we take semen from the male, and we put a drop of semen here, and then we say how well is the sperm able to penetrate the cervical mucus. Again, the same thing will happen if there are anti-sperm antibodies. The sperm is going to show shaky motility as soon as it comes in contact with the cervical mucus. The other tests that you should be knowing are called as immunobead test. So these are again tests to detect anti-sperm antibodies. They are called as sperm immobilization test, the sperm agglutination test. So sperm immobilization, sperm agglutination, immunobead, Miller-Kussrow, postcoital, and finally we can do the immunoglobulin assay. So these all names might be asked to you. Another thing which is important is, in case you are asked what is the most common cause of an abnormal postcoital test, yes, what will be the most common cause of an abnormal postcoital test, then the answer is wrong timing, right? The reason is that if you don't do it between day 12 and day 14 of the cycle and you do it a little later than that, then we anyways know that after the progesterone is going to come, the cervical mucus becomes thick, it becomes impermeable to sperms. So you would see that there is no forward motility and you would say there is immunological infertility, but the cause of the test is an abnormal cervical mucus itself. So wrong timing is the most common cause of an abnormal postcoital test. Now another thing which we should know is that although I am telling you that there is something like an immunological infertility or cervical factor infertility, but the problem here is that nowadays we don't do any such test. We are not doing any test practically to look for cervical factor infertility or the immunological infertility. The reason being that even if we find that, oh, there are anti-sperm antibodies, we do not have any treatment for these antibodies. Earlier on it was said that a course of steroids can help in these patients, but all those studies have been refuted. There is no role. So we don't have a treatment for the presence of anti-sperm antibodies. Simply because we don't have a treatment, why to look for them? So even if you look for them and you tell the patient that, look, you have anti-sperm antibodies and that's the cause of your infertility, and then you say, but we don't have any treatment for it, right? So we don't look for these tests or the presence of cervical factor infertility. In fact, since we do not have any treatment, what do we want to do is we want to bypass the cervix completely. Right? Just for example, if you're coming for my class and then you see that the road is jammed, right? What do? You say, I'll take another road. So you're trying to bypass the normal route, take a route which is shorter, maybe easier, or reaches the destination quickly, right? So since we don't have any treatment, so you would not actually get down from your car and tell all the vehicles go this way and go this way. You yourself are going to change your route, and that is what exactly we do. So we bypass the cervix, and this bypassing the cervix is called as IUI or intrauterine insemination. Now intrauterine insemination, what we do is we take a sample from the husband's semen, we process the sample, so we improve the quality of the sample. During this processing, the anti-sperm antibodies would also be washed away if they are present in the semen itself. Once you process and concentrate the semen, then there are catheters. We use catheter to inject this semen directly into the uterine cavity, right? So we are completely bypassing the cervix, and it really doesn't matter to us if there is anti-sperm antibodies in the cervical mucus. So we put the catheter in the uterine cavity and directly inject the semen inside the uterus close to the fallopian tubes, right? So IUI is the treatment of immunological infertility or cervical factor infertility or anti-sperm antibodies. The amount of semen that is injected is 0.5 to 1 ml. Right, so the amount of semen that is injected is 0.5 to 1 ml. Usually we take 1 ml of semen and 4 ml of a diluent, and then we put it into the uterine cavity, right? So the amount of semen used for this purpose is 0.5 to 1 ml. So this is about cervical factor infertility. Next we talk about another thing which is important, and that is uterine factor infertility, right? So the next thing we talk about is uterine factor infertility. Now, when you talk about uterine factor infertility, as I said, there can be many causes. The causes could be endometritis. The cause could be tuberculosis, endometrium. The cause can be a fibroid in the endometrium or in the uterus. The cause can be again exposure to a drug like DES, right? Then the cause could be congenital anomalies. So what I'm going to talk about here is congenital anomalies of the uterus or the Mullerian anomalies. Again, one of important topics being asked nowadays. Now, when you talk about Mullerian anomalies, there is a classification system which is given by ASRM. ASRM stands for American Society of Reproductive Medicine, right? So, according to this ASRM classification, we divide the Mullerian anomalies into 7 types. So, we have type 1, type 2, 3, 4, 5, 6 and 7. So, type 1 is called as segmental agenesis. Type 1 is segmental agenesis. Type 2 is unicornuate. Type 3 is uterine didelphius. Type 4 is bicornuate. Type 5 is septate. Type 6 arcuate. And type 7, the one which is occurring due to exposure to DES. So type 1 segmental agenesis, unicornuate is 2, didelphius is 3, bicornuate 4, septate 5, arcuate 6 and DES is 7. So this is as per the ASRM society. Now you get a lot of questions, so I'll take up the questions one by one and then as well clear the doubts that pertain to this topic. Now once you talk about Mullerian anomalies, which is the most common? So can you all type this for me? Which is the most common Mullerian anomaly among all? Which is the most common Mullerian anomaly? Anybody? Type 1, type 4. No. So the sequence here does not tell us the order, right? So this is simply not the order or the sequence. This is just an order given by the ASRM society, and the most common Mullerian anomaly is bicornuate. Now till last year or even few months back, we had a consensus on the answer as septate, and we have changed the answer from septate to bicornuate now. The reason is because the latest Williams as well as Williams gynecology both give bicornuate as the most common Mullerian anomaly, whereas we don't have any reference for septate uterus. Those are all the internet sites which tell us that it's septate, but if you read them in detail, then there is something more to that. So the most common Mullerian anomaly is bicornuate as per the latest Williams, both obstetrics and gynecology, right? So this is what we're going to stick to now because we have a reference. So in case we get a question where we can put a reference, then this is the reference. We don't have any reference for septate. As far as Novak's is concerned, it doesn't mention about the percentage of anomalies at all. So there is no mention about the percentage, right? So we're going to stick with bicornuate as the most common anomaly. On the other hand, if they ask you most common Mullerian anomaly, so if they ask you most common Mullerian anomaly to cause abortions, most common Mullerian anomaly associated with abortions. Now what is the answer? Quickly. Right. So Mysore is right. Please read the question very carefully. If it says most common anomaly to be associated with abortions, then the answer is septate uterus. Fibroid is not a Mullerian anomaly. right? So septate uterus is the one which is associated with abortions. Most common Mullerian anomaly to be associated with infertility. So if we see the infertile couples, then which one is the commonest? The answer here again changes and it becomes unicornuate. The most common Mullerian anomaly, very good Mysore, yes, to be associated in infertility is unicornuate uterus. Again, a newer question, which is the most common Mullerian anomaly? Which has most obstetric complications. So obstetric complications are maximum with which type of Mullerian anomaly? Obstetric complications are maximum with which type of Mullerian anomaly? The answer again is unicornuate. Then another fact is that all Mullerian anomalies have a close association with urinary tract anomalies. And urinary tract anomalies can be seen in 25 to 30% of cases of Mullerian anomalies. So the incidence of urinary tract anomalies in patients with Mullerian anomalies is 25 to 30%. Therefore, all patients of Mullerian anomalies must undergo either a renal scan, or IVP. So either of the two is mandatory in any patient with Mullerian anomaly. Either you go ahead and do a renal ultrasound or you do an IVP, right? Again, a single line of question is, which Mullerian anomaly has highest association with urinary anomalies or urinary tract anomalies? And again, the answer is unicornuate, where the association of urinary anomalies is as high as 40 to 50%. So which anomaly has highest association of urinary tract anomalies? It is unicornuate, which may be as high as 40 to 50%. Then you got another question in AIPG 2014. What was the question? The question said, which Mullerian anomaly is associated with ectopic ovary? Which Mullerian anomaly? So anybody can write down the name of the anomaly. Which Mullerian anomaly is associated with ectopic ovary? As I am saying, this is a question of this year AIPG 2014. So anybody knows the answer? No, the answer is not didelphys. The answer is again unicornuate. The answer is again a unicornuate uterus. Another question, which anomaly has best reproductive outcome? Which anomaly has best reproductive outcome? Then for this, we follow the order as the best outcome is with arcuate, followed by didelphys, followed by bicornuate. So the best reproductive outcomes are seen with arcuate uterus, yes Mysore, you're right, or followed by didelphys, followed by bicornuate. So we say their reproductive outcomes are very similar to that of women with no Mullerian anomalies, right? So if they ask another question, for which anomaly we do not do a surgery? For which anomaly we do not do, usually we do not do a corrective surgery. For which anomaly we usually do not do a corrective surgery? Yes, exactly. The answer is again going to remain the same. So the best answer is arcuate, followed by didelphius, followed by bicornuate. Right? Now, we usually don't require it, but patients with didelphius uterus and bicornuate uterus may have history of recurrent preterm labor. Right? So they may have history of recurrent preterm labor, and then if required we can do a surgery. So I'm saying mostly we do not require a surgery because their outcome is as good as a normal female. But in case we have to do a surgery, then we can do unification surgery. Then we can do a unification surgery which is called as a Strassmann metroplasty. So a Strassmann metroplasty is a unification surgery. It may be done for didelphius, it may be done for bicornuate if required. Usually it is not required, right? What is the treatment for septate uterus? So for septate uterus, the surgery which we do nowadays is called as hysteroscopic resection of the septum. So nowadays we do hysteroscopic resection of the septum. It is a good surgery with a good success rate of 80 to 90%, right? So we introduce a hysteroscope and start cutting the septum. That's what we do. Another thing is, before hysteroscopic resection came into being, we were doing an open surgery for even septate uterus, and then the name of that surgery was Tompkins. So Tompkins was a surgery which was done for septate uterus long time back. It was an open surgery. But as I am saying, nowadays we don't do Tompkins for hysteroscopic resection. What we do is, for septate, what we do is now a hysteroscopic resection of the septum. Why am I telling you these names? Because there is a question and you're going to tell me an answer for this question. So all our surgeries for Mullerian anomalies except, right? So option A is Strassmann, option B Tompkins, option C McIndoe, and option D hysteroscopic resection. So what is the answer for this question? Yes. And now because we know what all others are used for, can you tell me what is McIndoe's surgery? Where do we do a McIndoe's surgery? We just did discuss it yesterday, but I think I did not tell you the name. So can you tell me for what is McIndoe's surgery used? Very good. Yes. So you are correct. It is a surgery which is done for, or it is the name of the surgery done for vaginoplasty. So it is a type of vaginoplasty. So McIndoe is a type of vaginoplasty where we increase the available space in the vagina for a female. Karamsa, that is not for prolapse, it is a surgery for vaginoplasty, right? Okay, now I ask you, what is the investigation of choice for Mullerian anomalies? So what is the answer? What is the investigation of choice for Mullerian anomalies? HSG, ultrasound, HSG again. Beaconair says MRI. Anybody else? You want to type in your answers? Hysteroscopy, again HSG, again hysteroscopy. So only one correct answer today, and that's Beaconair. The answer is MRI. The investigation of choice for Mullerian anomalies is MRI. Now please understand, HSG is only a screening tool and it is usually never done for uterine anomalies. We are actually doing it for tubal anomalies, and then when you did it for the tubal factor, you find a coincidental presence of a uterine anomaly. Hysteroscopy only tells you that there is an anomaly or there may be a uterine anomaly, but it can never tell you which anomaly is it, right? So it only tells you that there may be a uterine anomaly. So it is not the investigation of choice. What happens, as I have told you, is usually we are doing HSG much more commonly, and we do it for tubal factor, and then we find a coincidental Mullerian anomaly. Now the second things that you've been writing is hysteroscopy. Now please understand, hysteroscopy is never the investigation of choice. You should not mark it. It's an invasive method. I'll give you a better answer or a reasoning for that just a few minutes from now, but it is never an investigation of choice. Most of the times, investigation of choice are those investigations which are non-invasive and still help you make a diagnosis, right? So hysteroscopy is not an answer. Then some of you are writing ultrasound. Now please understand, the single 2D ultrasounds or the simple ultrasounds that are available in majority of places are not good for Mullerian anomalies. The only ultrasounds which can help us to tell what type of an anomaly is it can only be a 3D or the 4D ultrasound. A routinely available 2D ultrasound cannot pick up Mullerian anomalies, right? It cannot pick up Mullerian anomalies that well. So the order. So I said that the investigation of choice for Mullerian, I'm going to write down these things again so that we don't have any confusions at all, right? So investigation of choice for Mullerian anomalies is MRI. Gold standard investigation is always laparoscopy for Mullerian. So there would be things which you will not be able to pick up even on MRI, and then the only thing you can do is a laparoscopy, right? So gold standard investigation is laparoscopy. Investigation of choice is MRI. Now I want to ask you, how will you differentiate a septate uterus from a bicornuate uterus? Now usually how I ask this question is, what is the differential diagnosis of septate on HSG? What is the differential diagnosis of a septate uterus on HSG? And the answer is bicornuate. So please understand, HSG is an investigation which will actually tell you कि या तो ये bicornuate है या फिर ये septate है. So it is the one which raises the suspicion. It never differentiates between the two. Can hysteroscopy differentiate? Again, the answer is no. Hysteroscopy cannot differentiate between a bicornuate and a septate. The only thing which can differentiate a bicornuate from a septate uterus is something by which we can do or see the fundus of the uterus, as correctly mentioned by Mysore. So the only way to differentiate the two is when we can see the fundus of the uterus, right? Why do you want to do invasive investigation, Ludhiana? Why do we want to go ahead with laparoscopy when you can easily do an MRI to differentiate between the two? Now in MRI, the points that we see are the dip in the fundus is more than 1 centimeters in a bicornuate uterus, and the tubal cornu are more than 4 centimeters apart. So the two findings which we can easily look on MRI is the dip in the fundus. It has to be more than 1 centimeter deep, which is suggestive of bicornuate, and the distance between the two tubal cornus, if it is more than 4 centimeters, again it indicates us a bicornuate uterus. So the things which can differentiate, again I am saying MRI, laparoscopy, a 3D and a 4D ultrasound. A plain ultrasound cannot differentiate, right? So neither the answer is HSG, nor it is ultrasound, nor it is hysteroscopy. The answer is going to be either MRI. If MRI is not in the options, then the next best answer is laparoscopy, or if a 3D, 4D ultrasound is in the options, then that will be placed before laparoscopy, since these are non-invasive investigations, right? Now, so many times in today's class and yesterday's class, did I use the term as DES, right? Diethyl stilbestrol use. Now, what are the problems which we see with the exposure to diethylstilbestrol? Now, in the vagina, exposure to DES leads to vaginal adenosis. It leads to vaginal adenosis. It leads to clear cell cancer of the vagina. At the level of cervix, it can cause adenocarcinoma. It can cause cervical intraepithelial neoplasia, SIN lesions. It can also cause something which are called as cervical collars, so a collar or a hood. So these are again congenital anomalies of the anatomy, cervical collar or a cervical hood, HOOD. And when you talk about uterus, the classic appearance of uterus with exposure to diethylstilbestrol is called as a T-shaped uterus. So it produces a T-shaped uterus. And if you talk about males, then DES exposure in the males causes testicular hypoplasia. It causes testicular hypoplasia. It can cause hypospadias, which I did mention yesterday when we were talking about clomiphene citrate, and it can also cause cryptorchidism. Right? So cryptorchidism. So these are all the things which can be seen on exposure to diethylstilbestrol. So this is about the cervical factor infertility and the uterine factor infertility. And the next thing we talk about is going to be male factor infertility, right? So it's going to be the male factor infertility. Now luckily we don't have to do much in that. There are certain standard questions which are asked in male factor infertility, and they usually pertain to the WHO parameters. So when you talk about the male factor infertility, the most important test for us is getting the husband's semen analysis. So HSA is the most important test. Before I go to the parameters of HSA, certain things which were asked last year in the NEET exam. What were those questions? The questions were, what is the average liquefaction time of the semen? And it is 20 minutes. So the average liquefaction time is 20 minutes. Ideally, semen analysis should be done on a liquefied semen, right? And the maximum time period we wait for liquefaction can be 60 minutes. The maximum time period for which we can wait for liquefaction to occur is 60 minutes. If after 60 minutes there is no liquefaction, then we would do on the semen analysis on a non-liquefied semen, right? So the maximum time we wait is 60 minutes. Then what is the speed of sperm motility? What is the speed of sperm motility in the female genital tract? And it is 3 millimeters per hour. It is 3 millimeters per hour. What is the ideal method of obtaining semen? For obtaining semen for HSA? And the answer is by masturbation. The next what we talk about are WHO parameters for semen analysis. Now these have lately been changed by WHO in 2010-2011. They've not been updated in your books, but that does not mean that you don't have to know them. These are what are going to be asked since these are changed very recently, right? So when you talk about WHO parameters, volume of the semen should be more than 1.5 ml. pH should be more than 7.2. Total sperm count total sperm count should be more than 39 million per ejaculate. Sperm concentration should be more than 15 million per ml. Earlier this was 20 ml, now it has been changed to 15 million per ml. Sperm motility and total. So total sperm motility should be 40%. Total sperm motility should be 40%, whereas progressive motility, what we just talked about, progressive motility should be more than 32%. Sperm morphology. So normal morphology should be more than 4%. Normal sperm morphology should be more than 4%. Then WBC count. The WBC count should be less than 1 million per ml. So these are the parameters. Based on these parameters, we have certain terminologies. For example, the terminologies used are, what is aspermia? So aspermia means no ejaculate or no semen. That is aspermia. Azoospermia means no sperms in the ejaculate. So no sperms in the semen is azoospermia. Teratospermia is abnormal morphology. Asthenospermia is abnormal motility. Necrospermia is the presence of dead sperms. Oligospermia would be counts less than 15 million per ml. Severe oligospermia is counts less than 5 million per ml. So this is severe oligospermia. Then globospermia. By globospermia, it means rounded heads. So sperms with rounded heads because of the absence of acrosomal cap. And then can they fertilize the ovum? Can such a sperm fertilize the ovum? A globospermia sperm. So the answer is no, yes, because it lacks the acrosomal cap. It cannot bring about the process of fertilization, right? Now, if you talk about two things, that is non-motile sperms and dead sperms. So if we see non-motile sperms and dead sperms, what will happen is both these types of sperms will be present only at one place. So both of them would not be moving. Then how do we differentiate a non-motile sperm from a dead sperm, right? How do we differentiate a non-motile sperm from the dead sperm? The answer is hypoosmotic swelling test. Hypoosmotic swelling test. इसमें क्या होगा? The non-motile sperms, but which ones are alive? The non-motile ones will swell up, whereas the dead sperms will not swell up. So the non-motile sperms would swell up, whereas the dead sperms, it is terato, it is not kerato, Karam sir, terato, T. I don't think this appears like a K. Teratospermia is abnormal morphology. Now, Belgaum, okay, I'm giving the values for you. Quickly write it down. Volume should be more than 1.5 ml. pH should be more than 7.2. Total sperm count should be more than 39 million. Sperm concentration more than 15 million per ml. Total motility should be more than 40%. Forward motility or progressive motility 32%. Normal morphology 4%. And WBC count less than 1 million per ml. Right? So these are the values. The other important thing that we need to know here is, how do we work upon a case of azoospermia, right? So if there is a case of azoospermia, then this is what we do. Now once there is azoospermia, we want to look for semen fructose. So this is the algorithm for this. We look for semen fructose. Semen fructose could be present or semen fructose can be absent. If semen fructose is present, then the cause is obstruction of epididymis. So obstruction to the duct of epididymis is the cause if semen fructose is present and there is azoospermia. If semen fructose is absent, the next test we do is serum LH, FSH and testosterone. If the testosterone levels are normal and so is FSH level, so if the FSH and testosterone are normal, then the reason is obstruction of the vas deferens. Obstruction of the vas deferens. And the test here we do is called as TRUS, a transrectal ultrasound. So when there is obstruction at the level of vas deferens and we do a transrectal ultrasound, what are we going to see? We are going to see dilated seminal vesicles. We are going to see dilated seminal vesicles. On the other hand, if FSH is high, so on the other hand, I'm saying if FSH is high and testosterone is low, then the defect lies at the level of testes, right? So there is defective spermatogenesis, which is the problem here. Since when the testosterone and FSH were normal, the cause was obstruction of the vas deferens, we call this obstructive azoospermia. And similarly, when the cause is at the level of testes and in spermatogenesis, we call it a non-obstructive azoospermia. Right? Now, depending on whether it is obstructive azoospermia or non-obstructive azoospermia, we have different treatment modalities. So, if it is obstructive azoospermia, then the treatment is surgery, right? So we are going to do a resection anastomosis to remove the obstruction and form the vas deferens duct again. So the answer to this is surgery. Whereas if it is non-obstructive azoospermia, the process we do is TISA or TC, where TISA stands for testicular sperm aspiration and TC stands for testicular sperm extraction. The idea is that the spermatogenesis is defective, so there are going to be very few sperms that are produced, and therefore in the semen it is going to be an azoospermia. But when you take a sample directly from the testes, you may be able to get 1, 2, 3 or 4 sperms. Normally they are produced in millions of numbers, right? So when you take a biopsy or do a TISA or a TESI from the, you do a TISA and a TC from the testes, then we may or we do get some sperms. The problem is that once you do a TISA and a TC, these sperms are non-motile, right? Because the motility is achieved in the epididymis. So these sperms are non-motile, and if these sperms are non-motile, then the next procedure we do for them is a special technique of IVF called as ICSI. It is called as ICSI. ICSI is intracytoplasmic sperm injection. ICSI is intracytoplasmic sperm injection. So we directly put the sperm inside the cytoplasm of the ovum. So that is ICSI. So therefore the treatment of non-obstructive azoospermia is TISA or TC plus ICSI, right? Intracytoplasmic sperm injection, right? So this was about the male factor infertility. Now when you talk about the male factor infertility, we can divide the male factor infertility into mild to moderate male factor infertility and severe male factor infertility. The initial treatment for mild to moderate male factor infertility, again the answer is IUI. Because as I said that before we actually do the insemination procedure, we are going to take the semen analysis sample, we are going to concentrate and we are going to purify the semen, and then we inject it. So for mild to moderate male factor infertility, it is IUI, whereas for severe male factor infertility, the answer again is IVF. So for severe male factor infertility, the answer again is IVF. Now besides this, there is an entity called as unexplained infertility. There is an entity called as unexplained infertility. Now when you talk about unexplained infertility, it means that you have evaluated both the partners, the male and the female, right? You've evaluated both the partners, the male and the female, and we could not find any problem with either the male factor or the female factor. So we could not find any problem with either the male factor or the female factor, and therefore it is called as an unexplained infertility. Now when you talk about unexplained infertility, what should be the treatment for this unexplained infertility? The treatment for unexplained infertility is superovulation with clomiphene citrate, superovulation with clomiphene citrate along with IUI for 3 cycles. So the initial treatment of unexplained infertility is going to be superovulation for 3 cycles and IUI. Now here we don't use the term ovulation induction simply because the female is herself also ovulating. But in order to increase her chances of pregnancy, we are increasing the number of ova that are being formed in one cycle. Hence we use the term as superovulation. So it is superovulation with clomiphene citrate along with intrauterine insemination for 3 cycles. If this fails, then the next treatment is IVF. If this fails, then the next treatment is IVF. Also, if you talk about male factor infertility, other than IUI and IVF, can we give certain drugs to the males? So the answer is yes. We can give certain drugs to the patient as well. So when you talk about male factor infertility, then There have been studies which have seen the use of clomiphene citrate, gonadotropins, and even GnRH agonists. So they have been when you talk about male factor infertility, I am saying there have been certain drugs which have been tried in the males to increase the number of sperms. These drugs which have been used in males to increase the sperm content or the sperm number or the sperm concentration are GnRH agonists, clomiphene citrate, GnRH agonists, clomiphene citrate, and even gonadotropins. So talking again, I was talking about drugs which can be given, right? Drugs which can be given for male factor infertility. These drugs are GnRH agonists, clomiphene citrate, and again gonadotropins. So all these drugs have been tried. All these drugs have been tried, but they may not be Hold on, we're trying to correct the notepad. Please have patience. Alright, yes, so the drugs which can be given for male factor infertility, GnRH agonist, clomiphene citrate and gonadotropins, they've all been tried, but none of this have been seen to be very, very effective. But yes, if you ask me whether they can be given to improve the sperm number and or the count of the sperms, right? No, they're not different. We use the same drugs. See, as far as clomiphene citrate is concerned, what you have to remember is that the starting dose for ovulation induction is 50 milligrams, or when given to the sperms is 50 milligrams, and the maximum approved dose by FDA, the maximum approved dose is 100 milligrams, and the maximum approved time for by FDA is 12 months. So at max it can be given for 12 months, and the maximum daily dose can be 100 milligrams as approved by the FDA, right? Now when you talk about infertility, there is something that we cannot leave behind, and that is endometriosis, right? Now endometriosis is nothing but presence of endometrial glands and stroma outside the uterus. Presence of endometrial glands and stroma outside the uterus is called as endometriosis. The most common site of endometriosis is ovary, followed by the pouch of Douglas, followed by uterosacral ligaments, followed by fallopian tubes, right? So ovaries, POD, uterosacral ligaments and the fallopian tubes. Now what is important is that there is the growth of these endometrial implants. The growth of these endometrial implants is dependent on Ludhiana, you'll have to go back and read the process of spermatogenesis for this. I said semen fructose, if it is present, then the cause is post-epididymis. If semen fructose is absent, then the cause is prior to the level of epididymis. Prior to the level of epididymis, it can be obstruction of the vasa deferens, or it can be the testes itself, right? So that is why that is the first test we do. Now, what I am saying is that the growth of these endometrial implants is dependent upon ovarian steroids. It is dependent on ovarian steroids, and therefore we say that endometriosis is most common in reproductive age group. It is rare, it may be seen, but it is rare in adolescent. It is rare in adolescent and post-menopausal women. The most common theory which explains the process of endometriosis and which has been widely accepted is retrograde menstruation. It is retrograde menstruation, and this is called as the Sampson's theory. This is called as the Sampson's theory. The second common theory which has been accepted is the theory of coelomic metaplasia. This theory of coelomic metaplasia, that it says that there are undifferentiated cells that undergo metaplasia and convert into the endometrial type of cells, right? So coelomic metaplasia theory. There are certain immune theories as well. There is genetic theory. Now, as per the genetic theory, we have seen that the gene which is involved, in endometriosis. Can anybody tell me which is the gene? Again, this is your AIPG latest MCQ. Which gene is involved in the process of endometriosis? Anybody? The answer to this question is KRAS. So the gene which has been seen to be involved with endometriosis is KRAS, and it is seen that the risk of endometriosis, so I'm still talking about the genetic theory. So the gene which has been involved is KRAS, and then I'm saying that the risk of endometriosis is 7 times higher if a first degree relative is affected. And this genetic theory says that the inheritance is multifactorial, right? So they say that the inheritance is multifactorial. Other than these four, the other theories are a theory of lymphatic and vascular spread, although it has not been accepted. Theory of lymphatic and vascular spread, and finally an induction theory. The induction theory says that there are certain hormones and other mediators which induce endometrial cells outside. Right? Which induce the endometrial cells outside. So that is the induction theory. But as I told you, the most commonly accepted theory is retrograde menstruation or Sampson's, and the second one which is accepted is the coelomic metaplasia theory. Right? Now if you talk about endometriosis, what is the symptoms, or what are the symptoms? The most common symptom of endometriosis is pain. Now that is a very, very safe answer, but there is more to this question. Yes, so the answer is pain in general. Now when you talk about pain, then which type is the most common pain? The most common type is a chronic pelvic pain. So the best answer is a chronic pelvic pain, not even a cyclic pain. So the best answer is chronic pelvic pain. The second answer is dysmenorrhea. So the second type of common pain is dysmenorrhea. The third type of pain is deep dyspareunia, which means painful coitus. Deep dyspareunia or painful coitus. Other than pain, the patients with endometriosis present with infertility. Then they can also present with abnormal uterine bleeding. And the least common presentation is a low back pain. So the most common is chronic pelvic pain, dysmenorrhea, then deep dyspareunia, infertility, abnormal uterine bleeding, and a low back pain. If you talk about these signs, then most often what we find is pouch of Douglas tenderness. So there is tenderness in the pouch of Douglas. Second, there are tender, thick uterosacral ligaments. There are tender and thick uterosacral ligaments. We can even feel nodularity on the uterosacral ligaments. We can also feel nodularity on the uterosacral ligaments. Then the next sign is uterine tenderness. Uterine tenderness. So pouch of Douglas tenderness, tender thick uterosacral ligaments, nodules on the uterosacral ligament, uterine tenderness. Then the next finding can be a retroverted fixed uterus. A retroverted fixed uterus. And still another finding could be adnexal mass. And still other finding can be adnexal mass. Agro is asking me, can it lead to ectopic pregnancy? Yes, it can lead to ectopic. Anything which hampers the anatomy in the pelvis can lead to ectopic, right? Now the gold standard investigation to diagnose endometriosis is laparoscopy. The gold standard investigation to diagnose endometriosis is laparoscopy. Right? So you take a biopsy and you send it for histopathology, and what you're going to find is endometrial glands and stroma. So laparoscopy is the gold standard investigation. CA 125 is also raised, and CA 125 is more raised in endometriosis as compared to genital TB. In genital TB it is minimally raised, but it will be raised. In endometriosis the levels can be quite high, to the extent that CA 125 may be more than 100. It may be even more than 100 with an endometrioma. Right? So it may be more than 100 if there is an endometrioma in the ovary. Now, can you tell me what happens to endometriosis in pregnancy? So does it worsen, does it improve, or there is no change? Can you tell me what happens to endometriosis in pregnancy? Anybody? Improves. Yes, that's the correct answer. So it undergoes regression, and the reason is decidualization. So there is decidualization of these implants and there is regression of the disease. It does not increase, there is regression of the disease. Now again, as far as endometriosis is concerned, again we have a classification given by ASRM, which is the American Society of Reproductive Medicine, and the classification says that it can be minimal endometriosis. Now, minimal endometriosis means there are isolated implants. There are isolated implants, but there are no adhesions. So, there are isolated implants, but no adhesions. Mild endometriosis means there are superficial implants. There are superficial implants which are less than 5 centimeters in aggregate. So they are less than 5 centimeters in aggregate, but again there will be no adhesions. So there are superficial implants, the size increases, but they are still less than 5 centimeters in aggregate. Moderate endometriosis is when there are multiple implants, both deep and superficial. So these implants are both deep and superficial, and along with these implants there is presence of adhesions. So now in moderate endometriosis even adhesions come up. So mild, when there are isolated implants, no adhesions, or minimal. Mild, when there are superficial implants which are less than 5 centimeters in aggregate. Moderate, when there are both superficial and deep implants along with adhesions. And finally severe endometriosis, which means multiple implants. Severe means multiple implants along with adhesions. Multiple implants along with adhesions. Along with an endometrioma of the ovary. Along with an endometrioma of the ovary. Now, if you talk about an endometrioma of the ovary, what are the characteristic features of endometriotic cyst? What are the features of endometriotic cyst? So, the first thing is that the endometriotic cysts are less than 12 centimeters in size. Number 2, this endometriotic cyst is adhered to pelvic side wall. So it is adhered to the pelvic side wall or to the broad ligament. So if you look at laterally, it would be adhered either to the pelvic side wall, medially to the broad ligament. Then the endometrioma, it is on the surface of the ovary. So it is present on the surface of the ovary, or it occupies the position of the ovary. And the last point is that it has a tarry chocolate colored fluid. It has a tarry chocolate colored fluid, and that is why it is also called as a chocolate cyst of the ovary. It is also called as the chocolate cyst of the ovary. Now this is what is minimal, mild, moderate and severe endometriosis. Coming to what is the treatment of endometriosis. Now the treatment of endometriosis, we'll come to it, hold on. Now another thing is that I said that the most important symptom or the most common symptom of endometriosis is going to be pain, right? Now the severity of the pain is dependent on what? The severity of pain is dependent on the depth of the adhesion or the implant. Deeper the implant, more is going to be the pain. So it is dependent on the depth of the implant. Now if you talk about treatment of endometriosis, the treatment would depend upon the presentation. So the first thing we said is pain. So what is the treatment of pain? Now first we talk about the medical management of pain. Now if you talk about the medical management of pain, then again we divide it into whether it is minimal or mild or moderate to severe. So if there is minimal to mild pain or minimal to mild endometriosis, then the drug of choice can either be NSAIDs, non-steroidal anti-inflammatory drugs, or it can be combined oral contraceptive pills. Which one to give? If the cycles are regular, we preferably start the patient with NSAIDs, whereas if the cycles are irregular, we start them on combined oral contraceptive pills, right? If you talk about moderate to severe endometriosis, then the drug of choice for this is GnRH agonists. Now please remember that the GnRH agonists, they relieve pain and they will also reduce the size of the implant, right? So they also reduce the size of the implant. We have talked about the routes that the GnRH can be given via. But important point here is that here the GnRH agonist is not given in a pulsatile manner, it is given continuously. So here they are given continuously because we want to cause suppression of the ovaries. So therefore we give it continuously. The second line drugs which are equally effective are progestrogens. As we say that these progestrogens cause decidualization of the implants and therefore they are helpful. The progestrogens can be used in any form. So they can be oral, it can be injectable, it can be intrauterine, right? So in any form you can give these progestrogens. Then the other drugs that are given are aromatase inhibitors. Aromatase inhibitors can also be given. And finally, danazol can also be given. Now, a lot of your guidebooks still give the drug of choice as danazol, which is wrong. Danazol was given earlier on when the effects of GnRH and all were not discovered. Nowadays, we don't use danazol at all because the dose at which it will cause suppression is quite high, and at that doses it has severe androgenic side effects. So danazol is not given as a first line drug. In fact, it is still effective, but it is one of the last line drugs. When none of the other drugs are effective, you may use danazol to cause regression of these implants. Talking about the surgical management of pain, talking about the surgical management of pain. Now, what are the conditions in which you are going to do surgical management, right, and not do medical management? Number one, if the symptoms of the patient are severe, they are severely incapacitating. So if the symptoms are severely incapacitating, what we need is a surgical management and not medical management. Second indication, symptoms that are not responding to medical management. So symptoms that are not responding to medical management. And third we say is an advanced disease. And how do we describe an advanced disease or advanced endometriosis? Is any disease that causes anatomical distortion. So anatomical distortion is one criteria. Presence of endometriotic cyst is another criteria. And bowel and bladder obstruction is definitely an indication for surgical management. Bladder and bowel involvement are indications for surgical management and not medical management. Now, Jammu is writing endometrial fertility index. What do you mean by that? We don't use that term in our practice at all. In fact, none of the textbooks would give anything like an endometrial fertility index. So what exactly are you wanting to ask me? You'll have to ask me that. So till they type what they want to ask, I'll go ahead. So this was the surgical management of pain. Coming to the management of a cyst or a mass. That is the chocolate cyst of the ovary. The scoring system is same that we are using in ASRM, right? So the scoring system is same as minimal, mild, moderate and severe. And the various sites are given different scores, and depending on that you categorize the patient as minimal, mild, moderate or severe. You don't need to go into the details that what positions would be given a severe score or what positions are given a mild score. The criteria I have told you is dependent on the implants, whether there are superficial implants or deep implants. The first thing is that what we see. The second thing we see is if there are implants, how many, are they multiple or isolated? The third thing you see is whether there is presence of adhesions or not. And the last thing you see is distortion of anatomy, which is presence of cyst or presence of distortion of other anatomy in the sites. It may be bowel, it may be bladder, it may be any surrounding structure, right? Now when you talk about a cyst or a mass or a chocolate cyst of the ovary, then the only or the ideal management or the best management, as you want to put it, is a cystectomy. Because it is seen that any other management of the endometriotic cysts other than cystectomy has a high recurrence rate, right? In fact, if you are asked what is the recurrence rate of endometriotic cyst, the recurrence rate varies between 5 to 20% per year. The recurrence rate varies between 5 to 20% per year. There is another criteria on which people manage these endometriotic cysts. The best thing is cystectomy, but some of them do say that if the cyst is less than 3 centimeters, we can do with aspiration. But if it is more than 3 centimeters, it definitely needs cystectomy, right? Apart from this, in general, please remember, if they ask you what is the best or the ideal treatment, then it is a cystectomy for the mass, right? So it is neither in suction or aspiration, it is neither laser destruction, it is cystectomy, for the simple reason that I said that the recurrence rate with other procedures is very high. Talking about the third problem in these patients, and that is infertility, right? Okay, so talking about infertility, again, as we say that if the treatment or if the endometriosis is minimal to mild, so you would always, what surgery is done for pain? Surgery is simple. If it is a endometriotic cyst, do a cystectomy. If there are adhesions, do adhesiolysis. If there are implants, destroy the implants either by laser or by cautery, right? So if there are implants, we destroy the implants. If there are adhesions, we cut the adhesions. If it is a cyst, we would remove the cyst, right? So these are specific surgeries that we do. Non-specific would be do a hysterectomy, right? Or do a presacral neurectomy, right? Which is destroy the nerves which are carrying the pain fibers. Whereas specific is destroy the implants, cut the adhesions and remove the cyst, right? So if you talk about infertility and endometriosis, and again if the endometriosis is mild or minimal, then the treatment is clomiphene citrate plus IUI for again 3 cycles. Clomiphene citrate plus IUI is done for 3 cycles. Why? I'll come to your question, Agra. Just let me finish this part, okay? So I'm saying the treatment of minimal to mild endometriosis is clomiphene citrate along with IUI for 3 cycles. Whereas if it is moderate to severe endometriosis, then the treatment is IVF with or without a surgery. So you may club it with a surgical procedure, right, which may be any of the surgeries that we told you, or you just simply do an IVF and don't do a surgery. Now Agda is saying, why is there chocolate color cyst? You tell me. Now these are endometrium, right? Just like the endometrium in the uterus, endometrium outside also undergoes cyclical changes. It's undergoing to go bleeding, then resolution, then bleeding again. And blood in the various stages of its resolution takes different color patterns, and that is why this altered color gives a chocolate-like appearance to the cyst, and that is why it is the chocolate cyst of the ovary. If pain is due to collection of fluid in cul-de-sac, oh no, the fluid in the cul-de-sac doesn't cause pain, Karam said. Fluid in the cul-de-sac, I told you, can be present in so many conditions. Fluid in the cul-de-sac is not a feature of endometriosis. Feature of endometriosis in the pouch of Douglas is involvement of the uterosacral ligaments and formation of adhesions or nodularities on the ligaments. Fluid doesn't cause pain, right? What, or maybe you're trying to ask me is ruptured cyst. Is that what you're trying to ask me? So pain is never due to fluid collection. Fluid would be seen in a normal menstrual cycle at the time of ovulation, right? Fluid may be seen even with minimal PID. Fluid is not a feature of endometriosis, okay? Which hormone stabilizes the endometrium? Allahabad, come on. Now who's going to answer the question for Allahabad? Which hormone stabilizes endometrium? Now, your use of words is not correct, and that is why you're getting confused. Right? The endometrial protective activity. So there is something called as endometrial protection. The endometrial protection is given by progesterone, which is what we are going to do here. When you say stabilization, then it could mean anything. Stabilization could mean that the endometrium is bleeding and you want it to stop bleeding, then you can even give estrogen for that purpose, right? So the use of term is not correct. So you're not using a correct term. Endometrial protection is done by progesterone. That is what you should know, right? Okay, so this was infertility, or this was endometriosis and infertility. Now, just a few things about fibroid uterus, although I think most of you think that it's an easy topic and you know quite a lot about it. So I'm not going to go into too many details. Cancers associated. Alright, per se, I don't think there has been any cancer which has been attributed to endometriosis. The associated cancers could be ovarian, they could be endometrial cancers, because the pathology is same, that is, whatever cancers are estrogen dependent could be associated with endometriosis. But per se, endometriosis has not been the cause of any cancer. There may be associated endometrial cancer, or these patients may be prone to endometrial cancers, or maybe even ovarian cancers for that matter. So any cancer which is estrogen dependent, right? But I don't think any cancer has been particularly been attributed to endometriosis. Alright, yes, I think Shimla has a better opinion. Please ask questions at the end. What you can do is, you can keep writing down your questions on a small paper, right? And then at the end of the session or end of 2 hours or something like that, we'll give you time to, fire your questions at me, right? We can do that. So as I said, I'm not going to go into too many details of fibroids, but yes, there are certain questions which you all persistently end up doing wrong in an easy topic, which makes you lose, right? So when you talk about fibroid, what you have to know is that there are 3 types. I think you all are aware of that. There is a subserosal, there is intramural, and there is a submucosal fibroid. The intramural are the most common types of fibroids, whereas the submucosal are most symptomatic. So intramural are most common and submucosal are most symptomatic. What is the most common presentation of fibroids? Can anybody answer that question for me? What is the most common presentation of fibroids? The most common presentation is asymptomatic. So majority of fibroids are asymptomatic. No, majority of fibroids are asymptomatic. Yes, and it is only a coincidental finding that there is a fibroid in the uterus. The next common presentation is menorrhagia. Now, it is important for you to understand the kind of bleeding. The kind of bleeding we are saying is associated with fibroids is menorrhagia, which means the cycles are regular, but they are heavy. So, the cycles are regular, but they are heavy. So, that is menorrhagia. Now, another question I want to ask you, and you'll tell me, what is the most common presentation of fundal fibroids? If they are to produce symptoms, what is the most common symptom of fundal fibroid? Now, the most common symptom of fundal fibroid also remains menorrhagia. All right, it also remains menorrhagia, but a change in answer is when we ask you which fibroid is most commonly associated with inversion uterus, and then the answer is a fundal fibroid. So it is one of the most common fibroids to cause inversion, but the most common presentation of a fundal fibroid is still menorrhagia, right? Then if you talk about submucosal fibroids, they have been hysteroscopically called as three types: type 0, type 1 and type 2. A type 0 submucosal fibroid is one which lies completely intracavitary. So if it is completely intracavitary, it is type 0. Type 1 is which is more than 50% is intracavitary, and type 2 is more than 50% is intramural. So less than 50% is intracavitary, but more of it is now embedded in the myometrium, right? Only a part of it is going to be submucosal. Now the classification is important because the type 2 fibroids are hysteroscopically non-resectable. So type 2 fibroids are hysteroscopically non-resectable, right? Then we all know that a fibroid can cause pressure symptoms depending on what structure is it pressing on, right? So if you talk about the pressure symptoms, then the fibroid can be located in the anterior wall of the uterus or posterior wall. Which of these two causes urinary retention and which causes urinary frequency? So anybody? Give me the answer for which of the two, anterior or posterior, is more likely to cause urinary retention. So which causes retention of urine? Alright. Now, please understand that the posterior ones cause retention, whereas the anterior ones cause increased frequency of maturation. So, the anterior cause increased frequency of maturation, whereas the posterior ones cause retention. The reason is that the posterior fibroids, whether they are on the uterus or in the cervix, the posterior fibroids get lodged in the pouch of Douglas, and they push the rest of the entire uterus forwards, and when they do it, the uterus obstructs the bladder outflow and presents as urinary retention. whereas the anterior ones cause irritation of the bladder mucosa and they cause increased frequency of maturation. So increased frequency is anterior and retention is posterior, right? Then the other questions that you need to know are, which is the most common degeneration? The most common degeneration in a fibroid is a hyaline degeneration, and the least common is sarcomatous degeneration. And the latest reports say that the incidence of sarcomatous degeneration is less than 0.5%. It is less than 0.5%. So that is the sarcomatous degeneration. Then again, there is a term called as womb stone. So there are certain named terminologies with respect to fibroids. So what is womb stone? Womb stone is a calcified, pedunculated, subserosal fibroid. So a calcified, pedunculated, subserosal fibroid is called as a womb stone. Why? Because once you do an ultrasound or an x-ray, you see that there is something or a ball like something in the abdomen of the patient. So calcified, pedunculated, subserosal fibroid is called as a womb stone. Then there is something called as a true broad ligament fibroid and a false broad ligament fibroid. The usual question is that how do you differentiate a true broad ligament fibroid from a false broad ligament fibroid? So what you should know is first, what is a true fibroid and what is a false broad ligament fibroid, right? So a true broad ligament fibroid is one that arises de novo. It is one that arises de novo between two layers of broad ligament. Whereas a false broad ligament fibroid is actually a uterine fibroid which outgrows between the two layers of broad ligaments. Right? How do we differentiate? The two are differentiated by the position of the ureter. The two are differentiated by the position of the ureter. So ureter lies medial to the fibroid if it is a true broad ligament fibroid. So in a true broad ligament fibroid, the ureter lies medial to the fibroid, whereas in a false broad ligament fibroid, the ureter lies lateral to the fibroid. The ureter lies lateral to the fibroid. If you're still talking about the terminologies, there is something called as lantern on the dome of St. Paul's Cathedral. Now, I don't know who gave this term, but this is a term which is coined for central cervical fibroids. So it actually looks like a big cervix with a small uterus sitting on top of it. So lantern on the top of St. Paul's, on the dome of St. Paul's Cathedral is the term we use for central cervical fibroids, right? Now who's going to tell me what is the investigation of choice for a fibroid uterus? What is the investigation of choice for a fibroid uterus? Come on. Yes. So the investigation of choice for a fibroid uterus is ultrasound. That's easy. Now let's see who's going to tell me what is the ultrasound appearance of a fibroid. How does a fibroid appear on the ultrasound? Investigation of choice for a fibroid uterus is ultrasound. And my next question to you is, what is the ultrasound appearance of a fibroid? The ultrasound appearance of a fibroid is classically described as hypoechoic. It is classically described as hypoechoic, right? Another thing that you should know is, what is the differential diagnosis of a fibroid uterus? So the differential diagnosis of fibroid is adenomyosis. The differential diagnosis of a fibroid is adenomyosis. Now, a fibroid, as we know, appears due to smooth muscle proliferation. Yes? Adenomyosis is endometrium present in the myometrium. Now, when endometrium was present, or endometrial glands and stroma were present outside the uterus, we call it as endometriosis. When endometrial glands and stroma are present inside the myometrium, it is called as adenomyosis, right? Now, a fibroid uterus is irregular, and we say that a fibroid makes the surface of the uterus bumpy. So it is an irregular, bumpy uterus, whereas adenomyosis is a symmetrical growth of the uterus, or causes symmetrical growth of the uterus and produces a globular uterus. A fibroid uterus is non-tender to touch, whereas adenomyosis is tender to touch. A fibroid uterus has dysmenorrhea, no doubt, but it is not the chief complaint. So the main complaint of the patient with a fibroid uterus is menorrhagia. On the other hand, the chief complaints of a patient with adenomyosis are menorrhagia, and equally important is dysmenorrhea. So it is a painful condition, much more painful than a fibroid uterus, right? So dysmenorrhea is one of the major complaints in adenomyosis. We said the investigation of choice here is ultrasound. What is the investigation of choice for adenomyosis? Anybody? What is the investigation of choice for adenomyosis? Yes, Mysore is correct. It is an MRI. So for adenomyosis, it is an MRI. No, investigation of choice, Belgaum, I said, has to be a non-invasive investigation. It is an MRI. Whereas, you're correct on that part, that gold standard, or the only way to diagnose adenomyosis is on histology. Right? The gold standard, or the only way to diagnose adenomyosis is on histology. So it's not a biopsy. You can't take a biopsy from the myometrium. So what we do is do a hysterectomy and send the sample, right? So the gold standard is histology. Then if you want to further differentiate the two, a fibroid uterus may cause massive growth of the uterus. The uterus may even reach 16 to 20 weeks pregnant uterus size, right? Whereas in adenomyosis, the uterine size is usually around 8 to 10 weeks. It usually does not grow bigger than that. So it is 8 to 10 weeks in adenomyosis, 16 to 20 weeks in case of a fibroid. Now I said on ultrasound, it appears hypoechoic. What do we see in ultrasound if it is a case of adenomyosis? What is seen is presence of cysts in the myometrium. Presence of cysts in the myometrium, and we see ill-defined junctional zone. The junctional zone means the junction of endometrium and myometrium. So an ill-defined junctional zone and the presence of cysts in the myometrium is a feature of adenomyosis. Now, I just said that histopathology is the best way to diagnose adenomyosis. Then they ask you, what is the criteria? Again, ask this year AIPG. What was the question? At what distance from the junctional zone are the endometrial deposits present? At what distance from the junctional zone are the endometrial deposits present? What is the answer? It is 2.5 mm. No, it is 2.5 mm or more than one high power field. It is not more than 3 high power fields. It is more than one high power field from the junctional zone or 2.5 mm from the junctional zone if you are to call it a case of adenomyosis. The treatment of adenomyosis is hysterectomy. The only treatment of adenomyosis is hysterectomy, right? Coming to adeno be made without no, see, a lot of radiologists do pick it up on ultrasonography, but as we say that it is never confirmatory. So ultrasound findings are not confirmatory. Ideally, it should be an MRI, right? But a lot of people would write adenomyosis on ultrasound, but there is then no other way to, refute it unless you do a biopsy or a hysterectomy and tell, oh, there was no adenomyosis. So a lot of people do write suggestion or suggestive of adenomyosis on ultrasound, but that is not the investigation of choice. The investigation of choice is MRI, right? Okay, now before I go further, there is something special to fibroid called as red degeneration of the fibroid. The red degeneration of fibroid is characteristic to pregnancy, although it can rarely occur even outside pregnancy. So usually we say it is associated with pregnancy. It is usually seen in the second trimester of pregnancy. And red degeneration of fibroid presents as acute abdomen. It presents as acute abdomen, by which we mean there is pain abdomen, nausea and vomiting, and maybe along with that fever, right? On investigating, there is leukocytosis. Now, we have to remember that even though there is leukocytosis, red degeneration is an aseptic condition. The fever and leukocytosis are only reactionary. The fever and leukocytosis are only reactionary. It is otherwise an aseptic condition, right? The treatment is conservative. The treatment is conservative management, right? That is, we give analgesics, antipyretics, bed rest, and fluids. There is no role of antibiotics and no role of surgery. So analgesics, antipyretics, bed rest, and fluid is what is given to a patient with red degeneration of the fibroid. Remember another small point which you all, let's see if you know it or not. A fibroid is dependent on what hormones? Estrogen alone, progesterone alone, or both? Yes. Yes, so please remember, a fibroid is dependent on both estrogen and progesterone. A fibroid is dependent on both estrogen and progesterone. Estrogen causes proliferation, whereas progesterone prevents apoptosis. So the latest theory says that it is dependent on both estrogen and progesterone and not estrogen alone, right? What are the indications for treatment? Any symptomatic fibroid should be treated. any symptomatic fibroid should be treated. Number 2, even if it is asymptomatic but it is more than 12 weeks pregnant uterus size, it is still an indication to treat. Most common degeneration in pregnancy is going to be red degeneration only, right? Now, I know what you're trying to ask is, since it is most common is Hyline, so is it also most common in pregnancy? But when they're asking you pregnancy, the better answer remains is red degeneration, right? So more than 12 weeks pregnant uterus size, or a fibroid that is more than 6 centimeters in size. These are the indications. Now, if you talk about recurrent pregnancy loss, then we do not treat fibroids routinely for RPL. But we will treat when all other causes have been excluded. So when all other causes have been excluded and the patient is suffering from recurrent pregnancy loss, then if there is a fibroid in the uterus, you might as well treat it. Same holds true for infertility. So we routinely don't treat fibroids, but we would treat in a couple with infertility when there is no other cause of infertility identified. When no other cause is identified and there is a coincidental fibroid sitting in the uterus, then it calls again for the treatment of the fibroid, right? Now, when you talk about treatment of the fibroid, there are drugs which control blood loss, effect of fibroid in pregnancy. Now, you're asking me really small things which you... Alright, what would be the effect of a fibroid on pregnancy? Come on, I think you should be able to enumerate that. It can cause abortions. It can cause IUGR. It can cause preterm labor. Then, what else? It can cause postpartum hemorrhage. It can cause malpresentations. It can cause obstruction. It can even be a cause of abruption. Right? There's nothing special about it. So fibroids can cause all these things in pregnancy, right? Okay, so what I'm saying is that if you talk about treatment, there are drugs which reduce blood loss. And there are drugs which reduce the size. Now these are two different categories. So I'm saying there are drugs which will reduce the size of the fibroid, and there are drugs which will reduce the blood loss. Now if you talk about drugs which reduce blood loss, the first line drugs or the drug of choice are oral contraceptive pills. Now please understand that we said a few minutes back that a fibroid growth is dependent on both estrogen and progesterone. So having said that, low dose oral contraceptive pills do not cause growth of the fibroid. Low dose OCPs do not cause growth of the fibroid, rather they will reduce the blood loss, but they do not reduce the size. The second could be a levonorgestrel intrauterine device which comes by the name of Mirena. Third is a drug called as tranexamic acid. It is an antifibrinolytic drug which has been found to be effective to reduce the amount of blood loss in a fibroid. Progestogen alone drugs or tablets have not been found to be very effective in the control of blood loss. So alone progestrogens are not very effective, but yes, you can put them, but they are not really effective, so I've put them really down the line. If you talk about drugs which reduce the size of the fibroid, then GnRH agonist, GnRH antagonists. Now here are two things more about GnRH agonist that you should know. Number one, GnRH agonist cause a condition called as a flare response. Now before they cause feedback inhibition, initially they cause increase in the release of LH and FSH, which is called as a flare response. This flare response is not seen with antagonists. The second thing that you need to know is GnRH agonist, what is the approved time for which they can be given at a stretch? What is the approved time for which they can be given? The answer is 6 months. So GnRH agonist should not be given for more than 6 months. Reason is because they cause severe osteoporosis. Right? So they reduce the bone density, they cause osteoporosis when they are given beyond 6 months. Now what will happen is, when you stop the drug after 6 months, it causes regrowth. So it is not very effective. It will be effective only when you give it. So during the time you are giving it, it is going to cause shrinkage of the fibroid. But whenever you stop it, it is going to cause a regrowth of the fibroid. Right? And we cannot give it lifelong to any female. We cannot in fact give it for more than 6 months because it causes osteoporosis. And that is why if you want to give it for more than 6 months, if you really want to give it for more than 6 months, then we have to do something which is called as add-back therapy. Now in this add-back therapy, what do you think are we going to add back? Can anybody tell me? What are we going to do in the add-back therapy? So about add-back, you should know that it is to be given beyond 6 months of GnRH therapy. And in add-back therapy, yes, what we are going to give is estrogens, right? And the estrogens which we give here are conjugated equine estrogen. Conjugated equine estrogen is what we give in the add-back therapy. So whenever we want to give GnRH agonist for more than 6 months, estrogen has to be added back, right? The third category of drugs which can be given to reduce the size of the fibroids are mifepristone and ulipristal. These both are selective progesterone receptor antagonist, or modulators I should say. They are selective progesterone receptor modulators, mifepristone and ulipristal, right? Another drugs which can be given to reduce the size of the fibroid is aromatase inhibitors, and just to complete the list is danazol. It also causes shrinkage of the fibroid, but again never given because of the severe androgenic side effects. Now as far as GnRH agonist is concerned, I told you it does cause significant reduce in the size, but even then you would hardly see GnRH agonist being prescribed in the OPD to patients with fibroids. Why? Because number one, if you give it to patients with fibroids in reproductive age group, the patient cannot conceive, right? Because we're giving it continuously, so the patient will not be able to conceive. Secondly, as I told you that we cannot give it for more than 6 months, and when you stop it causes regrowth. So the only place where GnRH agonists are being used nowadays is prior to myomectomy. So we give it prior to the myomectomy in a big sized uterus or in a big sized fibroid, because it will reduce the intraoperative blood loss. It causes shrinkage of the fibroid and it will reduce the intraoperative blood loss. So before we plan the surgery, we put the patient in GnRH agonist. It will cause shrinkage and it will reduce the blood loss, right? Now if you talk about surgical management, the surgical management could be a myomectomy, or it could even be a hysterectomy. And something which is done between medical and surgical methods called as uterine artery embolization. So the different type of things that are available are myomectomy, hysterectomy, or uterine artery embolization. All I'm saying is uterine artery embolization is reserved for women who are not being helped by medical management or who are not getting relief with medical management and who are not willing for a surgical procedure. So uterine artery embolization comes between medical and surgical management. If you talk about myomectomy, you classify it depending on the route by which you're doing. So there can be an abdominal myomectomy, there can be laparoscopic myomectomy, and there can be hysteroscopic myomectomy. Right? Now, just like any other procedure, if you combine or compare, not combine, if you compare a laparoscopic surgery with an abdominal open surgery, then the benefits are very standard, right? So we say it is less time taking, there is less post-operative morbidity, this is less expensive, there is early recovery, shorter post-operative hospital stay, right? So these are the standard things which we use whenever you compare a laparoscopic surgery from a open abdominal surgery. On the other hand, the disadvantage of laparoscopy or laparoscopic myomectomy is that it has higher recurrence rate. So laparoscopic myomectomy as compared to abdominal myomectomy has a higher recurrence rate. As far as hysteroscopic myomectomy is concerned, we actually cannot compare a hysteroscopic procedure from an abdominal procedure simply because the indications for two are different. So hysteroscopic myomectomy is done for submucosal fibroids, whereas an abdominal myomectomy would be done for subserosal or intramural fibroids, right? But even then, if we want to compare, hysteroscopic myomectomy has more blood loss. In case there is blood loss, then the hysteroscopic myomectomy has more blood loss. No, the recurrence rate is less, provided the selection of the patient is good. For example, what I mean is, if I select a patient with type 2 submucosal fibroids for hysteroscopic myomectomy, am I going to be successful? No, I cannot be successful because I have not chosen my patient correctly. As I said, type 2 submucosal fibroids cannot be removed completely via hysteroscopy. So they will have a higher recurrence rate. But when done with good patient selection, it has a lesser recurrence rate as compared to abdominal myomectomy and a higher blood loss rate, right? The reason is, why is there is a higher blood loss? Because it is very difficult to coagulate the vessels hysteroscopically. Once the major vessels are bleeding, you really can't control the blood loss. Whereas if you're doing an open surgery, you can do multiple things to control the blood loss, right? Whereas in hysteroscopy, it becomes difficult to control the blood loss. But given majority of the patients would not have excessive blood loss. Majority would have blood loss, but in case there is blood loss, then yes, the blood loss would be more simply because we cannot control the blood loss that easily in a hysteroscopic surgery as compared to an abdominal surgery, right? Now there is a newer thing which has come up with fibroid treatment. It is called as MRG-HIFU. MRG stands for magnetic resonance guided high frequency focused or high intensity focused ultrasound. So this is a new non-invasive method which has come up. What we do is the patient lies on a table, you focus the fibroid via an MRI machine, and from below high intensity ultrasound waves are given to this fibroid. It causes destruction of the fibroid. So it is one of the newer non-invasive methods, very effective, which has come up for the treatment of fibroid uterus, MRG HIFU or high intensity focused ultrasound. So it is also called as FUS, focused ultrasound, high intensity focused ultrasound. Now, what are the contraindications to MRG HIFU? So if there are more than 5 fibroids in number, if the fibroid size is more than 10 centimeters in size, if it is a heavily calcified fibroid, and if the patient desires future conception. So these are as of now the contraindications. I'll hold the mic closer, I'm so sorry for that. So these are as of now the contraindications for MRG HIFU. I said more than 5 fibroids in number, more than 10 centimeter size of the fibroid, a heavily calcified fibroid, and patients who desire future pregnancy. Again, in them we cannot do again in them we should not do high intensity focused ultrasound or MRG HIFU, right? So with this we finish the fibroids or the fibroid uterus. Alright, now what we're going to start with is going to be one of the most important topics in gynecology, and that's going to be, can we take a lunch break after 1 hour? Are you really hungry right now? All of you are hungry? I think we can go ahead for an hour and then take the lunch break. Yes, so we'll take the lunch break at 2, not at 1. Okay, we'll see, we'll do a compromise somewhere between 1 and 2. Okay, so now what we're going to start with is going to be oncology, right? And what we start with is cervical cancer. Now when we say cervical cancer, why do I start with it? Because it is the most common cancer among Indian women. So as of now, it is the most common cancer among Indian women. And the thing with cervical cancer is that there is a long time period between the infection, pre-invasive and invasive lesions. So there is a long time between pre-invasive, invasive lesions, and that is why we do universal screening for cervical cancer. Okay, so we do universal screening for cervical cancer. Now, whenever you talk about universal screening for cervical cancer or screening for any cancer for that matter, we have to know when should be the onset, how do we continue, and when do we stop, right? So, screening for cervical cancer begins at 21 years of age. It begins at 21 years of age, irrespective of onset of sexual activity. So even if a girl has her first coitus at the age of 16, we start screening only at 21 years of age. The screening method we use can be only pap smear, or it can be PAPS plus HPV DNA testing. So it can be only pap smear, or it can be PAPS or HPV DNA testing. When we use only pap smear, then the screening interval is once every 3 years. When we combine PAPS and HPV DNA testing, then the screening interval is once every 5 years. But another thing which you have to remember is that HPV DNA testing can be done only for women more than 30 years of age. So for women between 21 to 29 years of age, we can only use pap smear. We cannot use HPV DNA testing, or we don't use HPV DNA testing. HPV DNA testing is to be used only beyond 30 years of age. Right? So this is how we continue. When do we stop screening? Why? Now, the reason for the why is that before 30 years of age, HPV infection is very commonly found in that age group, between 21 to 29. So what will happen is, if you use it for screening, every patient will turn out to be positive and the load of screening is going to be very high. So what we are bothered about is not HPV infection. What we are bothered about is persistent HPV infection. So that is why we start screening for HPV DNA only beyond 30 years of age, because we want to pick up the ones which are persisting, because it is the persisting infection which has risk of malignancy, right? All right. I don't know what, Bilaspur, what you're writing, maybe the coordinators will manage that. What do you mean by space notepad? Whatever. We'll keep. Okay. The next thing we talk about is, when do we stop screening? Right? When do we stop screening for cervical cancer? We stop screening at 65 years of age. We stop screening by 65 years of age. The reason is, or there is a rider added to it which says, look people, I'm writing in the center, the notepad is going to move, right? So stop being worried about smaller things and pay attention on what is being told in the class. If you keep stopping me for everything, then we can't really go ahead and teach, right? The notepad is going to move, बच्चा. जब मैं लिखूंगी तो वो अपने आप move करेगा. और अगर वो अपने आप नहीं करेगा और मैं manually करूंगी, then it wastes a lot of time, right? In moving it left, right, up and down. So we have to make the class more effective. I'll try and write it in the center, but it's going to move. Try and understand, right? So we stop screening at 65 years of age, but there is a rider added to it. The rider is that provided the last 3 pap smears are normal or they have no suspicion of malignancy. So we stop screening at 65 years of age, provided the last 3 pap smears have no suspicion of malignancy. On the other hand, if any of the last 3 pap smears have suspicion, then we extend the age to 75 years of age. In that case, we will extend the age to 75 years of age, right? Now, once you talk about screening and we talk about pap smear, the instrument we use is the Ayers spatula. It's a wooden instrument, Ayers spatula, and the solution we use has 95% alcohol and 5% ether. So it's a combination of alcohol and ether, 95% alcohol and 5% ether. Whenever we send the pap smear, the reports of pap smear can be any of the following. The first, so what I'm writing is now the Bethesda system of classification, which was given in 2010 and then again modified in 2011. So when you talk about the Bethesda system, the report of pap smear can be any of the following. The first report is normal. The next is infection. The next is reactive reparative changes. Reactive reparative changes. Still next is ASCUS. The ASCUS stands for atypical squamous cells. Atypical squamous cells of undetermined significance. Atypical squamous cells of undetermined significance. The next possible report is LCIL, where LCIL stands for low-grade squamous intraepithelial lesion. Still next report can be HCIL, high-grade squamous intraepithelial lesion. And finally, the report can be frank cancer. So normal, infection, reactive and reparative changes. Now whenever the report is any of these three, that is normal, infection or reactive reparative changes, we really don't need to bother about malignancy, right? There is no risk of pre-invasive lesions or malignancy. If there is an infection, we treat the infection by giving the drug. If there is reactive reparative change, it means that there was inflammation which is now recovering, right? So these are recovery changes that you see. Any of the reports after that, that is ASCUS, LCIL or HCIL or cancer, are called as abnormal reports, right? Now please remember that as far as pap smear is concerned, pap smear is only a screening tool, right? Pap smear is only a screening tool. Before I go a little forward, from where do we take the pap smear? The pap smear is taken from the transformation zone, which is located on the squamocolumnar junction. So it is taken from the ectocervix, from the transformation zone, which is located on the squamocolumnar junction. Now this is the region or the area where pre-invasive and invasive lesions first appear. If you talk about the transformation zone, then this zone has an outer margin and an inner margin. Physiologically, with increasing age, what we see is the inner margin will recede inside the endocervix. So as the age of a female increases, the inner margin will go inside the endocervix. This is a normal physiology. But the conditions where the transformation zone moves out. What are the conditions where the transformation zone moves out? Number 1, pregnancy. So in pregnancy we see the reverse, the TZ moves out. Number 2, it also moves out in women who are using oral contraceptive pills. And it also moves out at puberty. Single answer or the single best answer to this question is pregnancy. So if they ask you in which condition does this transformation zone move out, I'm saying the single best answer is pregnancy, but otherwise it moves out in all these 3 conditions. Also, in the Bethesda system, we've started to classify pap smear as LSIL, HSIL and ASCUS and so on. But before the Bethesda system, the pap smears were labeled, or the reports were labeled in 2 other systems, the dysplasia system and the SIN system. So that is why they are still asking you these questions, that if the report is LSIL, what does it correspond to in dysplasia and what does it correspond to in SIN? So LSIL corresponds to mild dysplasia and it corresponds to SIN 1. So it corresponds to mild dysplasia and to SIN 1, LSIL. What do we mean by mild dysplasia? It means lower 1/3 of epithelium. The lower 1/3 of the epithelium is dysplastic. The lower 1/3 of the epithelium is dysplastic. When we use the term HSIL, HSIL can or is equal to, all these 3, SIN 2, SIN 3 and CIS. So HSIL is equivalent to SIN 2, SIN 3 and CIS. SIN 2 corresponds to moderate dysplasia. SIN 2 corresponds to moderate dysplasia, whereas SIN 3 and CIS correspond to severe dysplasia. Also, moderate dysplasia means, or SIN 2 means, lower 2/3 of the epithelium is dysplastic. The lower 2/3 of the epithelium is dysplastic, whereas SIN 3 means more than lower 2/3 is dysplastic. More than the lower 2/3 is dysplastic. CIS means carcinoma in situ, and it implies that entire epithelium is dysplastic. Entire epithelium is dysplastic. So that is what it means when we say CIS. So this is the equivalent terms of LSIL and HSIL in SIN system and in dysplasia system. Another thing which you have to understand is that dysplasia is pre-malignant for cervix. Dysplasia is a pre-malignant condition, whereas metaplasia is not pre-malignant. So metaplasia is not pre-malignant, whereas dysplasia is pre-malignant. Also, you have to know that as we said that PAPS is only a screening tool, and this is the method we use in India, that is pap smear, even at the level of PHCs. So even at the level of a primary healthcare center, screening for cervical cancer is done with pap smear, right? Any abnormal report on pap smear has to be confirmed. And the confirmation is only by histopathology. The confirmation is only by histopathology, and we take histopathology in the form of biopsy from the cervix. So the tissue sample is taken in the form of a biopsy. Now in order to take this biopsy, we take help of an instrument called as a colposcope. So a colposcope is an instrument which has an inbuilt microscope, and it is used to visualize the cervix, but please understand that it will only visualize the ectocervix. A colposcope cannot visualize the endocervix at all. So all it visualizes is the squamocolumnar junction on the ectocervix. Now, if I am using a colposcope to take a biopsy, what I have to understand is that ectocervix is a big area. So from where do I take a biopsy? So I have to identify abnormal areas on colposcopy from where I should take a biopsy such that my pickup rate for cancer is going to be high. So what describes abnormal areas? As we say that dysplasia is a pre-malignant condition, and we all know that pre-malignant or malignant conditions have a specific feature which is increased vascularity. So they are more vascular than the surrounding areas, and that is why we look at number 1, abnormal vessel patterns. So when we are doing a colposcopy, we look at the abnormal vessel patterns which are described as punctate, reticular, punctate pattern, reticular pattern, and mosaic pattern. So these are abnormal vessel patterns which, if seen, must be included in the areas of the biopsy. The second thing we look at is color of the mucosa. The mucosa which is dysplastic or is unhealthy is pale, right? So it is pale as compared to the healthy pink mucosa on other sides. The third thing we can look at is the contour. So areas which have irregular contour should also be biopsied. So either you look at the vascular pattern, the second criteria is the color, and the third is the contour. We can also use acetic acid and Lugol's iodine to take the or identify the abnormal areas. So we say on application of acetic acid, the abnormal areas are areas that are stained, and these are the white areas. So on applying acetic acid, it is the stained areas that are abnormal, or the aceto-white areas abnormal, from which we should take the biopsy. If you talk about Lugol's iodine, then we say that the unstained areas are abnormal. So in application of acetic acid, some areas will look mahogany brown, whereas the other areas will not take up the brown color. So the unstained areas on application of Lugol's iodine are abnormal areas, and again they should be biopsied. Now, sometimes it is, if you are sitting in a remote corner of the country, there is a possibility that you will not have microscope at your hand, right? So in that case, again, what we use is acetic acid and Lugol's iodine, and we do VIA and VILI. VIA stands for visual inspection with acetic acid, and VILI stands for visual inspection with Lugol's iodine, where the idea is again the same, to pick up the aceto-white areas and to pick up the unstained areas on Lugol's iodine, as they would be very much visible to the naked eye, right? Now, if I ask you, what is the single best parameter which differentiates a pre-invasive lesion from the invasive lesion? What differentiates a pre-invasive lesion from invasive lesion? Can anybody tell me? Yes, very good, my source. So the answer is an intact basement membrane. So if the basement membrane is intact, it is a pre-invasive lesion. Whereas if the basement membrane is breached and there is involvement of the stroma, then it is a invasive lesion, right? Alright, now we come to management of pap smear, right? So if you are the treating doctor and you've taken a pap smear for the patient, she will come with the report to you only for the pap smear assessment, and then you should know what you're going to do with any of these lesions. So if the report on pap smear is ascus, then any of the following three things can be done. First, we can repeat pap smear after 6 months. So if it is ascus, we can repeat pap smear after 6 months. Another thing that we can do is do HPV DNA testing. And the third thing we can do is straight away go and take or do a colposcopic directed biopsy. So any of the three can be done. Repeat pap smear after 6 months, HPV DNA testing, or a colposcopic directed biopsy. If you do a pap smear after 6 months and the report is anything more than or equal to ascus again, then that's an indication then to do a colposcopic directed biopsy. And if you do an HPV DNA testing and it turns out to be positive for the high risk DNA, then again we will have to do a colposcopic directed biopsy. So the single best answer, if they ask you, is a colposcopic directed biopsy. That is the single best answer out of the all the three. Otherwise, all three can be done. These are, now what I am teaching you now is not my management of ASCUS or LSIL or HSIL. These are guidelines given by ASCCP. So this is the American Cancer Society, Cervical Cancer Society, and they've given these guidelines, ASCCP guidelines, that I am teaching you now, right? So this is the ASCCP guideline to deal with ASCUS. Next, if the report of pap smear is HSIL, as I said, as with any screening method, if a screening method comes out to be, the test comes out to be normal, we don't do anything ahead. Whereas if any screening method comes out to be positive, it says that there is, for example, if you do an HIV method and you say that the screening test is positive, then we have to do a confirmatory test. Similarly, because pap smear is a screening tool, any abnormal report has to be confirmed, right? So if the report is LSIL, the next answer is again a colposcopic directed biopsy. The answer is going to be a colposcopic directed biopsy. Now please understand that nowadays the terms of SIN 1, 2 and 3 are not used for pap smear. SYN 1 and 2 and 3 are to be used with colposcopy. So the report of colposcopy is going to come as SYN 1, SYN 2 or SYN 3, right? Now why I am telling you here, I am going to ask you a question and you are going to reply to me. If the pap smear report is SYN 1, if the pap smear report is SYN 1, what should be your next step? Quickly. Anybody? If the pap smear report is SYN 1, what should be our next step? So, please don't get confused. No matter what they write on pap smear, if they write SYN 1, if they write SYN 2, if they write SYN 3, the answer is going to be only one. It is going to be a colposcopic directed biopsy. Now they try and confuse you. They'll say pap smear shows SYN 3 and what should be the next step, and you people go and mark treatment, right? No, that's wrong. So pap smear may anything abnormal report, the answer is going to be a colposcopic directed biopsy, right? Now, then we come to HSIL. Then we come to the management of HSIL, that is if the report is HSIL on colposcopy, on pap smear. So if it is HSIL on PAPS, the next step again remains the same, a colpo directed biopsy. Now sometimes the examiner in the options may not write this full statement, colposcopic directed biopsy. So even if it says colposcopy, it is self-explanatory that we are going to do a biopsy with it, right? So please don't get confused with that as well. But in HSIL we do an additional step called as ECC, right? ECC stands for endocervical curettage. ECC stands for an endocervical curettage. Now why have we added this point in HSIL? HSIL का क्या मतलब था? High risk of malignancy or high risk of squamous cancer, right? Which means that the cancer can be, usually the cancer arises in the transformation zone, but the transformation can, the cancer can also arise in the endocervix. Since it's a high risk lesion, there is a probability that the cancer arises in the endocervix. So to take a biopsy from the ectocervix, what we do is colposcopy. But colposcopy can never show us the endocervix, and therefore we do an extra step to take biopsy from the endocervix as well, and that is the endocervical curettage, right? Now, this is the management of HSIL and LSIL. Coming to the management of SYN lesions. So when we say SYN 1, please ensure that it is a colposcopic SYN 1, that is confirmed on colposcopy. So when SYN 1 is confirmed on colposcopy, our initial management is conservative. Our initial management is conservative for SYN 1. Why? The risk of SYN 1 to convert into cancer is only 1%. The risk of SYN 1 to convert into cancer is only 1%. The risk of SYN 1 to convert into CIS, that is carcinoma in situ, is 11%. The risk of SYN 1 to convert into carcinoma in situ is 11%. Right? Now when you talk about conservative management, what do we do in this conservative management? We do PAPS and HPV DNA testing every 12 monthly. So every 12 monthly we are going to do a pap smear along with HPV DNA testing. This conservative management is done for a period of 2 years. Why? Because 2 years is the average time for SYN 1 to regress to normal. It is the average time taken by SYN 1 to regress to normal, and any SYN 1 after 2 years means it is a persistent SYN 1, and as I told you, it is the persistent infection which leads to malignancy. So if it is a SYN 1 even at 2 years, then the answer changes to treatment. So we no longer do conservative management. Now we are going to do treatment for this. The treatment of choice for SIN1 type of lesions is ablation, which means destruction of the transformation zone, and the preferred mode of ablation is cryoablation. It is going to be cryoablation. In cryoablation, what all do you need to know? Number one, we use cold carbon dioxide and nitrous oxide gas. We use cold carbon dioxide and nitrous oxide gas. The technique is freeze, thaw, freeze. The technique used is freeze, thaw, freeze. Cryoablation is an OPD procedure. The mechanism by which these cells are destroyed is called as in cryoablation is called as crystallization of intracellular water. Crystallization of the intracellular water. The most common side effect during the procedure is pain. The most common side effect during the procedure is pain, whereas the most common long-term side effect is a persistent watery discharge. A persistent watery discharge. The other long-term side effects could be cervical stenosis or cervical incompetence. Please remember, bleeding is not a complication of cryoablation. Bleeding is not a complication of cryoablation. Also, please remember, among all procedures done on cervix, among all surgical procedures done on cervix, cryoablation is least likely to cause incompetence. So it is one of the safest procedures. So it is a rare complication, right? So among all the procedures done on cervix, cryoablation is least likely to cause cervical incompetence. So this was the management of SIN1. Coming to the management of SIN2 and SIN3, and as we said, it should be colposcopic confirmed. Now, the management of SIN2 and SIN3 is going to be straight away treatment. Why? The risk of conversion of SIN2 into cancer is 5%, and the risk of conversion of SIN3 into cancer is said to be more than 12%, and some books give it an absolute value of 22%, right? So the conversion risk of SIN2 to frank cancer is 5%. No, SIN1 doesn't recur, right? Recurrence is again something very rare that you do. SIN1 is a mild lesion, and the conversion of SIN2 into frank cancer, as I said, is more than 12%, and some books give a definite value of 22%. Therefore, there is no role of conservative management. What we are going to do is going to be treatment. The treatment of choice for SIN2 and SIN3 is excision. So for SIN 1, it was ablation. What prior to ablation? Prior to ablation in SIN 1, we said it is conservative management, and in conservative management we do pap smear and HPV DNA testing every 12 monthly for a period of 2 years. So the treatment of choice for SIN 2 and SIN 3 is excision, and the excision procedure of choice is called as LEAP, and the other name for LEAP is LETS, where LEAP stands for large loop, it stands for, that is for LETS. LEAP stands for loop electrosurgical excisional procedure. So LEAP stands for loop electrosurgical excisional procedure, and LETS stands for large loop excision of transformation zone. Large loop excision of the transformation zone. Nowadays, LEAP is the treatment of choice for SIN 2 and SIN 3. For the following reasons. Why is it the treatment of choice? Number 1, it is an OPD procedure, so can be done without anesthesia or minimal anesthesia. It is a very short procedure, it takes less than 2 minutes. The procedure is both diagnostic and therapeutic. It needs no training. So it is an easy to perform procedure. We don't need any special training to do a LEAP procedure, right? Now before LEAP came into being, for SIN 2 and SIN 3, people were doing another procedure called as conization. So before LEAP came into being, people were doing conization. This is nothing but a cone biopsy. Cone biopsy is a procedure which is done in operating room. So it requires full anesthesia. It is a major surgical procedure. Again, conization is also both diagnostic and therapeutic. Since it is not done nowadays, so they are very fond of asking you the indications of conization today. So what are the conditions where we still do conization? And before I make you write the indications, I'm going to make a diagram and I'm going to tell you how the cone is cut. Now before I cut the cone, tell me what A is, what B is, and what is C. So what point is A? A is the stroma, alright. B is endocervix and C is ectocervix, right? So these are the regions, and this is how we cut a cone. So the base of the cone is on the transformation zone or on the ectocervix, and the apex of the cone is directed into the endocervix. So can you quickly write down what all areas can be sampled with cone biopsy? Quickly, anybody, what all areas are sampled with cone biopsy? Anybody? So when you are doing a cone biopsy, we are getting a sample. Yes, exactly, Mysore. We are getting a sample from all the 3 sites. We are getting a sample from the transformation zone, We are getting a sample from the stroma and we are getting a sample from the endocervix, right? Now when I give you the indications, you will be able to understand it much better that why in these indications we are doing a cone biopsy. So again I am repeating, we are getting samples from all three sites, ecto, endo and stroma, right? So if you talk about indications, the first indication of cone biopsy today or conization today is unsatisfactory colposcopy. Now what do we mean by unsatisfactory colposcopy? When the entire transformation zone is not visible, the colposcopy is called as unsatisfactory, because I told you that physiologically with age the transformation zone recedes into the endocervix. So if the entire transformation zone is not visible outside, then we have to do a cone biopsy because this colposcopy is unsatisfactory. Second, when there is a lesion on the cervix, and entire lesion is not visible by colposcopy, then also the colposcopy is unsatisfactory. So for example, there is an ulcer on the cervix, only small amount of ulcer is outside, the rest is inside the endocervix. Then again it is an unsatisfactory colposcopy and we will have to do a cone biopsy for this. Second, when there is discrepancy between cytology and histopathology. So when there is discrepancy between cytology and histopathology, by cytology we mean pap smear and by histopathology we mean a colposcopic biopsy. So for example, a cytology report says that it is a high grade lesion, HSIL, and when I do histopathology, I found out that the answer is SIN1. So are these corresponding lesions? A screening report, a screening sample or a screening method tells us it is a high grade lesion, whereas a confirmatory test, which is supposed to be more sensitive and specific, tells us that it is a low grade lesion. So that means either of the one is wrong. या तो cytology report गलत है या histopathology report गलत है. And in that case we need to call our third umpire, and the third umpire in this case is going to be a cone biopsy, right? The third umpire in this case is going to be a cone biopsy, right? So these are two indications. Coming to the next indication. So the first indication I said unsatisfactory colposcopy, and the second indication we said discrepancy between cytology and histopathology, right? The third indication for conization today is when ECC is positive in HSIL. So when I did a colposcopy and endocervical curettage, if the report says that endocervical cells or endocervical curettage is positive for malignancy, then again we will have to do something extra now, and the answer is going to be a cone biopsy or a conization. Fourth, when I send a sample on colposcopy and the histopathologist says there is suspicion of microinvasion. Now when there is suspicion of microinvasion, it means I need to see a sample from the stroma. So I need to see the junction between stroma and the mucosa or the epithelium in order to see microinvasion. And the only possible way to get a sample from the stroma is a cone biopsy. We cannot get it in LEAP because LEAP only cuts the transformation zone on the ectocervix, right? The last indication, if the report of pap smear was adenocarcinoma, Now please understand, whenever there is adenocarcinoma, it means we have seen columnar cells. And where are columnar cells present in the cervix? They are present in the endocervix, because the ectocervix would be lined by squamous cells and the endocervix would be lined by the columnar cells. So whenever the report of pap smear or a biopsy, colposcopic directed biopsy, comes as adenocarcinoma, then again the modality of choice is not going to be LEAP, it is going to be a cone biopsy or a conization. So these are the only 5 indications for conization in modern day. Otherwise we are sticking to LEAP. Now please understand, LEAP is the treatment of choice for SIN 2 and SIN 3, and even cis term we don't use nowadays, it is an older term. So it is the treatment of choice for SIN 2 and SIN 3, irrespective of age of the patient, irrespective of parity of the patient, and irrespective whether the treatment or the question says best treatment and so on. So the questions try and confuse you by changing the age of the patient, by changing the parity, and by writing the word best treatment. So even if it is a 45-year-old lady with SIN 3, the answer remains as LEAP. Even if it is a 40-year-old lady, para 3L3, the answer is still LEAP. Even if the question says the best treatment for SIN 2, the answer, or SIN 3, the answer remains LEAP. So we are not going to mark hysterectomy as the answer. So in these cases, hysterectomy is not the answer. The answer remains as LEAP, right? When would you, there would be some of you who would still want to ask me, ma'am, when should we mark hysterectomy as the answer then? I know you are hungry, so am I. Just a few minutes more. I need to complete this, or I can just skip it out. Do you want me to skip it out? So when you say hysterectomy, I'm saying some of you would actually would want to ask, ma'am, when do we do hysterectomy then? So answer to that question is, if the question says a recurrent SIN, if it is a recurrent SIN lesion, then yes, the answer, or a better answer, is hysterectomy. If it is adenocarcinoma, again the better answer is hysterectomy. If the question says patient will not follow up, so if the question clearly says that patient is SIN 3 and she is not going to follow up, then again the better answer is hysterectomy, but it has to be said in those many words. Last, when there are coexistent other pelvic pathologies. So when there are coexistent other pelvic pathologies, for example, patient is also suffering from DUB, for example, she has multiple fibroid uterus, then yes, again, it may be an indication for hysterectomy. But alone, SIN 2 or SIN 3 is no indication for hysterectomy. Alright? So with this, we take a break and we start the class at 2:30. Is that okay? So it's going to be a 25-minute break. Yes, they will put up the pages for you. LEAP done under colpo. No, LEAP is not done under colposcopy. It is an OPD procedure. You can do it just directly. Right? अच्छा जाओ तो सही. We'll start at around 2:35. ठीक है ना तुम्हारा ना मेरा. Right? So 2:35 to 2:40 we start the class again. Back. So what we're going to do now is going to be cervical cancer proper, right? So we begin with cervical cancer. Now, till now, what we did was the pre-invasive lesions of the cervix. Now we go on to cervical cancer. Now, as I said, this is the most common cancer among Indian women. Even as far as the latest PARC is concerned, that is what it says. So this is the most common cancer among Indian women. Now, if we talk about risk factor, then certain risk factors are very easy and all of us know, but still we would enumerate, and then we come to the ones which are, which are controversial or they have something more to them than simply the risk factor. So if we talk about risk factors, then early age at first intercourse, early age at first childbirth, multiparity, multiple sexual partners, low socioeconomic status, low socioeconomic status, presence of sexually transmitted diseases, presence of pre-invasive lesions. Now, as far as pre-invasive lesions are concerned, we say 10% of LCIL, 10% of LCIL convert into HCIL, and then we say 10% of HCIL convert into frank cancer. So 10% of LCIL convert to HCIL and 10% of HCIL convert into frank cancer. Right? Now, other than these, the things which remain a little controversial are, number 1, or let's say number 8, is cigarette smoking. So please understand, cigarette smoking is a risk factor for cervical cancer, but only for the squamous cell type. So cigarette smoking is a risk factor for only the squamous cell type of cancer. Oral contraceptive pills. Oral contraceptive pills are also a risk factor, but they have to be consumed for a period, a minimum period of 5 years to cause any increase in the risk. So only when they are used beyond or for consecutively for a 5-year span do oral contraceptive pills become a risk factor. Oral contraceptive pills have also been seen to be more commonly associated with adenocarcinoma as compared to squamous cell cancer. So they are related to adenocarcinoma. Also, please remember that early menarche and late menopause. Early menarche and late menopause are not risk factors for cervical cancer. So they are not the risk factors for cervical cancer. As far as genetics is concerned, as of now, you should remember that family history is not a risk factor. Although some people say that there may be some association, but what exactly are the genes, if at all there are any, we don't know them, they are still into study. For as of now, you should say that family history is not significant for cervical cancer. Then, these are all risk factors for cervical cancer, right? But what is the causative agent for cervical cancer? So what is the causative agent? So when you say causative, then it is the HPV infection, right? So HPV is causative. HPV is causative. Just a moment, please. Huh? निकल गया. Oh. Just a moment, please. When you talk about the HPV infection, there are certain one-liners that we are supposed to know. So I said this is the causative agent. This is the causative agent of cervical cancer. And when we say that, we divide HPV into high risk and low risk. So what are the high risk HPVs? We all know 16 and 18, right? But other than 16 and 18, there are other high risk type of HPVs. The other high risk HPVs are 30. So other than type 16 and type 18, which are the high risk HPVs, the other high risk are 31, 33, 35, 45, 58, right? So these are all the high risk HPVs which are present. When you talk about low risk HPVs, they are type 6 and type 11, right? Out of all the high risk HPVs, type 16 and type 18 are responsible for 70% of cervical cancers. Type 16 and type 18 are responsible for 70% of cervical cancers. Out of which we say type 16 is more sensitive, type 18 is more specific. Alright, also we say that type 16 is more associated with squamous cell cancer, whereas type 18 is more associated with adenocarcinoma. Then type 16 and 18, other than this, what do type 6 and type 11 cause? Type 6 and type 11 are low risk HPVs and they are associated with a condition called as condylomata acuminata. Condylomata acuminata, and if a baby is born from a mother who is carrying the HPV virus in the genital tract, then they also cause a condition in the newborn baby called as juvenile papillomatosis. Juvenile papillomatosis is another condition caused by the HPV infection. Then the characteristic histopathological finding, in HPV infection is called as coilocytosis, which means perinuclear halo. So coilocytosis is what? It is the presence of a perinuclear halo, and this perinuclear halo appears because of cytoplasmic clearing. It appears because of cytoplasmic clearing, right? Also you should know the viral proteins which are responsible for malignant transformation of the cell. Viral proteins responsible for malignant transformation of the cell are E6 and E7. They are E6 and E7, and out of the two, the better answer is E6 if you have to choose between the two. But both viral proteins are associated with malignant transformation, E6 and E7. On the other hand, if we ask you, viral proteins required for DNA replication, right? So if we ask viral proteins which are required for replication of the virus, these are E1 and E2. So for replication it is E1 and E2. For malignant transformation it is E6 and E7. What cell types are affected by the HPV infection? So we say HPV infects the basal epithelial cells, or they're also called as the basal stem cells. So it infects the basal epithelial cells, and the basal stem cells, right? Now, since HPV is associated with the cancers, that is why we've come up with the HPV vaccines. There are two types, Gardasil and Cervarix, right? So there is Gardasil and there is Cervarix. Gardasil is quadrivalent, whereas Cervarix is bivalent. Both the vaccines are made up of inactivated viral capsid protein. Both vaccines are made up of the inactivated viral capsid protein. Gardasil has 16, 18, 6 and 11 capsid proteins, whereas Cervarix has only 16 and 18 capsid protein. The ideal age to give the cervical cancer vaccine, irrespective of which one are you giving, is 11 to 12 years of age. The ideal age is 11 to 12, but they can be given any time between 9 to 26 years of age. They can be given any time between 9 to 26 years of age. Both vaccines are given as intramuscular injection, and the dose is 0.5 ml. So both the vaccines are given as an intramuscular injection in the dose of 0.5 ml. Gardasil is given at 0 months, 2 months and 6 months, and Cervarix is given at 0, 1 and 6 months. So all 3 doses, so it is given in the form of 3 doses, and all 3 doses have to be completed within the 6-month time, right? So within 6 months all 3 doses have to be given. Also, if you talk about which one is more potent, then Cervarix is said to be more potent or efficacious as compared to Gardasil. Cervix is said to be more potent as compared to Gardasil because it is bivalent, so it is said that it has less impurities. It has less impurities and hence it is more potent. Now, the other thing what you should know about the two vaccines is that Gardasil can be given to both boys and girls, whereas Cervarix can be given only to girls. Why is HPV vaccine given to the boys? Because it can also cause, HPV virus is known to cause what all cancers? The HPV virus can cause cervical cancer, vaginal cancer, vulval cancer, penile, anal and oral. So cancers which are caused by HPV are cervical, vaginal, vulval, penile, anal, oral, right? So out of the two, I am saying Gardasil is the one which can be given to boys, whereas Cervarix can only be given to the girls. If we ask you what is the protection rate of the HPV vaccine, so how many cervical cancers can the vaccine prevent? Then the answer is 70% of cancers can be prevented by the HPV vaccine. So the protection rate is 70%. The 30% are caused by other high risk HPVs, right? So that means even after vaccine is given, cervical cancer screening should continue. Cervical cancer screening should be done. HPV vaccine should be given to all HIV positive females. HPV vaccine should be given to all HIV positive females. No booster is required, so there is no booster dose. HPV vaccine is contraindicated in pregnancy. HPV vaccine is contraindicated in pregnancy. And if we talk about the, no, this is it about the HPV vaccines. Oh no, one thing. What is the most common side effect? The most common side effect is pain at the site of injection. But most important side effect is syncopal attack. So HPV vaccine is very common to cause syncopal attack in the females, and therefore we say any female who is going to receive the HPV vaccine, she should be, because there is the 6 and 11 are the strains of 6 and 11 are not present in cervix, and which are the common strains to cause the other cancers among boys when you talk about penile, anal and oral cancers. So since cervix is only protecting against 16 and 18, that is why it is not given to the boys, right? So syncopal attack is the most important side effect in any female who is going to, why it is a side effect? What do you mean why? It is a side effect which has been seen. Once you give the vaccine, it is seen that it causes syncopal attack, and that is why the girl should be accompanied by someone, and there has to be an observation period of 15 minutes, right? So there should be an observation period of 15 minutes, and the girl should be accompanied by someone when you are giving the HPV vaccine. Alright. Now this was about the HPV virus. The next thing we talk about are certain one-liners from cervical cancer before we go on to the details of the cancer. Right? The one-liners are, I said it is the most common cancer among India. And then we say that the most common histopathology is squamous type. So most common are squamous cell cancers. I told you the 16 and 18 are responsible for 70% of all cervical cancers. Right? The 16 and 18 are responsible for 70% of all cervical cancers. Now the most common histopathology is squamous cell cancer. Squamous cell cancer accounts for 70% of all cervical cancers. Squamous cell cancer accounts for 70% of all cervical cancers. And adenocarcinoma, being the next common, accounts for 30% of all cervical cancers. The most common mode of spread for cervical cancer is lymphatic. The most common mode of spread for cervical cancer is lymphatic. The most common presenting complaint and the first presenting complaint. The answer to these two are same. The most common presenting complaint and the first complaint in the patient is irregular vaginal bleeding, whereas the most specific complaint is postcoital bleeding. So most specific complaint is postcoital bleeding, whereas the first complaint and the most common complaint I am saying is irregular vaginal bleeding. Now if I ask you a question, a patient 36 years old comes with history of postcoital bleeding, what should be your next step? What should be the next step if a lady comes with complaints of postcoital bleeding? Yes, anybody? Yes, so please understand, if it is postcoital bleeding, then the answer has to be pap smear. Postcoital bleeding is no indication to do colposcopy. Alright, so postcoital bleeding is no indication to do a colposcopy directly. The first indication, even in postcoital bleeding, is going to be pap smear. The next thing is that a lady comes with history of postcoital bleeding, and on examination there is a, let's say, 3 into 4 centimeter mass on anterior lip of cervix. Right, so I am saying a 36-year-old lady comes with history of postcoital bleeding, and on examination there is a 3 into 4 centimeter mass on the anterior lip of cervix. Then what is the next step? Now what is the next step in this case? Karam is saying colposcopy, biopsy, colposcopic biopsy, colposcopic biopsy. No, the answer in this case is biopsy, but it is not a colposcopic biopsy. It is a special biopsy called as punch biopsy. So the answer is going to be punch biopsy whenever there is a visible growth on cervix. So whenever there is a visible growth on the cervix, the answer is not pap smear. The answer is not colposcopic biopsy. The answer is a punch biopsy. Why do you need to see to do microscopy and take a biopsy when a grossly visible lesion is there? So if a grossly visible lesion is there, we don't need a microscope to take the biopsy. So that is why the biopsy which is taken is called as punch biopsy, right? Then what is the most common cause of death in cervical cancer? The answer is uremia resulting from renal failure. So the most common cause of death in cervical cancer is uremia. What is the risk of involvement of ovaries? What is the risk of involvement of ovaries in cervical cancer? Answer is less than 0.5%. So less than 0.5%, and that is why whenever we are doing a surgery for cervical cancer, we don't remove the ovaries. So majority of times we don't remove the ovaries, right? Then which is the most common lymph node to be involved in cervical cancer? If it is most common, then the answer is obturator. So the most common lymph node to be involved in cervical cancer is obturator, whereas the sentinel lymph node for cervical cancer are paracervical lymph nodes. The sentinel lymph nodes for the cervical cancer are paracervical lymph nodes. So most common are obturator, and sentinel is going to be paracervical lymph node. Then what is the most important prognostic marker? What is the most important prognostic marker for cervical cancer? So what is the most important prognostic marker for CA cervix? The answer is stage of the disease followed by lymph node status. Stage of the disease followed by lymph node status are the prognostic markers when you talk about cervical cancer, right? So these were the one-liners that are important from cervical cancer. The next thing we go on to is staging of cervical cancer, right? So we now talk about staging of cervical cancer. The staging of cervical cancer is given by FIGO, International Federation of Obstetricians and Gynecologists. Now all these stagings for almost all the cancers have been changed. So I'm going to give you the latest stagings, right? So when you say FIGO or International Federation of Obstetricians and Gynecologists, they say that the staging for cervical cancer is going to be a clinical staging. So that means the gynecologist is going to examine the patient. She is going to stage the patient clinically, and whatever stage she says, that is going to be the stage of the patient. So since it is clinical staging, FIGO says the following investigations cannot be used to change the stage of the patient. Following investigations cannot be used to change the stage of the patient. What are those investigations? Number 1, MRI. Number 2, ultrasound. Number 3, CT scan. And number 4, PET scan. So normally these are the investigations we use to change the stage. But here FIGO says since it is a clinical staging, these investigations should not be used to change the stage of this disease, right? The only thing for which CT scan has been approved, so the figure says that CT scan can be used or to look for hydronephrosis. So CT scan can be used only to look for hydronephrosis. For anything else, we do not use CT scan to change the stage, but it has been approved for hydronephrosis. Also, we should know the investigations which can be used is a long list, like, right? But so anything other than this can be used. Now, but still, when we say can be used, you should please remember that all kind of scopies can be used, right? A scopy means to see a particular organ. So cystoscopy, which is to see the bladder, can be used. Hysteroscopy can be used. Colposcopy can be used. Proctoscopy can be used. So all kind of scopies have been allowed. X-ray has been allowed. Barium meals have been allowed. So all these investigations are allowed. The only ones that are not allowed are MRI, ultrasound, CT and PET, right? Now coming to staging. So we talk about stage 1 cervical cancer. So if we talk about stage 1 cervical cancer, it is divided into A1 and A2, B1 and B2. So cervical cancer stage 1, A1, A2, B1 and B2. Now, if this is a tissue and the cancer is starting here, there is two ways the cancer can spread. It can either go in the depth or it can grow in the horizontal direction. So that is what is used in the staging of cervical cancer. So stage 1A1 is less than 3 mm in depth and less than 7 mm in horizontal spread. A2 is 3 to 5 mm in depth and still less than 7 mm in horizontal spread. B1 is gross tumors, so A was microscopic, B is gross tumor. So B1 is less than or 4 centimeters in size, less than 4 centimeters in size. B2 is more than or equal to 4 centimeters in size, more than or equal to 4 centimeters in size. Now any tumor which cannot be put into A2, for example, if I say that the depth of invasion is 4 mm, whereas the horizontal spread is 9 mm, then this particular case cannot be put as A2, right? Because both the criteria should be met in order to put it into A2. So therefore we say B1 includes all macroscopic lesions and it includes lesions which cannot be put into A2. So any lesion that cannot be put into A2 but it is microscopic automatically goes into B1, right? So this is stage 1. A and B. Coming to stage 2. Now we say it is stage 2 cervical cancer when upper 2/3 of vagina is involved. When the upper 2/3 of vagina is involved, we say it is stage 2. Again it is divided into A and B. A means without parametria and B means with parametria. The parametrium is this connective tissue that surrounds the uterus and the cervix. So the connective tissue which surrounds the uterus and the cervix is called as parametrium. Now further, A is divided into A1 and A2. I am saying A, so stage 2A, which is involvement of upper 2/3 of vagina without parametrium, is further divided into A1 and A2, where A1 is less than 4 centimeters and A2 is more than or equal to 4 centimeters. So A1 is less than 4 centimeters and A2 is more than or equal to 4 centimeters. Coming to stage 3 cervical cancer. So if we talk about stage 3, it is involvement of lower 1/3 of vagina divided into A and B. A is not reaching the lateral pelvic wall, right? So parametrial invasion began in stage 2B. In A, it is extending into the parametria, but it is not reaching the lateral pelvic wall, whereas 3B is reaching the lateral pelvic wall. With or without lower 1/3 of vagina. So even if the lower 1/3 of vagina is not involved, but it says that the lateral pelvic wall is reached or is involved, then the stage directly jumps to stage 3B. So it is reaching the lateral pelvic wall with or without the lower 1/3 of vagina being involved. Now sometimes in the MCQ the same thing is written indirectly. So what indirect things written mean the same, that is the lateral pelvic wall is involved, right? So the indirect things which indicate involvement of lateral pelvic wall are: number 1, presence of hydroureter and hydronephrosis. Number 2, pain radiating down the lower limb, which means the nerves on that side up till the level of lateral pelvic wall have been reached, or edema of lower limb, which would again mean obstruction of lymphatics on the affected side up till the level of lateral pelvic walls. So these 3 things when written again indirectly mean involvement of the lateral pelvic wall. Talking about stage 4, stage 4 is divided into A and B, where A is involvement of bladder and rectum, and B is involvement of, or we say, distant metastasis, right? B is involvement of distant metastasis. Now, if I tell you that there is a lady who is a known case of cervical cancer, on examination, upper 2/3 of vagina is involved with parametrial invasion, and on CT scan there is hydronephrosis. What is the stage of the disease? What is the stage of the disease? Yes, so please understand, as I told you, CT scan is not allowed for anything else, but it is allowed for hydronephrosis. So the answer to this question will be 3B. Similarly, there is another applied MCQ which says, let us put it in the same sense. So we'll say again, there is a lady who is a known case of cervical cancer, right? So I'm saying the same question again, but I'm going to change something in the question. So I'm saying there is a lady who is a known case of cervical cancer, and how do we know? Distant. That is what we said. It is a clinical staging. So if the patient is manifesting with clinical signs and symptoms, maybe you can do a chest X-ray and you see deposits in the lung. Then can't you find out? Don't tell me that you can see distant metastasis only with CT scan and an MRI. Right? You can do X-rays, you can do bone scans, and you can still find out the distant metastasis, right? So now I'm saying there is a known case of a patient who is a cervical cancer patient, and the upper 2/3 of vagina is involved with hydronephrosis, and on cystoscopy, bullous edema of bladder mucosa is seen. What is the stage of the patient? Now that is what the catch is, right? The answer still remains 3B, and I'm going to tell you why. The answer is 3B because bullous edema of bladder mucosa on cystoscopy does not change the stage. Why? It does not change the stage. Why? Because this only means that lymphatics are obstructed. It does not mean that the bladder itself is involved with cancer, right? So it only means that the lymphatics are obstructed. That is why there is bullous edema of the bladder mucosa. So it is the involvement of the bladder itself which will change the disease and not the edema of the mucosa which changes the stage. Is it clear to everybody? Yes or no? Yes. Okay. So this was the staging of cervical cancer. Once we do the staging, we come to the treatment. Now, when you talk about the treatment of cervical cancer, first the broad terminology is that the primary modality of treatment up to stage 2A. The primary modality of treatment up to stage 2A is surgery. Whereas the primary modality of treatment, any stage more than or equal to 2B, that is when the parametrium is involved, then the answer changes to chemoradiation. By primary modality, what do we mean? It means the first treatment we would like to give to our patient. So if the patient is up till stage 2A, then the first treatment I would like to give her is surgery. If she is 2B or beyond, then I would like to do chemoradiation for her, right? Now, knowing this much was enough about 2 years back, but nowadays they're asking you great details about the surgical part as well as the chemoradiation part. So, we talk about detail in stage-wise manner. What are the treatments available? So we talk about first about stage 1A1. Now when you talk about stage 1A1, we have 3 options for our patient. The options are hysterectomy, conization, and the third option is a new surgery which we have come up with, is called as radical trachelectomy. The new surgery is called as radical trachelectomy. Now, how do we decide which one to do? We have 3 options. So, do we ask the patient कि आज कौन सा कराने का मन है, वही वाली surgery कर देते हैं, right? Do we do that? No. So, we have very specific indications of which surgery is going to be done in which patient. Yes? So, talking about when you should mark answer as hysterectomy, when you should mark the answer as conization, and when should you mark it as radical trachelectomy. No, the concern is not the age, the concern is fertility preservation. So, if childbearing is complete, so patient does not desire any future child, then the answer is hysterectomy. Now please understand, here I am changing the answer according to parity because we are dealing with invasive cancers. We are not dealing with pre-invasive lesions now, right? So if childbearing is complete, the answer is hysterectomy. This hysterectomy is called as type 1 hysterectomy, also called as simple extrafascial hysterectomy, right? So type 1 hysterectomy or simple extrafascial hysterectomy is what we do for stage 1A1 cervical cancer if childbearing is complete. If fertility preservation is required, then we have 2 options. Either we can do conization or we can do radical trachelectomy. Now I am writing RT, but you will write the complete statement as radical trachelectomy, because when you revise, you would read it as radiotherapy, right? So please, you will write the complete statement. So once fertility preservation is required, either conization or RT, radical trachelectomy, can be done. And then the deciding factor is called as LVSI. LVSI stands for lymphovascular space invasion. So if lymphovascular space invasion is absent, conization can be done. If lymphovascular space invasion is present and childbearing is required, then we can do radical trachelectomy, right? So if it is present, we do radical trachelectomy. If it is absent, we do conization. And this conization here is therapeutic conization. Please understand, the indications of conization that we gave before were indications of diagnostic conization. Here it is used as a part of treatment and therefore called as therapeutic conization, right? So radical trachelectomy, if you want to write down a few points about radical trachelectomy, what would those points be? That it is a fertility preserving surgery. It can be done in stage 1A1, 1A2 and 1B1, where the growth or the cervix or the cancer is less than 2 centimeters. So it can be done for stage 1A1, 1A2 and 1B1, where the cancer is less than 2 centimeters. Third, the structures we remove in radical trachelectomy are cervix, parametria, cervix, parametria, pelvic lymph nodes, and a very small part of vagina. So cervix बीच में से निकाल दिया, we are left with uterus above and vagina below, and the two are connected by a cerclage operation. So we put a cerclage between the uterus and the vagina. So this is the radical trachelectomy. Any patient who conceives after radical trachelectomy has to be delivered by a cesarean section. Any patient who conceives after radical trachelectomy has to be delivered by a cesarean section. So this is the treatment of stage 1A1 cervical cancer, right? Coming to stage 1A2. So if we talk about stage 1A2, again, fertility preservation required. So if fertility preservation required, our surgery is going to be radical trachelectomy. Whereas if family is complete and it is stage 1A2, then the surgery we do is called as Werdheim's hysterectomy. Then the surgery we do is called as Werdheim's hysterectomy, also called as type 2 hysterectomy, also called as modified radical hysterectomy. So three names of the same surgery, right? So Werdheim's hysterectomy or type 2 hysterectomy or modified radical hysterectomy is done for stage 1A2. And along with this hysterectomy for stage 1A2, along with this we are going to do pelvic lymphadenectomy. Pelvic lymphadenectomy, by which we mean all the pelvic lymph nodes are going to be removed. Pelvic lymphadenectomy. Coming to the three other operable stages. कौन कौन सी हैं? 1B1, 1B2 and 2A. These are the three other operable stages. In these three stages, the surgery we do is called as Meiggs hysterectomy. It is called as Meiggs hysterectomy, also called as type 3 hysterectomy, also called as radical hysterectomy. So again, three names for the same surgery. Meiggs hysterectomy, also called as type 3, also called as radical. Now Ludhiana, what do you mean when you write, please explain Vardimes? What do you mean by your question? क्या पूछना चाह रहे हो? So till they write, so for these three surgeries, for these three stages, this is what we do. Meiggs or type 3 or radical, right? Now Meiggs, so let me come to that. So don't jump onto questions before we finish the topic, right? So Vardimes has to be compared with Meiggs. Let me finish that and I'll come to the difference between a type 2 and a type 3 hysterectomy, right? So type 3 hysterectomy, also called as radical, and along with this we do a pelvic lymph adenectomy, plus now we add a second thing called as para-aortic lymph node sampling. Now we add to this entire thing a para-aortic lymph node sampling. Now, what are we removing in Vardimes that makes it different from a type 3 or a radical hysterectomy? Now, the points of difference are, number one, in Vardimes hysterectomy, only medial half of parametrium is removed. Only medial half of parametria is removed. Number two, the uterosacrals and Macken rods are cut and ligated midway. The uterosacrals and Macken rods are cut and ligated in the midway. Number three, the uterine artery is ligated. Uterine artery is ligated after it gives the ureteric branch. The uterine artery is ligated after it gives the ureteric branch. And the last point for Vardimes is less than 2 centimeters of vagina is removed. The fourth point is less than 2 centimeters of vagina is removed. Whereas if you talk about type 3, all parametria is removed. The uterosacrals and Macken rods are cut and ligated at their insertion. So all of it is removed. Third, the uterine artery is ligated. The uterine artery is ligated at its origin. So from the internal iliac where it is coming out, at that very point it is ligated. And the fourth point is more than 2 centimeters of vagina is removed. More than 2 centimeters of vagina is removed. Right, so this is what makes type 2 hysterectomy or Vardimes different from a type 3 or Meiggs hysterectomy. Alright, now Ludhiana and Karamsad had asked me a question. Now I'm going to ask you a question to you. Right, my question to you is, what are these structures removed when you are doing a total abdominal hysterectomy? What are the structures removed when you are doing a total abdominal hysterectomy? Option A, uterus alone. Option B, uterus plus cervix. Option C, uterus plus cervix plus fallopian tubes. Option D, uterus plus cervix plus FT plus ovaries. Yes. Tell me. So Karamsad says A. Ludhiana, I am waiting for your answer. What is your answer? Ludhiana says C. And then some of you say D. And sadly, why did I point it out here? Because you want to know the bigger and the bigger and the bigger things which have lesser probability of being asked, whereas you don't know the basics, right? The answer to this question is B. Alright? The structures removed when you're doing a total abdominal hysterectomy is uterus and cervix. So this is what is a TAH. Whereas a subtotal hysterectomy, so and this was last year's MCQ, and almost 50% of the students did it wrongly, right? Whereas when you do a subtotal hysterectomy, then the structure which is removed is only uterus, cervix is left behind. Whereas when you remove all the things, you call it as a TH plus BSO, total abdominal hysterectomy plus bilateral salpingo-oophorectomy, and the other name given to this is pan-hysterectomy. Now can you also tell me why are there two classifications? One I told you is total, subtotal and pan, and then I am giving you another classification called as type 1, type 2, type 3 hysterectomy. Why? So please understand, when you use the terms like TAH, subtotal and TH, these terms are used for benign, hysterectomy is done for benign lesions. When you are doing it for malignancy, the hysterectomies are type 1, type 2, type 3 and so on. So type 1 is simple extrafascial, type 2 is Verdheim's, type 3 is Meig's. Alright? Okay. So this was about the surgical management of the stages. Then there is something called as indications for post-operative radiotherapy. Now please understand, this is not the primary treatment. This is in which conditions I did a surgery, but after the surgery I will have to give radiotherapy as an additional treatment. So the indications are presence of positive lymph nodes. Number 2, presence of parametrial invasion. And number 3, presence of positive margins. So if the margins are positive, if the lymph nodes are positive, and if the parametrial invasion is there and we did a surgery for our patient, then in all these 3 conditions, I will also have to give her a post-operative radiotherapy. Right? Now I come to chemoradiation. So the concept of writing it together is chemoradiation itself means it is concurrent chemoradiation. So both of these things are given together. So we write them together and we give them together. So it means concurrent chemotherapy and radiotherapy to our patient. Right? Now when you talk about chemotherapy, the drug most commonly used for chemotherapy is cisplatin. It is cisplatin. The other drug which may be used in cervical cancer is 5-fluorouracil. Right? When you talk about radiotherapy, now again we have to do it in little more detail. So when you talk about radiotherapy can be divided into 2 types. It can be external beam radiotherapy, also called as EBRT. So external beam radiotherapy, or there can be brachytherapy, which means intracavitary. If we are going to give both the therapies to the patient, then external beam is given first, followed by brachy. External beam means I am going to give radiation from a distance. So when I give external beam radiotherapy, I can give it to the pelvis. So when I give radiotherapy, external beam, I can give it to the pelvis, or I can give it to pelvis and abdomen. When it is given to both pelvis and abdomen, it is called as extended field radiotherapy. Alright, so when it is given to pelvis and abdomen for both, it is called as extended field radiotherapy. Now, when we give external beam radiotherapy, what is the radiation that you give to the pelvis? So, in EBRT, when you give it to the pelvis, we give in total 25 fractions of radiotherapy. We give 25 fractions of radiotherapy, and this is distributed over a period of 5 weeks. Each fraction measures 1.8 to 2 grays, and therefore the total dose given to pelvis in EBRT is 40 to 50 grays, and this was your this year's AIPG question, right? Similarly, if I am giving EBRT to the abdomen, again we give 25 fractions distributed over 5 weeks, but here each fraction is going to be 1 to 1.2 grays, and therefore the total dose of EBRT to the abdomen is 25 to 30 grays. The radioisotope used for EBRT is cesium. The radioisotope used for EBRT is cesium. If you talk about brachytherapy, the brachytherapy is given at 2 points, point A and point B. And everything about these points is an MCQ, which is, what is the location of point A? So first point is the location. Point A is located 2 centimeters lateral to the uterine canal and 3 centimeters above external os. So 2 centimeters lateral to the uterine canal and 3 centimeters above external os. Point A corresponds to 2 structures. It corresponds to ureters and it corresponds to the paracervical lymph nodes. Third, the radiation dose at point A is 8000 centigrays. Point B lies 3 centimeters lateral to point A. So it lies 3 centimeters lateral to point A, which means 5 centimeters from the uterine canal, and again 3 centimeters above external os. So 3 centimeters lateral to point A and 3 centimeters above external os. Point B corresponds to obturator lymph nodes. And the radiation dose at point B is 6000 centigrades. Radiation dose at point B is 6000 centigrades. Now, this is one basic way of giving it. But then there is another criteria that are given by ABS. ABS stands for American Brachytherapy Society. So if you talk about the ABS, ABS says the radiation dose in early stage cancer to point A and advanced stage cancer to point A. So the radiation dose in early stage is 80 to 85 grays, and that in advanced stage is 85 to 90 grays. So this is according to the ABS. To point B, again divided into early and advanced. 50 to 55 grays in early and 55 to 60 in advanced. ABS refers point B as lateral pelvic wall. ABS refers the point B as lateral pelvic wall. Now when we are saying we are going to give, okay, first let us talk about the radioisotopes here. So when you talk about radioisotopes in brachytherapy, it depends on your nature of treatment, which means if you are giving a low dose therapy, then the answer remains cesium. Whereas if you are giving a high dose therapy, then the answer is iridium. So for high dose, the radioisotope is iridium. For low dose, it is cesium. Also, when you say you're going to give radiation therapy to the pelvis, what are the borders? So the upper border is the disc space between L4 and L5. The upper border is the disc space between L4 and L5. The lateral border lies 2 centimeters lateral to bony canal. And the lower border lies at the lower margin of obturator foramen. Alright. Also, when we say pelvic radiotherapy, all the lymph nodes in the pelvis are to be irradiated. All the lymph nodes, be it internal iliac, be it external iliac, be it obturator, be it presacral, be it common iliac. So all the lymph nodes in the pelvis are irradiated when you say you're giving radiotherapy to the pelvis, right? When you give extended field radiotherapy, okay, so when we give extended field radiotherapy, all the borders are same except the upper border. The upper border in extended field radiotherapy shifts to disc space between T12 and L1. It shifts to disc space between T12 to L1. Extended field radiotherapy is given when para-aortic lymph nodes are positive. Extended field radiotherapy is given. Extended field radiotherapy is given when para-aortic lymph nodes are positive. Please understand, if they ask you what is the stage of cervical cancer, if inguinal lymph nodes are positive, then it is considered as stage 4B. Inguinal lymph nodes in case of cervical cancer are considered distant metastasis. Inguinal lymph nodes in cervical cancer are considered distant metastasis. Finally, what do we do with recurrent cancer? If we are dealing with a recurrent cervical cancer, then the treatment depends on the primary modality of treatment. So if the primary modality of treatment was surgery, then for recurrent cancer we will give radiotherapy. If the primary modality of treatment was radiotherapy or chemoradiation, then for recurrent cancer, if the patient is operable, then the surgery that we do is called as total pelvic exenteration. The surgery which you do for recurrent cervical cancer is called as total pelvic exenteration. In this surgery, we remove almost every structure from the pelvis. It is a very, very debilitating surgery. It has poor survival rates, and majority of times when you tell about this surgery to a patient, they refuse to undergo this surgery. But yes, you should know it, that once you have given chemoradiation and there is a recurrence, and if the condition of the patient is that she can be operated upon, then we can do a surgery called as total pelvic exenteration. There is nothing much to repeat in this. All I said, the treatment for recurrent cancer is going to be reverse of the primary modality. So if the primary modality was surgery, then for recurrent cancer you give radiotherapy. If the primary modality is chemoradiation, then for the recurrent cancer, the condition is total pelvic exenteration. But for that we need that the patient ki condition should be such that she can be operated upon. Because what happens after radiotherapy, the general condition of the patient is usually quite poor. There is a lot of adhesion in the pelvis, or in the field of radiotherapy, there are a lot of complications, and quite a lot of times the patient cannot be reoperated upon. So the idea is that if she is operable, then yes, you can do another surgery. The surgery is called as total pelvic exenteration, right? So this is what we're going to do for cervical cancer. Okay. The next thing we're going to do is ovarian cancer. If inoperable, then you can't do anything. Then we say that we can give you chemotherapy. But chemotherapy is only palliative for recurrent cancers. Do you understand the meaning of palliation? Palliation means it is only going to give you symptomatic relief. It is not going to prevent the spread, or it is not going to do anything. It is just going to give you symptomatic relief. So if nothing can be done, then yes, you can give a chemotherapy as palliation. Alright? Okay. So what I said is that the next malignancy we're going to take up is going to be ovarian cancer. The finding in a patient which raises the suspicion, the finding in a patient which raises the suspicion of ovarian cancer is the presence of an adnexal mass. So for ovarian cancer, there are no pre-invasive lesions, but the lesion which when present raises the question that whether it is benign or malignant is the presence of an adnexal mass in a patient. Therefore, whenever I come across any patient and I find an adnexal mass in my patient, the only thing I am concerned about is this mass benign or is it malignant? So, what are the general features which point towards the benign nature? And what are the general features which talk about the malignant nature of the mass? Now, these are what I am going to write are general things, but there are going to be exceptions to everything, right? So this is not a hard and fast rule. There can be exceptions to every point we write, but this is a generalization that we are making. So when you say benign masses, the benign masses are usually present in the reproductive age group. Whereas malignancies are usually present in extremes of age. So they are either present in adolescents or they are present in extremes of age, post-menopausal women. Second, benign masses, patient may quite often give you a history of pain, whereas malignancies are painless until they are really advanced stage when the pain is because of involvement of many other structures, right? So malignant masses tend to be painless, whereas benign masses tend to be painful. On examination, the same finding is converted into tenderness. So the benign masses can be tender, whereas malignancies are non-tender. Also, benign masses have more tendency to be unilateral. Benign masses have a higher tendency to be unilateral, whereas malignancies have a higher tendency to be bilateral. When I examine, a benign mass usually has cystic consistency. A benign mass usually has cystic consistency, whereas malignant masses have variable consistency. Which means when I touch them at one point they may appear cystic, and when I touch them at the other point they may appear firm or even solid for that matter. The investigation of choice is an ultrasound. What are the findings on ultrasound which are suggestive of malignancy and therefore are called as high risk findings? So what are the findings on ultrasound which are called as high risk findings? So the first finding is presence of solid components. So even if the mass is cystic in consistency, but it has areas of solid components, it raises or it is a high risk feature for malignancy. Presence of thick septations. So we say that the malignant masses tend to be multilocular, but the more important feature of multilocularity which points towards malignancy is thick septations. And septations which are 2 to 3 mm or more than this thick are called as thick, right? Or they have suspicion of malignancy. The third high risk feature is presence of papillary projections. So presence of papillary projections inside or on the surface is indicative of high risk of malignancy. Fourth, adnexal mass which is associated with ascites. So if we have an ovarian mass and along with this in the abdomen there is ascites, again it is a high risk for malignancy. The last point being presence of enlarged lymph nodes, and matted bowel loops. So presence of enlarged lymph nodes and matted bowel loops again is a high risk feature for malignancy. So these 5 things when seen on ultrasound are indicators of high risk of malignancy. There are certain indications on another investigation which is called as a Doppler. So what is the high risk feature on Doppler? So on Doppler, malignant masses show high vascularity. Malignant masses show high vascularity. The technical way of writing high vascularity is a low RI and a low PI, where RI stands for resistive index and PI stands for pulsatility index. Right? So low RI, low PI again means high risk for malignancy. Now the primary concern is to know whether it is benign or malignant, because we want to know what are those masses for which the management is surgery, right? So what are the indications where ovarian masses would be managed surgically, or answer to your question is going to be a surgery. Now, the first indications for surgical intervention, alright, before I go to the indications. Now, when I say surgery, I really mean surgery. So, it may be laparoscopy, it may be a laparotomy. Now, why do I say that? Because in India, we still stick to laparotomy for malignancy surgeries. While abroad, they're all shifting now to even laparoscopy for even malignant surgeries. So, we are writing in general terms surgery. It may be laparoscopic, it may be a laparotomy, right? Now, indications for surgical management are: number 1, any mass with high risk features on ultrasound. So when we say any mass, it means irrespective of the age, irrespective of the size. So irrespective of age of the patient and irrespective of size of the mass. If the mass has any of the high risk features which we just wrote on ultrasound, then the answer to your question is going to be a surgery, right? Second, the second criteria is the size. And we say any ovarian mass more than 7 centimeters. So for ovarian mass, the cutoff for surgical intervention is 7 centimeters. So any ovarian mass which is more than or equal to 7 centimeters requires surgical intervention, right? Then any adnexal mass more than or equal to 10 centimeters. Now we have different cutoffs for adnexal masses and ovarian masses, because ovarian mass we know means we are aware of the site of origin, it is the ovary. When we say adnexal mass, it may be anywhere, it may be a tubo-ovarian mass, it may be only a tubal mass, right? So we are not sure what is the source of origin, and then we call it as an adnexal mass. And the criteria for adnexal mass is 10 centimeters. Third, any mass in postmenopausal women, any mass in postmenopausal women with raised CA 125. So irrespective of the size, if CA 125 is raised in a postmenopausal woman with an ovarian mass, it calls for surgical intervention, right? It calls for surgical intervention. Fifth indication, any mass which presents as, or fourth indication, any mass which presents as acute abdomen. Now a mass can present as acute abdomen in two conditions. Either it undergoes torsion or it undergoes rupture. So either it undergoes torsion or rupture. In both the cases, the mass has to be managed by a surgical, because there is no other management for acute emergency, right? So these are the indications which we follow to mark surgery as the answer. Now the same indications would be applied in pregnancy as well. So in pregnancy, we usually do not touch the ovarian masses, right? The conditions we would do surgery would be any of these. Along with these, in pregnancy we write any rapidly enlarging mass. So if it is in a pregnant female, other than all these conditions, the indication for surgery would be any rapidly enlarging mass, right? Any rapidly enlarging mass. All right. Now, if you talk about women in the reproductive age group and presence of adnexal mass or ovarian mass, so if the woman is in reproductive age group and she has an ovarian mass, then if the mass is between 3 to 5 centimeters, we don't do anything. Nothing is required. So what we only do is observation. Whereas if the mass lies between 5 to 7 centimeters, then what we do is a transvaginal ultrasound, or simply an ultrasound is done every 6 weeks. So we follow up the patient with ultrasounds every 6 weeks to see whether the mass is growing, regressing, or has it developed any malignant change, right? Please remember, there is no role of routine oral contraceptive pills for treatment of ovarian mass. There is no role of routine OCPs to be prescribed in a patient with ovarian mass. Why? Because oral contraceptive pills only help in prevention of appearance of new masses. They don't cause regression of current mass. So presence of only a mass is no indication to put the patient on OCPs. Yes, if there are other indications, for example, irregular cycles, or if there is pain during the cycles, then yes, oral contraceptive pills can be prescribed. But otherwise, if it is just a coincidental ovarian mass or a cyst in the ovary, then there is no need to prescribe OCPs. Only if the question goes ahead and mentions things which form other indications to give OCPs, then you should mark routine OCP as the, or OCP as the next answer. Right? So this is how we talk about ovarian masses in the reproductive age group. Also, a second point which is very important for reproductive age group women is there is no role of CA 125. There is no role of CA 125 in reproductive age women. CA-125 is used only for post-menopausal women where it becomes very significant. It has no role in reproductive age women. Why? I'm just going to tell you. Normal value of CA-125, how much is it? What is the normal value of CA-125? Anybody? Hanji, koi hai? Are you all there? No, you're not there. Where are you? So the normal values, you're all lost. Yes, the normal value of CA-125 is 35. Yes, the normal value of CA-125 is up to 35. Anything more than 35 is called as raised. Right? So anything more than 35 is called as raised. Is OBGY acting like a sleeping pill for all of you? Yes? Is it a sedative, hypnotic? What is it? No. Yes, yes, yes. Okay. Go outside for a second. It's not a break. Just go outside, get a cup of tea and come back. Morphine. OMG. All right. So now why I'm saying is that CA-125 is not effective in reproductive age women because there are a lot of benign conditions in which it is raised, as well as a lot of malignant conditions in which it is raised. So what are the benign conditions in which CA-125 is raised? It is physiologically raised during menstruation. It is raised in pelvic inflammatory disease. It is raised in patients with endometriosis, endometrioma. It is physiologically raised during pregnancy. Yes, it is raised in genital tuberculosis. It may be even raised in a fibroid uterus. And it is raised in any abdominal condition with itis. So, whether you say hepatitis, whether you say pancreatitis, so inflammation of the abdominal organs, CA-125 can be raised. So even if we order this investigation in a reproductive age women, we are nowhere because there are n number of conditions which can cause a raised CA-125, right? What are the malignancies in which it is raised? So if we talk about malignancies, then it can be raised in ovarian cancer. It is also raised in advanced stage endometrial cancer, also raised in colon cancer, pancreatic cancer, breast cancer, lung cancer. So there are so many cancers. Yes, it may even be raised in hepatocellular carcinoma in advanced stages. So even HCC, right? So there are so many cancers in which it can be raised. So again, it is of no value in reproductive age women. That is why we don't do it as a first line investigation in reproductive age women. So this was about adnexal masses. Mind you, we haven't even started ovarian cancer as of now. So as I said, adnexal mass is like a pre-invasive lesion. It is not actually a pre-invasive lesion, but for a gynecologist, it is of prime concern, right? Now we come to ovarian cancer proper. And when you talk about ovarian cancer, the first thing we're going to talk about is risk factors. So there are two etiopathogenesis of ovarian cancer. One is more the number of ovulatory cycles, more is the risk. And the second is high local estrogen content, right? So based on these, if we try and enumerate the risk factors, it will be early menarche, late menopause, early menarche, late menopause, nulliparity, obesity. It is related to BRCA1, BRCA2 and HNPCC. Also related to polycystic ovarian syndrome. Also related to polycystic ovarian syndrome. So these are all the conditions that act as risk factors for for ovarian cancer, right? The next thing we talk about is what are the protective factors. So what are the protective factors for ovarian cancer? Multiparity, breastfeeding, multiparity, breastfeeding, oral contraceptive pills, salpingectomy, tubal ligation, and even hysterectomy. So all these are protective factors and the risk factors for ovarian cancer. If we talk about smoking, then please remember, smoking is a risk factor only for mucinous type of ovarian cancers. Smoking is a risk factor only for mucinous type of ovarian cancer. One important risk factor that I've missed is hormone replacement therapy. So hormone replacement therapy is also a risk factor for ovarian cancer. Now, once you talk about ovarian cancers, the most common type of ovarian cancers are epithelial ovarian cancers. So I'm going to give you certain general points about epithelial ovarian cancers. I said they are the most common and they account for 90 to 95% of all ovarian cancers. What all is included in epithelial ovarian cancers? Serous type, then mucinous, endometrioid, clear cell, and Brenner's. Out of these, most common is serous. They account for 70% or rather 75% of all ovarian cancers, of all epithelial cancers. Mucinous and endometrioid both constitute 10-10%. Mucinous and endometrioid constitute 10-10%, and the rest would be formed by clear cell and Brenner's. Epithelial ovarian cancers most commonly occur in postmenopausal women. The peak age incidence is the 6th and the 7th decade of life. They present with vague abdominal symptoms like nausea, vomiting, abdominal pain, then altered bowel habit, later maybe anorexia, right? So they present with vague complaints, and what happens is that these ladies, they keep going to their family physicians or general practitioners, and they are diagnosed with gastritis or irritable bowel syndrome and so on, till one fine day they develop a big ascites, then they're either sent for ultrasonography or they're sent to a gynecologist, right? So that is the reason why epithelial ovarian cancers are diagnosed in late stages. They carry the highest mortality rate. In fact, ovarian cancer carries the highest mortality rate among all genital cancers, right? Then most of the epithelial ovarian cancers are sporadic. So most of them are sporadic. The mucinous ovarian cancers differ from the serous in certain aspects. What are those aspects? The mucinous tend to be unilateral. So how they are different from serous is they tend to be unilateral. They remain confined to ovary for a long time. So they remain confined to the ovaries for a longer time. They have higher tendency to be unilateral as compared to serous. The third point is they attain huge sizes. They attain huge size. They can reach even up to 20 centimeters. Lastly, they are associated with a condition called as pseudomyxoma peritoniae. Pseudomyxoma peritoniae. Next, now I said that mostly epithelial ovarian cancers are sporadic. Then automatically they want to ask you, what percentage of epithelial ovarian cancers are familial? And the answer is 10%. So only 10% are familial. These are the ones which are associated with the genes BRCA1, BRCA2 and HNPCC. The lifetime risk of developing ovarian cancer is highest with BRCA1. It is as high as 35 to 45%. The lifetime risk of developing ovarian cancer with BRCA2 is up to 25%. So we say between 15 to 25%. And with that HNPCC it is up to 15%. Now these are called as familial ovarian cancers, and therefore these are the ones for who we do screening. So screening for ovarian cancer is done when in women with history of breast cancer in the family, history of ovarian cancer in the family, or who are known positive cases of BRCA1, BRCA2 and HNPCC. The screening is done by combining two approaches, which is transvaginal ultrasound and CA125. The screening begins at the age of 35 years. And the treatment for these familial ovarian cancers, or what we can do for the patients with histories of familial ovarian cancers, is called as a risk reducing surgery, and this is a prophylactic BSO. So we do a risk reducing surgery called as prophylactic bilateral salpingo-oophorectomy. This is the first line treatment or prophylaxis that can be given to these patients. Bilateral salpingo-oophorectomy. If a patient is not willing for BSO or her family is not complete, at what age? I'm coming, don't rush. You want me to rush? So, I forgot what I was telling you. Right, so the first line treatment is BSO. In case the patient refuses a BSO or the family is not complete, then the second line treatment for these patients are oral contraceptive pills. Right? So OCPs are never a first line answer. The answer for the first line treatment is a prophylactic BSO. Now ideally, BSO should be done at 35 years of age. Ideally, here even I am writing everything. I don't think I'm fast. Anyways, I'll slow down if you want me to. Right? So I'm saying the ideal age for a bilateral salpingo-oophorectomy is 35 years of age. See, please understand, when I am dictating, I am not only dictating, I am writing every single word I say. Right? I don't even use short forms. The first time I use a short form, I write the full thing. So I'm writing is as much as you are writing. I'm not writing less than you, right? So anyways, I'll go a little slow, that's not an issue. So ideally, BSO should be done at 35 years of age, because beyond 35 years, every year the risk of developing cancer increases. Every year the risk increases after 35 years of age, and that is why the ideal age to do a prophylactic BSO is 35. But आजकल के ज़माने में by 35 years of age, most of the times the family is not complete. For example, medicos, right? So we say that the BSO can be done either at 35 or as soon as family is complete, or as soon as the family is complete. Now I said that the risk increases every year after 35 years of age, and the peak age incidence for familial ovarian cancers is a decade earlier than other epithelial cancers. So the peak age incidence here is seen in 4th to 5th decade of life. Right? Okay. So this is what is familial ovarian cancers. Now another thing before I forget. Once we do a bilateral salpingo-oophorectomy, there is no further risk of ovarian cancer. But these patients still have risk of a condition called as peritoneal carcinomatosis. So these patients can still develop peritoneal carcinomatosis. They also ask you, if I do a BSO in a patient who is carrying the BRCA genes, by what percentage is the risk of breast cancer also reduced? Then we say that the risk of breast cancer after doing a BSO or a prophylactic BSO is reduced by 50%. So it is protective for both ovarian cancer and breast cancer. Right? There is another entity called as borderline epithelial. Now, Please understand, we are just adding one word in front of epithelial ovarian cancers and it is borderline, and it changes so many things. What all does it change? Borderline epithelial cancers are like epithelial cancers, but the way to differentiate them is absence of stromal invasion. So borderline epithelial cancers do not show stromal invasion. Therefore, we say that borderline epithelial cancer is a histopathological diagnosis. Again, borderline epithelial cancers occur a decade earlier than the epithelial cancers. The borderline epithelial cancers metastasize late, so they remain confined to the ovary for a long time. They have better prognosis than epithelial ovarian cancers, and for all these reasons, borderline epithelial cancers of the ovary are managed by a conservative surgery. What it is, we'll come to it a little later. So they are managed by a conservative surgery. So these were the general features of epithelial ovarian cancers. We come to the general features of the next type of ovarian cancers, which are germ cell tumors. Germ cell tumors constitute 5% of all ovarian cancers. These include dysgerminoma, mature and immature teratoma, embryonal cell cancer, endodermal sinus tumor, which was previously called as yolk sac tumor, choriocarcinoma. Germ cell tumors are most commonly seen in 10 to 30 years of age. So they are most common in adolescent age groups. Peak is between 10 to 20 years, right? They present again with vague abdominal complaints. But along with this, they may present with precocious puberty or acute abdomen because they are rapidly growing tumors. Since they are so symptomatic, germ cell tumors are diagnosed in early stages. They also metastasize late. Germ cell tumors tend to be unilateral. They are also managed by conservative surgery. They are also managed by conservative surgery. So this was about the second type of tumors in the ovary, that are germ cell tumors. Then we talk about the third type of tumors in the ovary. Which are sex cord tumors. Again, if we talk about the general principles, the sex cord tumors are least common of all ovarian tumors. They can occur at any age. They can occur at any age, but they are most common at perimenopausal age. So they can occur any time, but the most common age group is perimenopausal. They also tend to be unilateral. They metastatize late. They have no relation to BRCA genes. The cancers included here, or the tumors included here, are granulosa cell tumor, theca cell tumor, Sertoli-Leydig tumor, fibroma thecoma group, and thecomas separately as well. Patients with with sex cord tumors have high tendency to develop a second malignancy, which is endometrial cancer. The sex cord tumors again will present with vague abdominal complaints. But along with this, they also present with abnormal uterine bleeding or virilization. Since they are again more symptomatic, they are diagnosed in early stages. So these are the general features about the three types of ovarian cancers. What we are going to write down next are going to be loads of one-liners, because lots and lots of them are asked from ovarian cancer. They are very scoring, and the problem with them is that either you know them or you don't know them, right? So there is nothing like a tukka. Second reason, that they are given in a very shabby manner in your guides. So you have absolutely non-reliable answers there. So we're going to write this down, and since these are purely one-liners, so I'm just going to give it to you. I'm going to write it down as well. Right? So how many of you have aching hands? All right. All of us have. Me. Me too, but then what to do, right? We have to study. So next what we talk about is, I said plenty of one-liners, and we start with certain statements. The statements are, which is the most common ovarian cancer? It is, the most common ovarian cancer is serous cyst adenocarcinoma, serous cyst adenocarcinoma. But if the question changes and it says which is the most common benign ovarian tumor, then it is serous cyst adenoma. Which is the most common ovarian tumor in pregnancy? The answer is dermoid. And which is the most common ovarian cancer in pregnancy? It is dysgerminoma. Now, had you all been sitting in Delhi, normally this part of the class is played as a rapid fire round, and whoever answers the maximum questions here gets a chocolate hamper from my side. But unfortunately, you all are very, very far away, and I cannot distribute chocolate hampers, right? So the most common tumor in pregnancy is dermoid, and the most common ovarian cancer in pregnancy is dysgerminoma. Now I said that the germ cell tumors are usually unilateral, right? Then they will ask you which germ cell tumor has highest risk of bilaterality. Which germ cell tumor has highest risk of bilaterality? It is a dysgerminoma. Okay, now focus on your studies. We'll get the coffee hamper later. Oh, sorry, not the coffee, the chocolate hamper. The risk of bilaterality in a dysgerminoma is 10 to 15%. In some books, it is quoted as high as 20%. So the risk of bilaterality in a dysgerminoma is 10 to 15%, whereas the risk of bilaterality in a dermoid is 10%. So it is less than 10%, right? Which tumor has highest risk of torsion? And the answer is dermoid. Which tumor has highest risk of torsion? The answer is dermoid. Now for dermoid, we say that a dermoid is almost always benign, right? So we say that the dermoid is almost always benign, and that is why they will ask you what is the risk of malignancy in a dermoid? What is the risk of malignancy in a dermoid? Oh no, 4 is too high. So the risk of malignancy in a dermoid is 0.2 to 2%. Please remember, it is always less than 2, not even equal to 2. It is less than 2%. And if a dermoid develops cancer, which cancer is it going to develop? The answer is squamous cell cancer, right? The answer is squamous cell cancer. Which is the most rapidly growing ovarian tumor? The answer is endodermal sinus tumor or yolk sac tumor. That is the reason why endodermal sinus tumor presents as acute abdomen. So they ask you which ovarian tumor presents as acute abdomen. The answer is endodermal sinus tumor or yolk sac tumor. Which germ cell tumor has worst prognosis? So worst prognosis is endodermal sinus tumor. And which germ cell tumor has best prognosis? It is a dysgerminoma. Then we say that dysgerminoma is the radiosensitive tumor of the ovary? So this was an old question. Which tumor is radiosensitive? The answer is dermoid. The newer, dysgerminoma. The newer question is, how do you describe the radiosensitivity of a dysgerminoma? So we described it as moderately radiosensitive. We describe it as not highly but moderately radiosensitive. Which tumor of the ovary involves opposite ovary by metastasis? Now please understand that this is different from bilaterality. So which tumor of the ovary involves opposite ovary by metastasis? The answer is granulosa cell tumor. Which tumor or ovarian tumor has increased risk of endometrial cancer? Again, the answer is granulosa cell tumor. Again, the answer is granulosa cell tumor. What is the counterpart of a dysgerminoma in a male? The answer is seminoma. The male counterpart for a dysgerminoma is seminoma. Then they ask us, or if they ask us, dysgerminoma is frequently associated with another cancer. Name it. And the answer is gonadoblastoma. So dysgerminoma and gonadoblastoma quite a lot of times coexist, right? Finally, what is Meigs syndrome? Meigs syndrome is the triad of ovarian fibroma along with ascites and pleural effusion. And once you remove the fibroma, so once the fibroma is removed, the ascites and pleural effusion, once the fibroma is removed, the ascites and pleural effusion resolve on their own. So it resolves spontaneously. Also, the pleural effusion that is seen in Meigs syndrome, yes, I'm coming to it. Yaar, tum log bahut badmash ho. So you want to jump onto stuff, and when I jump, then or I go fast, then you scold me. So pleural effusion is more commonly seen on the right side, but that is not a diagnostic criteria, right? So it is not necessary that only if it is on the right side it is Meigs syndrome. It may be on right or it may be on the left, but it is more commonly seen on the right side. Okay? What is pseudo-Meigs? Pseudo-Meigs is when there is the same triad or when there is ascites and pleural effusion, but not associated with ovarian fibroma. It can be associated with any other tumor, right? The tumor may be epithelial tumor, it may be a metastatic tumor, it may be granulosa cell tumor. So anything other than fibroma, because Meigs syndrome was classically described for an ovarian fibroma, right? So if it is anything else along with effusion and ascites, it is pseudo-Meigs. Okay? So the next set of one-liners, we're not over yet. So the next set of, which center knew the maximum of them and which knew the least? Be honest. So the next set of one-liners, we talk about special cell types that are seen. So you are given those names of these cells and you're asked where are these cells seen. So the first type of cells that we are going to, you can see the slide later, Jammu, right? We're going on to the next thing, and the next is special cell types that we can see, right? So the first I'm saying is signet ring cells. The signet ring cells are seen in Krukenberg's tumor. A Krukenberg's tumor is metastatic tumor of ovary. The Krukenberg's tumor is the metastatic tumor of the ovary. The most common primary for Krukenberg's tumor is stomach cancer. Agroha, what are you trying to write? I don't know. Most common primary is stomach cancer. Since Krukenberg's tumor is a metastatic tumor, that is why we say that the shape of ovary is well maintained. It is not destroyed. So the shape of ovary is well maintained. What do you want to ask me? Whether the ascites is a transudate or an exudate? So for me the better answer is transudate, although I don't have any reference for this question of yours, right? Either ways, if you talk about the ascites or the effusion, it has to be a transudate. Why should it be exudative? Right? But our OBGY books don't give it like that. But the better answer, as far as I am concerned, is a transudate. Right? The shape of the ovary is well maintained, and since it is a metastatic tumor, it is always bilateral. It is always bilateral. The next type of cells that we come to is, so first type was signet ring cells seen in Krukenberg's tumor. The next type of cells are called as Samoma bodies. The Samoma bodies are seen in serous type of ovarian tumors. The next are Schiller-Duval bodies. SCHILLER. Schiller-Duval bodies are seen in endodermal sinus tumor or yolk sac tumor. Alright, very good, Belgaum. Rokitansky protuberance. Rokitansky protuberance is seen in a dermoid. Karl-Exner bodies. The Karl-Exner bodies are going to be seen in granulosa cell tumors. Good, Mysore. Walthered cell nest. Walthered cell nest are seen in Brenner's tumor. Finally, Rinke's crystal seen in Leydig cell tumor or Hylas cell tumor. So Rinke's crystal could be seen either in the Leydig cell tumor or the Hylas cell tumor. The next set of one-liners are going to be from tumor markers. Okay. So what is the tumor marker for a serous cyst adenocarcinoma? It is CA125, or there is a new tumor marker which is HE4. HE4 stands for Leydig and Hylas. It is not hilar, Leydig and hilous cell tumor. I told you hilous cell tumors are found in the ovarian stroma and they resemble the Leydig cell tumor, right? So HE4 is a new tumor marker called as human epididymal protein 4. Human epididymal protein 4, and it is more specific for epithelial ovarian cancers as compared to CA125. So it is more specific than CA125. The tumor marker for mucinous is CEA, carcinoembryonic antigen. The tumor marker for dysgerminoma, the single best answer is LDH, but it also releases HCG and placental alkaline phosphatase. So the best answer is LDH, but it will also release HCG and placental alkaline phosphatase. The tumor marker for granulosa cell tumor is inhibin. The tumor marker for choriocarcinoma is HCG. The tumor marker for embryonal cell cancer is both HCG and alpha fetoprotein. The tumor marker for endodermal sinus tumor, the tumor marker for endodermal sinus tumor is again the single best answer is alpha fetoprotein, but it also secretes LDH, but it does not secrete HCG, right? So it also secretes LDH but not HCG. Then the tumor marker for dermoid and fibroma is none. So this is a googly question. A dermoid and a fibroma do not release any tumor marker, right? They do not release any tumor marker. Right, so with this we come to an end with the rapid fire round and all the one-liners that we had to do. The next thing we are going to talk about is going to be staging for ovarian cancer. I know it's a handache, but what do? What we can do is just finish ovarian cancer first. Oh, Gorakhpur, I'm not going too fast. Bache, how slow do you want it to be? Right? You'll have to improve your speed of writing. These were just factual things. There is nothing conceptual that I was telling you that you can say that I'm going fast. Right? 2 minutes break. Now, are you going to prepare Maggie in that 2 minutes? Tanda? So we'll finish ovarian cancer and then only we can take a break. Okay? हाँ यार क्लास 9 बजे तक है बीकानेर. Yes. So ovarian cancer. अरे क्यों खत्म कर दूंगी? Ovarian cancer staging is given by FIGO, again International Federation of Obstetricians and Gynecologists. And the difference here is that it is surgical staging. So cervical cancer was clinical, this is surgical staging. Bikaner, why are you saying like this? आप 7 बजे तक खत्म कर दोगे? क्यों खत्म करना है? Oh. Okay. Coming to stage 1 ovarian cancer, it is divided into A, B and C, right? So stage 1A ovarian cancer is when unilateral ovary is involved. So when unilateral ovary is involved, it is stage 1A ovarian cancer. 1B is when bilateral ovaries are involved. 1C is described as A or B with any of the following. A or B with any of the following, which includes number 1, tumor on the surface of ovary. Number 2, ruptured capsule. And number 3, presence of malignant ascites. So if any of these 3 conditions are present, then automatically the stage jumps to C, irrespective of whether it is unilateral or bilateral, right? Stage 2 ovarian cancer, again divided into A, B and C. 2A is when uterus and fallopian tubes are involved. 2B is other pelvic structures involved. And 2C is again A or B with any one of the following, which remains the same, that is tumor on surface, ruptured capsule, or malignant ascites. Right, so this is stage 2A, I mean 2, A, B and C. Coming to stage 3. Again divided into A, B and C. A is microscopic deposits on peritoneal surface. B is macroscopic deposits but less than 2 centimeters. 3C is divided into C1 and C2. C1 is macroscopic deposits on peritoneum which are more than or equal to 2 centimeters. And 3C2 is any positive lymph nodes. These lymph nodes can be pelvic lymph nodes, they could be para-aortic lymph nodes, or they could be inguinal lymph nodes. So any positive lymph nodes changes the stage to 3C2. Stage 4 is described as distant metastasis or tumor in the liver parenchyma. Now please understand, when the peritoneum on the surface of the liver is involved, it will be 3A if it is microscopic, right? But if the nodule is inside the parenchyma of the organ, then it is advanced or distant metastasis called as stage 4. Stage 3 and 4 are also called as advanced stage disease. Okay, we're doing ovarian cancer, Safai, right? So stage 3 and 4 are called as advanced stage disease, and most common mode of spread of ovarian cancer is called as tumor exfoliation. The most common mode of spread of ovarian cancer is tumor exfoliation. Now I said ovarian cancer is or the staging of ovarian cancer is surgical staging. So the procedure we do is called as staging laparotomy. In this procedure, we are going to treat the patient as well as stage. So we are doing only one procedure and we are going to do both the things, staging as well as treatment. So what are the steps of staging laparotomy? Number 1, a midline vertical incision. Number 2, ascitic fluid sampling. If ascitic fluid is not present, we can do a saline wash. So ascitic fluid sampling or a saline wash. Number 3, inspection and palpation of all abdominal organs. Number 4, random peritoneal biopsies. Number 4 is random peritoneal biopsies. These biopsies should specially be taken from the following areas: paracolic gutters, pouch of Douglas, and from the surface of diaphragm. Instead of a biopsy, we can also take scrapings from the surface of the diaphragm, so that is also allowed, right? Next point after taking biopsies is doing a TAH with BSO. So we do a total abdominal hysterectomy with bilateral salpingo-oophorectomy, and the TAH that we're going to do here is type 1 hysterectomy. It is going to be a type 1 hysterectomy. Next step is an infracolic omentectomy. Now when we say infracolic omentectomy, it means the entire omentum which is hanging down from transverse colon, has to be cut. Please, this is different from an omental biopsy. A biopsy would mean a small specimen, but we're not taking a small specimen. The entire omentum hanging from transverse colon has to be sent for histopathology, right? Infracolic omentectomy. Then we do pelvic and para-aortic lymph node sampling, pelvic and para-aortic lymph node sampling, and finally closure of the abdomen. So these are the steps of a staging laparotomy, and I am saying we are doing both staging as well as the treatment. Now if they ask you or let me first write down something else. Indications for post-operative chemotherapy. Indications for post-operative chemotherapy. Now for epithelial ovarian cancers, this is the rule we follow. All stages except stage 1A and 1B grade 1. All stages except stage 1A and 1B grade 1 need post-operative chemotherapy. The chemotherapy which we give for epithelial ovarian cancers is paclitaxel and carboplatin. The drugs used are paclitaxel and carboplatin. We give 6 cycles of intravenous chemotherapy. We give 6 cycles of intravenous chemotherapy. As far as germ cell tumors are concerned, the rule that we follow is even early stage cancers, for germ cell tumors I am saying the rule that we follow is even early stage cancers need chemotherapy, and for sex cord tumors the rule that we follow is only advanced stages need chemotherapy. The drugs used in the chemotherapy for germ cell tumors and sex cord tumors are BEP, bleomycin, etoposide and cisplatin. Now if I ask you what should be the primary modality of treatment in advanced stage ovarian cancer, option A surgery, option B chemo, option C radiotherapy, option D chemo plus radio. What is the primary modality of surgery, primary modality of treatment for advanced stage ovarian cancer? So Kota and Haldwani are right, so is Visakhapatnam. So irrespective of the stage of the cancer, the primary modality of treatment has to be a surgery. So the surgery, just the difference is that the surgery which you do in stage 3 and stage 4 is called as a debulking surgery. Why? Because we try and remove the maximum tumor load possible and then we give chemotherapy. But the primary modality of treatment has to be a surgery, right? What are the indications for fertility preserving surgery in ovarian cancer? Indications for fertility preserving surgery in ovarian cancer are: number 1, stage 1A and patient desires future pregnancy. So if she is only stage 1A and she desires future pregnancy, then it is a fertility preserving surgery. What surgery we do, I am just going to tell you, but first listen. Second indication, borderline epithelial tumors. And third indication is germ cell tumors. So these are the three conditions where we do fertility preserving surgery. And the fertility preserving surgery is called as unilateral salpingo-oophorectomy. So we remove the affected ovary and the tube and leave behind the uterus and the other side ovary and the tube. So unilateral salpingo-oophorectomy. Now please remember, cystectomy is never done for ovarian cancer. So if I make a question and I say that there was a lady with with ovarian cyst, I did a cystectomy and the histopathology report comes as epithelial ovarian cancer. The patient desires childbearing. What should we do next? So I'm repeating again, the patient is case of ovarian cyst. I do a surgery which is called a cystectomy, but the histopathology report comes as epithelial ovarian cancer. What should I do next as the patient desires fertility? Yes. So you will have to reoperate her and do a unilateral salpingo-oophorectomy. Cystectomy is never an answer for ovarian cancers. So since she desires childbearing, what we are going to do is a unilateral salpingo-oophorectomy. Okay. Last point is prognostic markers. If you talk about the prognostic markers, then please understand, you'll be given a question like all the following are poor prognostic markers except. So you have to understand that iatrogenic rupture of capsule, iatrogenic rupture of the capsule is not a poor prognostic marker. So that means the surgeon during the surgery cut open the capsule. So it does not become a poor prognostic marker. Ruptured capsule preoperatively is a poor prognostic marker. The other poor prognostic markers are advanced stage, advanced grade, aneuploidy, abdominal spread, lymph node spread, right? So any kind of spread would become a poor prognostic marker because that automatically increases the stage of the cancer, right? So advanced stage, advanced grade, aneuploidy, abdominal spread, lymphatic spread, malignant ascites, tumor on the surface, they are all poor prognostic markers, right? So I just said that iatrogenic rupture is not a poor prognostic marker. Preoperative rupture is a poor prognostic marker, right? So with this we finish ovarian cancer. And now we take a break. How long do you want the break to be? Quickly. It's 5:25. How long you want the break to be? 0 minutes. Alright, so we take a 15-minute break. It's 5:25. I start the class at 5:40. right? Now, and that's going to be endometrial cancer. And alright, so if you talk about endometrial cancer, the most common histology is adenocarcinoma, right? The most common histology is adenocarcinoma, and it is sometimes also called as endometrioid. So it's one and the same thing, whether we say adenocarcinoma or whether we say endometrioid cancer. The other histologies that are seen are papillary serous and clear cell. If you talk about risk factors for endometrial cancer, then the risk factors for endometrial cancer would be very similar to that of ovarian because the etiopathogenesis is same. So more the number of menstrual cycles, more is the risk, right? And unopposed estrogen is again a risk factor for endometrial cancer. So based on these, if we enumerate the risk factors for endometrial cancer, then these would be early menarche, late menopause, nulliparity, diabetes mellitus, hypertension and obesity, diabetes mellitus, hypertension and obesity, polycystic ovarian disease or polycystic ovarian syndrome, tamoxifen therapy, granulosa cell tumors of the ovary, again the same genes BRCA1, BRCA2 and HNPCC. When you talk about hormone replacement therapy, then please understand HRT is going to be a risk factor only when estrogen is given alone. If estrogen plus progesterone hormone replacement therapy is given, then it is not a risk factor for endometrial cancer, right? Because progesterone is considered protective and then HRT is not a risk factor. Coming to protective factors, the protective factors for endometrial cancer are, again, number 1, combined oral contraceptive pills, they are protective. Nulliparity is protective. Smoking is protective against endometrial cancer. Smoking is protective against endometrial cancer. There are certain types of estrogens called as phytoestrogens. Now please understand, although they are a sort of estrogens, it is considered as a protective marker for, sorry, yes, it will not be nulliparity, it will be multiparity, right? Thanks for correcting. It will be multiparity, smoking, phytoestrogens, what I'm saying is, although their name has estrogens, but they are protective, right? So these are antagonistic at the estrogen receptors, and therefore they're considered as protective agents for endometrial cancer. So these are the risk factors and the protective factors. Next, what we talk about in endometrial cancer is, again, certain one-liners which are important for us. What are those one-liners? First being, what is the most common presenting complaint? The most common presenting complaint is post-menopausal bleeding. The most common presenting complaint for endometrial cancer is post-menopausal bleeding. If they ask you, what is the most common cause of post-menopausal bleeding? Although it sounds like a similar question, but it is different, and therefore the answer is also different. If you talk about the other way around, that is the most common cause of post-menopausal bleeding, then on number 1 lies senile endometritis, or senile endometrial atrophy, right? So one and the same thing. Senile endometritis or senile endometrial atrophy. This is followed by exogenous hormone replacement therapy. This is followed by endometrial hyperplasia, which is followed by endometrial polyp, and on the 5th number comes endometrial cancer, right? So endometrial cancer comes quite lower down if you talk about other way around. The same question asked in the third way. The third way is, what percentage of cases of post-menopausal bleeding, what percentage of cases of post-menopausal bleeding have endometrial cancer? And the answer is only 10%. So only 10% of patients who present with post-menopausal bleeding will actually turn out to have endometrial CA. Still a similar appearing question. What is the most common cause? What is the most common cause of post-menopausal bleeding in India? What is the most common cause of post-menopausal bleeding in India? And the answer changes to cervical cancer. So in India, cervical cancer is still the most common cancer even in post-menopausal women. The reason is because cervical cancer has a bimodal peak. The first peak incidence occurs in the 3rd and 4th decade of life, whereas the second peak incidence is seen in the 5th and the 6th decade of life. So that is why in India, even if you talk about post-menopausal women, the most common cancer is cervical cancer, right? Then we talk about what is the mode of spread for endometrial cancer. It is called as a direct spread. The mode of spread is called as a direct spread. Endometrial cancer is also the most common cause of, most common cause of pyometra is endometrial cancer. On the other hand, if we ask most common cause of pyometra in India, the answer is cervical cancer. So in India, the most common cause of pyometra is cervical cancer, whereas world over, the most common cause of pyometra is an endometrial cancer, right? It is endometrial cancer. Now when you talk about endometrial cancer, we also divide endometrial cancers into type 1 and type 2 endometrial cancers. So we divide them into type 1 and type 2 endometrial cancers. Type 1 are more common. They are responsible for 80% of all endometrial cancers, whereas type 2 are responsible for 20% of endometrial cancers. The type 1 are which histology? They are adenocarcinomas or endometrioid histology, whereas type 2 have either papillary serous histology or clear cell histology. Type 1 are estrogen dependent tumors. They are not estrogen dependent. Type 1 are preceded by pre-invasive lesions, whereas type 2 are not preceded by any pre-invasive lesion. Type 1 have better prognosis, whereas type 2 have poor prognosis. Type 1 are usually seen in obese women. Type 2 are equally common even in thin women. Type 1 occur at perimenopausal age group, whereas type 2 are seen at advanced age. So higher the age, more is the risk of the cancer being type 2, right? Then the gene invaded or the gene involved in type 1 endometrial cancer is P10 and KRAS. The gene involved in type 1 cancers are P10 and KRAS, whereas the gene involved in type 2 is P53. Type 1 lesions show minimal myometrial invasion, whereas type 2 show deep myometrial invasion. Now, when we say that they may be associated with pre-invasive lesions, then definitely a lesion which carries the risk of malignancy is endometrial hyperplasia. So when you talk about endometrial hyperplasia, please understand that endometrial hyperplasia, no, Bikaner, you're confusing. The question that came in AIPG specifically asked about type 2 and then the answer is P53. If it is type 1, then the first gene to conk off is P10 and then it is KRAS. Alright? Yes. So, AIPG 2014 specifically asked about the gene involved in type 2 endometrial cancer, and as I said, then the answer is P53. Right? Whereas it is type 1, it will be P10 and KRAS, and the first to go out of the two is P10. Right? So when you talk about endometrial hyperplasia, it is a histopathological diagnosis. So it is not a diagnosis that the gynecologist is going to make, and it is not a diagnosis that an ultrasonologist is going to make. So it is not a finding on ultrasonography or on hysteroscopy. It is a finding on histopathology. Depending on what we see on histopathology, the hyperplasia can be simple without atypia. It can be complex without atypia, or it can be simple with atypia or complex with atypia. No, in what? What are you writing? In DNB only endo CA gene was asked. So I've given you the answers, right? If nothing is asked, then P, the endometrial cancer type 1 are more common, and then the first gene to go in type 1 endometrial cancer is P10. So that should be your answer. If nothing is mentioned, P10 is the answer, right? Simple without atypia, complex without atypia, simple with atypia, and complex with atypia. Okay. Now, the risk of conversion of simple with atypia, without atypia into malignancy is 1%. The risk of conversion of complex without atypia into malignancy is 3%. Simple with atypia 8%, and complex with atypia is 29%. Now, the treatment of endometrial hyperplasia actually depends on whether there is atypia or there is no atypia. So, if it is endometrial hyperplasia without atypia, if it is endometrial hyperplasia without atypia, then the treatment is progestrogens. Right? The treatment is progestrogens. The most commonly prescribed progestrogen is MPA, medroxyprogesterone acetate. Medroxyprogesterone acetate. It is given in the form of 10 milligrams every day, and it is given for a period of 6 months. Whereas if it is hyperplasia with atypia, the answer changes to hysterectomy. So the treatment of hyperplasia with atypia is hysterectomy. Then, as we all know, we have studied before that progesterone is or has endometrial protective activity, right? So it causes endometrial protection. The question is, what is the minimum number of days? What is the minimum number of days for which progesterone should be given in the menstrual cycle to reduce the risk of CA endometrium? Right? And the answer here is 12 to 14 days. If you have to choose one, then the best answer is 14 days, because there is no consensus onto what exactly one value should be. Some books say 10 to 14, some say 12 to 14. So if it is asked that the minimum number of days for which progesterone should be given to show endometrial protection, the best answer is, a single best answer is 14 days, right? It is going to be 14 days. Now, since endometrial cancer is not very common, we do not do universal screening. So we don't do universal screening. For that matter, we don't even do screening in post-menopausal women. ऐसा भी नहीं है कि हम हर post-menopausal women में endometrial cancer जाके ढूंढते हैं. Right? So, we only do screening in women who are positive for HNPCC. Why? Because the lifetime risk of developing endometrial cancer with HNPCC is as high as 75%. So, for women who are known to carry HNPCC genes, then in them screening should be done. The screening is done by endometrial sampling. The screening is done by endometrial sampling, and again the screening should begin by 35 years of age. It should begin by 35 years of age, right? Otherwise we don't do screening at all. Then how do we pick up endometrial cancer? If we don't do any kind of screening, then how do we pick up endometrial cancer? So we do testing in symptomatic women, which means any woman if she presents with postmenopausal bleeding. So I'm saying we do testing for endometrial cancer only in symptomatic women. That is, women who present with postmenopausal bleeding. These are the women in whom we should look for whether the cancer is present or not. Right? Now, so what should be our approach to a patient who presents to us with postmenopausal bleeding? The first investigation which we can do in a woman who presents with postmenopausal bleeding is transvaginal ultrasound. So the first investigation is a transvaginal ultrasound, and what we want to look for is endometrial thickness, right? What we want to look for is endometrial thickness. If the endometrial thickness is less than or equal to 4 mm, then the risk of cancer is negligible. Whereas, if we do a transvaginal ultrasound and the thickness of the endometrium is more than 4 mm, then we have to do endometrial sampling. Now, endometrial sampling is a broad term. All it means is that you have to take a sample from the endometrium and send it for histopathology. Now, once we know this, what this term means, then we come to the methods which are to be used for endometrial sampling, right? So, if you are asked what is the investigation of choice for postmenopausal bleeding, our answer is endometrial biopsy. Our answer is endometrial biopsy. This biopsy is an OPD procedure. So no anesthesia, nothing is required. This endometrial biopsy is specially the biopsy which is done with an instrument or a device called as pipelle or called as Vabra aspirator. So we're talking about two devices, a pipelle or a Vabra aspirator. These are low pressure suction devices that pick up samples from the endometrium which we send for histopathology. So the investigation of choice for postmenopausal bleeding is endometrial biopsy. But the best investigation is going to be a fractional curettage. I'm going to come to your question later, right? So the best investigation is going to be a fractional curettage. Why is fractional curettage better than endometrial biopsy? Now normally we say that the pickup rate of endometrial biopsy is as good as a fractional curettage except in certain conditions. So which are the conditions where endometrial biopsy is not helpful and we would want to do a fractional curettage? Number one, if there is cervical stenosis, which means you have to dilate the cervix, it has to be done in the OT. Why? Because many a times in postmenopausal women, the uterus undergoes atrophy and even the cervix gets tightly stenosed, right? So if it requires dilatation, then we do the procedure in OT and side by side do a fractional curettage. Second, if the report comes as atypical hyperplasia in case of endometrial biopsy, then again you need a procedure which is fractional curettage to be very sure that there is no coexistent endometrial cancer, simply because atypical hyperplasia has a very high risk of malignancy, right? Third indication is when biopsy report is normal, but the patient has recurrent symptoms. So the patient says that she has recurrent episodes of postmenopausal bleeding, whereas the biopsy which you have done says there is no cancer or no hyperplasia. Then again, we need to reconfirm it with the Bretta procedure, which is a fractional curettage. So the investigations which can pick up cancer are, the first I said is transvaginal ultrasound, the investigation of choice is endometrial biopsy, and the best investigation is fractional curettage. Now Jammu has asked me a question, why not PAPS? Now you are going to tell me, Jammu, what do you see in the pap smear? What do you see in the pap smear? Once you try and answer the question, you will get to know why it is not an answer, right? So now you tell me, you are saying that why is PAPS not an answer? What does PAPS pick up in endometrial cancer? Can you tell me? For that matter, anybody? So since Jammu has asked me this, so I want to ask them so that they put a little brain into it and then they would never ask the question or never get confused again. Right? So what I'm asking you, you are saying why not PAPS is an answer. So can you tell me what does PAPS pick up? Cervical cells. So, no, what I am trying to ask you is, what report on pap smear is going to tell you that it is endometrial cancer? Most common cause of postmenopausal bleeding in India is pap smear. That's not what is the basis of the answer. You have to tell me what the investigation picks up. If you are saying it can diagnose endometrial cancer, what report on pap smear tells you it is endometrial cancer? You don't know it, right? That is why you put up the question. PAPS. The problem with pap smear is the kind of report which the pap smear gives could be AGC or it could give query adenocarcinoma. Now whenever a pap smear report comes as AGC, where AGC stands for atypical glandular cells, or adenocarcinoma, which means cancer of the columnar cells, right? PAPS is just going to tell you this. The PAPS is not going to tell you from where did the atypical glandular cell came or from where has this columnar cell come. Now can you tell me what could be the source of the glandular cells or the columnar cells? Okay, so Karamsad and what? Who is asking me? Jammu. Karamsad and Jammu, both of you tell me. What could be the source of these atypical glandular cells or the columnar cells? Very good, Mysore. So, PAPS is only going to tell us that the PAPS has seen atypical glandular cells or adenocarcinoma, which is columnar cells. Now, these cells could either come from endocervix, right? Or they could come from, these cells can either come from endocervix or they can come from the endometrium. So even after you've done a pap smear, you still don't know what is the site of cancer. Is it an endocervical cancer or are these the endometrial cells you have picked up? Because what happens is the endometrial cells fall down. When they are shed off, they fall down and they come into the cervix. Right? So all PAPS is going to tell you is that, right, we have seen glandular cells or I have seen columnar cells and therefore it is a adenocarcinoma. But PAPS will never tell you what is the origin of these cells. Is it the endocervix? So is it a primary cervical cancer or is it a primary endometrial cancer which you have picked up from the cervix? Right? So any investigation which leaves you in a doubt can never be an investigation of choice. Right? What are you going to tell the patient? Look, I'm going to do a pap smear, but then I'm not sure what the report is. I'm not sure whether it is still which type of cancer. Can you say that to your patient? She's going to shoot at you. Right? So investigation of choice has to be a procedure which gives you a diagnosis. right? You can't say that I will do so many investigations and then I will tell you. So you have to do the best possible investigation which tells you whether it is this cancer or not. You can't keep beating around the bush. Definitely PAPs can pick up endometrial cancer in the form of AGC or adenocarcinoma, but then we are not sure what is the source of these glandular cells or columnar cells, right? All right. Now with that, I get another question. The question asks you, what percentage of patients of stage 1 endometrial cancer have a normal pap smear? That is the second reason why we don't use it as a tool. Yes. So, no, then again, Karam sir, that means again you don't know something. What is a fractional curettage, babies? Fractional curettage में हम दो जगह से curettings लेते हैं. The first sample is from the endocervix, which is sent in a separate vial, and the second sample is from the endometrium, all 4 walls sent in a separate vial. They are labeled separately, endocervical cells and endocervical curettings and endometrial curettings, right? Now based on this, okay, I've got 2 questions for you now. So one, I'm saying, what percentage of type 1 cancers, stage 1 cancers will have normal pap smear? And the answer is 50%. So if you just simply do a pap smear and she is a stage 1 endometrial cancer, 50% of times the pap smear report is going to say it is normal, there is nothing there. That is the second reason why we cannot use pap smear as the investigation of choice. You don't want to diagnose a malignancy in stage 4. We want to diagnose it in stage 1, right? Another thing which Karamsad had asked came as a question itself. So they asked, what is the first step you do in fractional curettage? And the answer is endocervical curettings. Even before you dilate the internal os, please listen carefully. Even before you dilate the internal os, the first thing to be done is take the endocervical curettings. Why? Once you do dilatation of the internal os, what is going to happen? There is a possibility that endometrial cells may come down. So the first thing is endocervical curettings, then you dilate the internal os, and then you do the endometrial curettings. That is how we perform the procedure of fractional curettage. Is it okay now? Are your doubts cleared? Yes or no? Good. Right. The next thing we talk about is staging of endometrial cancer. Now when you talk about staging, it is again given by FIGO, International Federation of Obstetricians and Gynecologists, and again it is a surgical staging, where stage 1 is divided into A and B, where stage 1 is divided into A and B, where 1A means only endometrium is involved and or less than 50% of myometrium is involved, right? So only endometrium is involved or less than 50% of the myometrium is involved. And 1B is more than 50% of myometrium is involved. So 1B is when more than 50% of myometrium is involved. So that is stage 1A, stage 1 divided into A and B. The next stage is stage 2, which means cervical spread. Stage 2 is cervical spread, right? Now, again, these are latest changes in the staging system where they say you will call it a cervical spread only when cervical stroma is involved. Now my question to you is, what will be the stage of the patient if there is involvement of only cervical glands? What will be the stage of the patient if there is involvement of only the cervical glands? Anybody? Anybody can tell me? Now if it is only cervical glands, very nice. So it will be still stage 1 for the same reason that I told you, that the endometrium is continuous in the endocervix and the uterus, right? So we don't take it as a spread until and unless the stroma is involved. So it will be 1A if it is less than 50% of myometrium, and it will be 1B if it is more than 50% of the myometrium. Coming to stage 3. Stage 3 is divided into A, B and C. So stage 3A is involvement of uterine serosa and adenexa. Involvement of uterine serosa and adenexa. 3B is involvement of vagina and parametrium. 3C is divided into C1 and C2. 3C is divided into C1 and C2, where C1 is involvement of or positive pelvic lymph nodes and C2 is positive para-aortic lymph nodes. So C1 is positive pelvic lymph nodes and C2 is positive para-aortic lymph nodes. We come to stage 4 endometrial cancer then. Stage 4 is again divided into A and B, where A is involvement of bladder and bowel and B is distant metastasis or positive inguinal lymph nodes. Distant metastasis or positive inguinal lymph nodes. Similar to in ovarian cancer, stage 3 and 4 are also called as advanced staged endometrial cancers. Similar to ovarian cancer, the procedure we do is called as staging laparotomy. The steps of staging laparotomy remain the same except the following changes. Number 1, routine omentectomy is not done for endometrial cancer. Routine omentectomy is not done for endometrial cancer. Omentectomy is done when the histology is papillary serous or clear cell. The third change is that we were doing pelvic and para-aortic lymph node sampling. Instead of sampling, we will do lymphadenectomy. Instead of sampling, we do lymphadenectomy if the histology is papillary serous or clear cell. The fourth difference is, if it is cervical spread, that is stage 2 disease, then instead of TAH, which was type 1, instead of type 1 hysterectomy, we will do a more bigger procedure, which is type 3 hysterectomy plus BSO. So if there is a cervical spread, Then the surgery we do is a type 3 hysterectomy with bilateral salpingo-oophorectomy instead of a type 1 hysterectomy. So these are the changes in staging laparotomy when you are dealing with endometrial cancer. Again the similar question. What is going to be the primary modality of treatment for advanced stage endometrial cancer? What is the answer? Primary modality of treatment for advanced stage endometrial cancer. Yes. So the answer would remain surgery. You will not mark chemotherapy, you will not mark radiotherapy, you will not mark chemo plus radio. The answer is surgery. Again, it will be called as a debulking surgery. Right? The next thing we talk about is post-operative therapy in endometrial cancer. Now, before we decide the post-operative therapy in patients with endometrial cancer, we divide the patients into low risk, intermediate risk, and high risk. So low risk, intermediate risk, and high risk. What is low risk? Low risk कौन से patients होते हैं? Patients who have endometrioid histology, who have involvement of only endometrium or less than 50% of myometrium. So who is called as a low risk patient? Where the histology is endometrioid, only endometrium is involved or less than 50% of myometrium is involved. Who are called as high risk? Patients with stage 3 and stage 4 disease and patients with papillary serous and clear cell histology are called as high risk patients. Now once we divide them into low risk and high risk, all others which don't fit into low risk, don't fit into high risk, automatically go into intermediate risk. So anything that doesn't fit into low and high goes into intermediate, right? Now if the patient falls into low risk, then there is no need of any post-operative therapy. There is no need of any post-operative therapy. If the patient is intermediate risk, then the treatment we give is radiotherapy to the site where the cancer has spread, right? Then the answer is radiotherapy. Whereas if the patient is a high risk patient, then the answer is chemotherapy with or without radiotherapy. The answer is chemotherapy with or without radiotherapy. Most of the places combine the two, but chemotherapy is a must. We may or we may not give a radiotherapy as well, right? So this is the post-operative management. Then we talk about prognostic markers. And if you talk about prognostic, before I go to prognostic, there is one more form of treatment for endometrial cancer called as hormonal therapy. So what is the role of hormonal therapy? Hormonal therapy for endometrial cancer is only palliative, right? So it is only a palliative therapy. It really doesn't stop the progress of the cancer. Talking about prognostic markers. So remember a single statement. all are poor prognostic markers. All are poor prognostic markers except ER/PR positive status. So ER/PR positive means positive for estrogen and progesterone receptors. So when the ER/PR status is positive, then we say that it is a good prognostic marker, whereas if ER/PR, all others would mean advanced stage, right? What others would mean? Advanced stage, grade, cervical spread, abdominal spread, lymphatic spread, more than 50% myometrial invasion. So all these would be poor prognostic markers, except we are saying ER/PR positive status, which is considered as a good prognostic marker and not a bad prognostic marker, right? So with this we finish the endometrial cancer as well. The next thing which we are going to take up is included, or I usually included with malignancies, and that's going to be molar, right? So the next thing that we're going to do is molar pregnancy. Alright, so we are going to start molar. Now before we go further, we are going to do the terminologies. So there is a terminology called as GTD, which is gestational trophoblastic disease. And then there is another terminology called as GTN, which is gestational trophoblastic neoplasia. Now when you specifically say GTN, it includes invasive mole, it includes choriocarcinoma, and it includes PSTT, which stands for placental site trophoblastic tumor. Right, placental site trophoblastic tumor. Whereas when we say GTD, that is gestational trophoblastic disease, then GTD would include these three plus partial and complete mole. So GTD includes everything: a partial mole, a complete mole, invasive mole, choriocarcinoma, and PSTT. Right. So before we go on to the neoplasia part of molar pregnancy, we would study about molar pregnancy per se first. And a molar pregnancy is divided into a complete molar pregnancy, or a complete mole, and a partial mole. Right. Again, we're going to give it to you in a tabulated form in order to make it easy to remember. Right, so we're going to differentiate partial mole and complete mole. Now when we talk about partial and complete moles, a complete mole there is trophoblastic proliferation. In a complete mole, there is trophoblastic proliferation. There are no villi, and there is no fetal tissue. So there is trophoblastic proliferation, there are going to be no villi-like structures, and there is going to be no fetal tissue. When you talk about partial moles, the trophoblastic proliferation is focal, so it is less. Some villi formation is there, and some fetal tissue is also there. When you look at these two things grossly, then in complete moles, there is complete hydropic degeneration of placenta. There is complete hydropic degeneration of placenta, whereas in partial mole, there is only focal hydropic degeneration. When you look at them in the microscopy, two features which are seen in partial mole and not seen in complete mole are scalloping. So scalloping of villi is seen in partial moles and it is not seen in complete moles. Right? So scalloping is not a feature of complete mole, it is rather a feature of partial moles. And then what you would see microscopically as well would be villus architecture. So villi architecture would be present in partial and they would be absent in complete moles. Now, when you talk about complete moles and partial moles, so here again it is complete and partial. Complete moles are usually diploid. The complete moles are usually diploid and both sets of chromosomes are paternal. So both sets of chromosomes are paternal and the most common karyotype is 46XX, which is seen in 80% of complete moles. 20% are 46XY. It is these 20% that are dispermic. Otherwise, majority of complete moles are monospermic. So what happens is, the ovum is there, but the genetic material of the ovum degenerates. It is fertilized by a single sperm, which then duplicates its genetic material. So majority or 80% are monospermic, whereas only 20% are dispermic, and these are the ones which have the karyotype as 46XY. Whereas if you look at the partial moles, 90% of partial moles are triploid. And it is the extra chromosome set which is paternal. The rest 10% are tetraploid. The rest 10% are tetraploid. Next, if you talk about these, the beta HCG values are very high in complete moles, whereas the beta HCG value is higher than POG, but not as high as seen in complete moles. So it would be high than what should be at a particular period of gestation. It will be more than that, but it will never be very high, which is seen with complete moles. In complete moles, the fundal height is more than the period of gestation in 50% of patients. The fundal height is more than the period of gestation in 50% of patients, whereas in the partial mole, the fundal height is either equal to the period of gestation or less than the period of gestation, but never more than the period of gestation. The complete moles have a classic history of passage of grape-like vesicles. They have a classic history of passage of grape-like vesicles, whereas no such history is present in partial moles. The most common presentation for both, but whether you talk about partial or whether you talk about complete, is bleeding PV. The most common presentation in both, whether it is partial mole or it is complete mole, is going to be bleeding per vaginum. If we do an ultrasound for complete mole, then the characteristic appearance on the uterus is called as snowstorm appearance. Yes, whereas if you do an ultrasound in the partial moles, it is usually misdiagnosed as missed abortion. For that matter, when we say that ultrasound easily picks up molar pregnancy, then this statement is true only for complete moles. The statement that ultrasound easily picks up molar pregnancy is not true for partial moles, right? So partial moles are mostly misdiagnosed as missed abortion, right? Then we talk about complete and we're talking about partial. If we talk further about these, then complete moles में कुछ चीजें classically मिलती हैं which are not seen with partial. What are these? Preeclampsia. The incidence of preeclampsia in complete mole may be as high as 27%. The incidence of preeclampsia in complete moles may be as high as 27%. Hyperemesis gravidarum. The incidence of hyperemesis gravidarum may be as high as 25%. Hyperthyroidism, the third thing. Which is seen in 7% of cases of complete moles. So none of these medical complications are seen with partial moles. These medical complications are seen with complete moles. Classically, complete moles are also associated with theca lutein cyst of the ovary. They are associated with theca lutein cyst of the ovary, which will be seen in 50% of cases of complete mole. The next thing is the risk of conversion of complete mole into GTN. So the risk of conversion of complete mole to conversion into GTN is 15 to 20%, and the risk of conversion of complete mole into choriocarcinoma is 4%. Similarly, the risk of conversion of partial mole into GTN is 3 to 5%, and the risk of conversion of partial mole into choriocarcinoma is negligible. It is less than 1%. Right? It is less than 1%. Then what are the high risk factors in a patient? So what are the high risk factors in a patient for development of GTN in molar? So if a patient is a case of molar pregnancy, there are certain high risk factors which tell us that this patient has higher risk to develop GTN. The first and foremost being HCG. If the values of HCG are more than 10 to the power 5, then the risk of conversion to GTN is higher. Second, excessive uterine enlargement. So for example, if the POG is only 10 weeks and the uterine size is 20 weeks, right? So excessive uterine enlargement, again, higher is the risk of developing GTN. The third, presence of theca lutein cyst, especially if they are bilateral and more than 6 centimeters in size. Presence of theca lutein cyst, I'm saying, especially if they are bilateral and they are more than 6 centimeters in size, there is a higher risk. And lastly is the age of the patient. If the age is more than 40 years, then again it is a high risk for development of GTN after a molar pregnancy, right? Now, what is the treatment of molar pregnancy? The treatment of molar pregnancy is suction evacuation. The treatment is suction evacuation irrespective of the size of the uterus. So irrespective of the size of the uterus, the treatment is suction evacuation. And after suction evacuation, we do a check curettage. Now please understand, this curettage is always sharp. It is never a blunt curettage, right? So a sharp curettage is what we do after we do the suction evacuation. What is the average time? What is the average time for HCG to return to normal? What is the average time for HCG to return to normal after suction evacuation? So in the complete mole, the average time is 9 weeks. In the partial mole, the average time is 7 weeks. If nothing is mentioned, that is the type of molar is not mentioned, go with 9 weeks, right? If nothing, by which I mean if they are not mentioning you the type of mole, they just write average time for HCG to return to normal after molar is, stick to 9 weeks. Whereas I'm giving you the detailed answer as well. So if it is complete, it is 9. If it is partial, it is 7 weeks, right? Now, therefore, in order to see whether the patient is developing GTN or not after molar, we do follow-up. So first we do weekly follow-up. So every weekly we send beta HCG till the time it returns to normal. So till the time it becomes normal. Once the HCG becomes normal, after that we send HCG monthly for a period of a minimum of 6 months. So if they ask you what is the period of surveillance after molar pregnancy, the answer is 6 months. So the period of surveillance for molar is going to be 6 months. What are the changes or criteria for diagnosis of GTN, right? So what are the criteria? For diagnosis of GTN after molar? The first criteria is 4 HCG values which plateau, which means day 1, day 7, day 14 and day 21. So we were sending weekly values. If 4 values show a plateau, then it is one of the criterias. By plateau we mean 10% plus minus, which means either 10% above the initial value or 10% below the initial value. Both are considered as plateaus. The second criteria is 3 HCG values which are rising. So 3 HCG values which are rising, that is day 1, day 7 and day 14. Why do you want me to repeat, Jammu? So day 1, day 7 and day 14, if 3 values show a rise, and since plus minus 10% was, if plus minus 10% was a plateau, then if the value rises by more than 10%, it is called as a rise. If the value increases from the previous value by more than 10%, it is considered as a rise. The third criteria is when the histopathologist gives the diagnosis itself as choriocarcinoma. Now please understand that the investigation of choice for molar pregnancy is definitely an ultrasound. The investigation of choice for molar pregnancy is an ultrasound, but the best investigation is always histopathology. So whenever we do suction evacuation, we always send the sample of the tissue obtained for histopathology, and therefore if there is a possibility that the histopathology report itself comes as choriocarcinoma, so it will be the third criteria. The fourth criteria is when the beta HCG is more than normal even after 6 months of suction evacuation. So if beta HCG is more than normal even after 6 months of suction evacuation, it is the fourth criteria. So if any one of the 4 criteria is met, then we make a diagnosis of gestational trophoblastic neoplasia, right? Now these are the lab, Jammu, we will take it up later, or you can get these slides repeated, right? So these are the lab criteria for diagnosis. How will the patient present in case she has converted from molar to GTN? So what could be the various presentations in which the patient can come up to us? So number 1, the patient can present with persistent vaginal bleeding. So even after suction evacuation, one of the presentations can be a persistent vaginal bleeding. The second presentation can be subinvolution of uterus. So the uterus should regress once you do a suction evacuation. But if it is not reducing to normal size and it is still larger than normal, that is called as subinvolution, and again it should give you a hint that she may be developing a GTN. So subinvolution of the uterus. Third criteria, persistent bilateral theca lutein cyst on ultrasound. And especially I said if they are large, that is more than 6 centimeters. Fourth, sometimes the patient may not present to you with vaginal bleeding, but one fine day she may present in emergency with shock. Why? Because the invasive mole keeps eating up the myometrium, and there will be one fine day when it penetrates the entire myometrium and serosa and presents with intraperitoneal hemorrhage, when the patient will present with shock straight away. The fifth presentation could be straight away in the form of metastasis. So the patient presents to you in the stage of metastasis. Now, the most common site of metastasis from choriocarcinoma are lungs. The most common site for metastasis from choriocarcinoma are lungs. They may be involved in 80% cases. The second most common site is vagina, involved in 30% cases, and followed by this is pelvis, involved in 20% cases. The least common sites are liver and brain. The least common sites are liver and brain with 10% incidence each. Right? So, the most common site are the lungs, followed by vagina. Now, there is something classical about these presentations as well. The classic thing is that the metastasis to the lungs have a special appearance on chest X-ray. The special appearance is called as cannonball metastasis. The special appearance is called as cannonball metastasis. The second appearance of the metastasis in the lungs can be again snowstorm. So please understand, if they tell you ultrasound pelvis shows snowstorm appearance, the diagnosis is complete mole. But if they tell us chest X-ray shows snowstorm appearance, the diagnosis is choriocarcinoma. So these are terms which are used similarly for the two findings. What is special about the vaginal metastasis? The vaginal metastasis classically present as bluish suburethral nodules. The vaginal metastasis classically present as bluish suburethral nodule, and these nodules are highly vascular. These are highly vascular. The maximum risk of choriocarcinoma is after complete mole, followed by full term delivery. So most of the choriocarcinoma cases occur after complete mole. But if you talk about a non-molar pregnancy, so in the non-molar pregnancy, the maximum incidence of choriocarcinoma is after a full term delivery or a full term pregnancy, right? Whereas the most common GTN per se after partial mole, if you talk about partial mole, the most common GTN is invasive mole. The most common GTN is invasive mole. Choriocarcinoma is seen most commonly, I am saying, after molar or complete mole, but in a non-molar pregnancy, it is most commonly seen in full term pregnancy, right? Now, since GTN is a kind of a cancer, we have a staging for it too. So, stage 1 GTN is tumor limited to the uterus. Stage 2, tumor outside uterus but within pelvis. Stage 3, metastasis to lungs. Stage 4 is distant metastasis. Stage 4 is distant metastasis. Now, in order to treat these patients with GTN, WHO has given a scoring system. Scoring system which we follow now is a modified scoring system, and I'm going to give you that scoring system. So what we actually do is we look at certain points, the points I'm going to give you, and we see the characteristics of those points and then give score to the point. The score can be 0, 1, 2 or 4. Finally, all those points, the scores of all the points are counted, and then we see what finally the score is. For example, the first criteria we take is age. Now we can give a low score to the patient like 0 or 1, or we can give a high score like 4. High score would mean poor prognosis and a low score would mean good prognosis. Age में what is given a low score? Less than or equal to 39 years is given a low score, whereas more than or equal to 40 is given a high score. The second criteria is value of beta HCG. Less than 10 to the power 3 is a low score. More than 10 to the power 5 is a poor score, and between 10 to the power 3 and 10 to the power 5 is an intermediate score, right? But the poorest would be if it is more than 10 to the power 5, best would be if it is less than 10 to the power 3. Third, size of the tumor. So if we talk about the size of the tumor, less than 3 centimeters is a good score. More than 5 centimeters is a poor score. Type of antecedent pregnancy. That means the GTN is developing after which type of pregnancy. So if it is a molar pregnancy after which GTN is occurring, it's a better prognosis. If it is a full term pregnancy, then it is bad prognosis. And ectopic and abortion come between. Right? Ectopic and abortions come in between. The fifth point is duration from antecedent pregnancy. So less than 4 months, good prognosis. More than 12 months, poor prognosis. And 4 to 6 and 6 to 12 come in between, right? So better prognosis if it is less than 4 months. Worse prognosis if it develops 12 months after the antecedent pregnancy, right? The sixth point is number of metastasis. So if it is presenting with metastasis, then what is the number of these metastasis? So less than 3 metastasis is a good score or a better prognosis, whereas more than 8 metastasis is a bad score or a poor prognosis. So number of metastasis less than 3 or more than 8. The next point is site of metastasis. So the next point we are saying is site of metastasis. So it's a good score if the metastasis is in the lungs or the vagina, because that would occur even in early stage cancer. Whereas if it is liver and brain, it is the worst prognosis or a high score. And finally, previous history of chemotherapy. So if the GTN is developing after an episode or after treatment with chemotherapy, then it is a good score. I'll explain, let me finish this. So previous history of chemotherapy is a good prognosis if it develops after single agent chemotherapy, whereas it is a bad score if it occurs after multi-agent chemotherapy. Now Bikaner is asking me to explain the point about duration, right? So I am saying, for example, a woman delivered today. So if the GTN develops within 4 months from today, it is a good score or a better prognosis. It is worst if it occurs even after 12 months from today. And we would give intermediate scores if it is between 4 to 6 months and 6 to 12 months. By which I mean, for example, less than 4 months, I give a score of 1. I give a score of 2, 3 here and 4 here. So maximum score would be given to if the pregnancy is, or if the molar or GTN is developing even 12 months after the antecedent pregnancy. This is what it means, right? Now once you see all these points, we add the score of each point. And then we divide the patient into low risk and high risk. So patient is a low risk patient if the total score is less than or equal to 6. And the patient is a high risk patient if the total score is more than or equal to 7. Not pregnancy occurs, the GTN occurs. Yes, if it occurs within 4 months, it is a better prognosis as compared to if the GTN is occurring even after 12 months of the pregnancy. Because we just did, because after full term, what was happening? After full term, the most common GTN is straight away a choriocarcinoma, which is a metastatizing type of a cancer, right? That is why it is the worst score after a full term pregnancy. Also, it is an unexpected outcome. After molar, GTN is an expected outcome. But after a full term pregnancy, GTN is not an expected outcome, right? What is the recurrence rate of molar pregnancy in further pregnancies? Alright, so if it is molar pregnancy, the risk of molar in future pregnancy is only 1%. So there is no increased risk, not greatly increased risk. After 1 molar, right, so I am writing, after 1 molar pregnancy, the risk of molar in the future pregnancy is 1%. Full term or previous? Miraj, what are you writing? What do you mean by full term or previous? Bikaner, I've answered your query. What is Miraj trying to write? Let me understand. So till you write what you want to know, Miraj. Full term of same pregnancy. See, people, you're not understanding. Yes, so the patient has delivered today, right? If she has delivered today as a full term normal pregnancy and then she develops a GTN, then the prognosis is poor rather than if a GTN develops after molar. That is what it means. Alright, thank you Karamsad. Right? Now what I was saying is that we divide the patients into low risk and high risk. A score of less than or equal to 6 is low risk and that of more than or equal to 7 is high risk. Now depending on what the scoring system is or what the score is, we treat the patient. So if the patient is a low risk patient, we give treatment in the form of single agent chemotherapy. And the agent of choice is methotrexate, right? And then, Bikaner, once upon a time, you were writing something about methotrexate and actinomycin D. So this is the question. Now, if a patient cannot be given methotrexate for some reason, there are contraindications, then yes, the other drug that can be given is actinomycin D. Right? But the drug of choice for single agent chemotherapy is methotrexate. What about high risk? Now stop saying thank you to each other. You don't say thank you to me so many times. Very bad. No, scoring is from 0 to 4. Scoring is from 0 to 4, not from 1 to 4. Right? Okay. High risk patients should be given multi-agent chemotherapy. So patients who have a score of more than or equal to 7 should be given multi-agent chemotherapy. All right. And the multi-agent chemotherapy that we give is I'm sorry, I just spilled some water on the table. All right, so the multi-agent chemotherapy that we give is called as IMACO. The regime is called as IMACO regime, and it stands for etoposide, methotrexate, actinomycin D, cyclophosphamide, oncovin or vincristine, right? So etoposide, methotrexate, actinomycin D, cyclophosphamide and oncovin. And if it is IMACO resistant patient, the IMACO resistant patient would be given a regime called as EMA-EP, where E stands again for etoposide, methotrexate, actinomycin D, and then again we give etoposide and cisplatin. So for IMACO resistant patients, the regime we follow is EMA-EP. Now the minimum duration of surveillance for GTN is 12 months. The minimum duration of surveillance for patients with gestational trophoblastic neoplasia is 12 months. And I said the minimum duration of surveillance for a patient with molar pregnancy is 6 months. Now, what is the single most important advice that we are going to give these patients during the period of surveillance? The single most important point is not to conceive. So these patients should not conceive again during this period of surveillance. But telling this to a patient that please don't conceive, they don't listen to us, right? So that is why the question says, what is the drug of choice for contraception in molar or after molar? What is the drug of choice for contraception after molar? And the answer is combined oral contraceptive pills. No, it is not IUD and it is not condoms as it is given in your guides. That is wrong. I can quote any number of books you want me to, and the answer is combined oral contraceptive pills, right? So the drug of choice for contraception after molar or after GTN for both, the answer is going to be combined oral contraceptive pills. Alright, so with this we finish molar pregnancy. Okay. So now what we can do is, this is what I have planned for you people. So just tell me if it is okay, or else we can go the other way around. What we can do is, we have 2 hours left. We can spend an hour on contraception, or somewhat that time on contraception, and the remaining time I can teach you twins, and maybe if you want RH negative. How about it? Yes, tell me, how about it? Is it okay? Do we go like that? So Karam Sir is saying yes, why not? Okay. So what we do now is going to be contraception. Now contraception is per se a very vast topic in itself. First twins. Do you want me to do twins and RH first? Do you want to do it that way? I am okay with that way as well. There is nothing much in infection. See, whatever you say, I can take up vaginitis as well and spend time on vaginitis. Or we can do prolapse. Prolapse may, all you need to know is the name of the surgeries, which I think you can get even from any book. So it's up to you, whatever you want, right? We can go that ways. What do you want me to do? Yes, so actually, yes, you should leave it to me because I know what are the important topics. Once you start interfering, then you lose on the important topics because then we are going according to you. Right? As far as I am concerned, I think RH is not being asked nowadays in any exam. It is just not being asked. For last 2.5, 3 years, no exam is asking about RH negative pregnancy. Right? So as far as I am concerned, I think you should do it from the club. I've given the points in the club. I would just give them here again. That's what I'm going to do. So I think we should leave that and maybe do, yes, right? So what you should do or what we will do is, I'll teach you twins, right? I will teach you twins and then I will take up contraception, right? And then if time permits, we will do a little bit of prolapse, right? That is what we can do. Or we can do twins and prolapse and then in the remaining time keep doing contraception. Now you're getting irritating. Now let's finish twin pregnancy first and then we go on to contraception, okay? Because twins is important, right? As far as I am concerned, I feel I should not leave this topic and I'm not comfortable leaving it because it is being asked in the exam, so I do want to teach you twins, right? So I don't want to leave it. No, we are not having an extra class. That's the scheduled time. So we have to finish it today, whatever we want to do, right? So talking about twin pregnancy. Now, as far as twin pregnancy is concerned, the first thing that you need to have to know is that most of the twins are dizygotic, right? Most of the twins are dizygotic. Only 1/3. Then, so most of the twins are dizygoted is what I'm saying. And out of all those who are monozygotic, out of all those which are monozygotic, only 1/3 are monochorionic, right? So the first thing I've told you is that most of the twins are dizygotic and only 1/3 are of the monozygotic twins are monochorionic. Rest will be all dichorionic. Now, how do we decide that what kind of a monozygotic twin is it? So it all depends on the timing of division. So in case the division takes place in the first 72 hours, that is first 3 days, then the kind of twin that is produced is dichorionic, diamniotic, dichorionic, diamniotic. If the division of the zygote occurs between 4 to 8 days, then the type of twin is monochorionic, diamniotic. If it occurs between 8 to 12 days, then it is monochorionic, monoamniotic. And if it occurs beyond 12 days, then these are called as Siamese twins or conjoined twins, right? So the type of division is going to determine, or the time of the division is going to determine the type of the twin, right? Now there is also another term or two more terms which are used called as superfecundation and superfetation. Now, what is the difference between the two terms, superfecundation and superfetation? Now, superfetation means a second pregnancy occurring in the course of an ongoing pregnancy. superfetation has till now not been shown in humans, right? So superfetation has not till now been shown in humans. It is a second pregnancy occurring in the course of an already ongoing pregnancy. On the other hand, if you talk about the term superfecundation, it means two separate ova are fertilized. Two separate ova are fertilized by two different sperms in one menstrual cycle. Right? So that is superfecundation, which is very much possible in humans as well. So superfecundation is two separate ova are fertilized by two different sperms, but the key word is that it is occurring in the single menstrual cycle, right? So that is superfecundation. Now, when you talk about monozygotic twins, there is chorionicity and there is amniosity. So for us, the most important thing is chorionicity. Why? Because the monochorionic twins have higher risk of certain problems. What are those problems? Number one, twin-twin transfusion syndrome, acardiac twinning, which is also called as TRAP sequence. TRAP stands for twin reversed arterial perfusion. Twin reversed arterial perfusion. Third problem is selective IUGR. Third problem, which is specific to monochorionic twins, is selective IUGR. And the fourth problem is increased risk of fetal death. Increased risk of fetal death. In case they ask you what is the most common problem with twin pregnancies in general, right? So they're not specifying the type of twin. What is the most common problem in twin pregnancies? The answer is prematurity. Most common problem in twin pregnancies, no, it is going to be prematurity. Twin-twin transfusion would not occur all the time. So the most common problem in general is the problem of prematurity in the child. Now, since chorionicity is very important for us, because monochorionic twins have higher risk of certain anomalies or certain problems, then we must know features which tell us that the twins are dichorionic, or in other words, indicators of dichorionicity. Now, the first indicator of dichorionicity is seeing two separate placenta. So, seeing two separate placenta indicates dichorionicity. But the problem is that in order to see two separate placenta, the ultrasound should be done really early in gestation, right? So, seeing two separate placenta. Opposite sex twins are always dichorionic. Opposite sex twins are always dichorionic. Third is something called as twin peak sign. The twin peak sign is also called as the lambda sign. It is also called as the lambda sign. Now the twin peak sign the ideal time to see it on ultrasound is between 10 to 14 weeks. The ideal time to see it on ultrasound is 10 to 14 weeks, but it can be seen up to 20 weeks. It can be seen up to 20 weeks. Now, twin peak sign appears because the chorion enters into the dividing membrane. So, this sign is produced because the chorion enters into the dividing membrane. The next sign that we can, or the next thing which indicates dichorionicity is more than 2 layers, in the inter-twin membrane. So, if we see more than 2 layers in the inter-twin membrane, it indicates dichorionicity. And actually, in a dichorionic twin, the number of layers in the inter-twin membrane is 4. The number of layers in the inter-twin membrane is 4. But it is not mandatory that the sonologist will see all 4. So, if he sees more than 2 layers, then also it indicates dichorionicity. The last point which tells us about dichorionicity is thickness of inter-twin membrane. Thickness of the inter-twin membrane. If the thickness of inter-twin membrane is more than 2 mm, if the thickness of inter-twin membrane is more than 2 mm, it again indicates dichorionicity, right? Now, just like we were seeing a lambda sign or a twin peak sign on dichorionic twins, the sign which we see in monochorionic twins is called as, now why do you want to jump up to twin transfusion syndrome when I am telling you something else right now? So, the monochorionic twins, will come to the questions sequentially, please hold on, right? So, that is why I said if you want to do it like this, then let's just ask questions on FB and let's not do the topic, right? So, monochorionic twins show the T sign. The sign which can be seen in monochorionic twins is called as the T sign. Now, this is because in this case the chorion does not enter into the inter-twin membrane. The chorion does not enter into the inter-twin membrane. Now, tell me one thing which you will see on ultrasound and that tells you that the twins are monoamniotic. What is the single best thing to see to know that the twins are monoamniotic? So, to diagnose monoamniotic twins, what we have to see is absence of inter-twin membrane. So, what we see is a single sac with 2 twins. There is no inter-twin membrane in monoamniotic twins. Now, monoamniotic twins become important because they undergo a special kind of a problem which is called as cord entanglement. So, the specific problem to monoamniotic twins is cord entanglement, and if cord entanglement occurs, it leads to death of both twins. If cord entanglement occurs, it leads to death of both the twins. This is the reason why monoamniotic twins are electively delivered by cesarean section. The monoamniotic twins are electively delivered by a cesarean section at 34 weeks. So, when the lung maturity is achieved, these twins are delivered by a cesarean section. Otherwise, there is a high risk of cord entanglement and death of the fetus. If we talk about conjoined twins, the most common type of conjoined twins are parapagous. Parapagous means twins which are laterally fused, right? So twins which are laterally fused are called as parapagous, and among parapagous the most common is thoracopagous. Among parapagous the most common is thoracopagous. The conjoined twins have the following features. They are always monoamniotic. Number 2, the twins are always in same orientation to each other. The twins are always in the same orientation to each other. Then they have contiguous skin. At some point they have contiguous skin. Finally, these twins will have more than 3 blood vessels in the umbilical cord. These kind of twins, the conjoined twins, will have more than 3 blood vessels in the umbilical cord. Now, if you talk about twin-twin transfusion syndrome, so if we talk about twin-twin transfusion syndrome, this is something which is seen in monochorionic twins. But please remember, it is more commonly seen in monochorionic diamniotic, not monochorionic monoamniotic. So these are more commonly seen in monochorionic diamniotic twins. The reason for twin-twin transfusion syndrome is deep artery to vein anastomosis. There are deep artery to vein anastomosis. What are you asking, Karam Sir? Can what? Congenity be the reason for abortion? Yes, twins do have a higher abortion rate as compared to a singleton pregnancy, right? So they do have higher abortion rates. So coming back to reason for this twin-twin transfusion syndrome is deep artery to vein anastomosis. As a result of these deep anastomosis, one twin acts as the donor and the other twin or the second twin acts as the recipient. Now earlier the criteria for diagnosing twin-twin transfusion syndrome were taken as a weight discordance of more than 20% and a hemoglobin difference of more than 5%. Right? So earlier these were the 2 criteria which were used to diagnose twin-twin transfusion syndrome. But now we don't use these criteria. The criteria which we use now is only one, and that is polyhydramnios in one twin and oligohydramnios in the other twin. This is the only criteria now used to describe twin-twin transfusion. So it is not only poly in one, it has to be poly in one and oligo in the other together to label it as a twin-twin transfusion syndrome. Now, both the twins in twin-twin transfusion syndrome have higher risk of congestive heart failure, right? Now, the result is that the recipient twin gets more blood and there is overload on the heart, which leads to congestive cardiac failure. If you talk about the donor twin, it suffers from anemia, and that is why it is again at higher risk from heart failure, right? Now, for twin-twin transfusion syndrome, we have a staging system which is used, and it is called as Quintero staging. In Quintero staging, the stage 1 stands for oligo in one twin and poly in the other twin. The bladder of the oligo twin is normally visible and the Doppler is also normal. So the bladder of the oligohydramnios twin is normally visible and the Doppler is also normal. So that is stage 1. Stage 2 is oligo in one twin and poly in the other twin, and the bladder of the oligo twin is not visible, but Doppler is still normal. Stage 3, oligo in one, poly in the other, bladder of oligo not visible, and now even the Doppler becomes abnormal. Stage 4 is when one or both the twins, either one or both the twins, show hydrops fetalis. And the last stage is stage 5, where either one or both the twins undergo intrauterine death. So that is a terminal stage of twin-twin transfusion syndrome. The treatment of twin-twin transfusion syndrome is fetoscopic laser ablation, of the anastomosis. Now, at the beginning of twin-twin transfusion syndrome, I told you that it is a feature of monochorionic diamniotic and usually not seen in monochorionic monoamniotic. What is the reason for that? The reason is that monoamniotic twins have more of superficial artery to artery anastomosis. They have more of superficial artery to artery anastomosis, which is protective for twin-twin transfusion syndrome, right? Which is protective for twin-twin transfusion syndrome. Now, if you talk about the mode of deliveries in twins, if the first twin is vertex, the mode of delivery is vaginal. If the first twin is breech, then the preferred mode of delivery is cesarean section. Why? Because if the first twin is breech and second is vertex, they undergo a phenomenon called as twin interlocking. So the aftercoming head of the first twin gets interlocked with the forecoming head of the second twin, and then there is no mode of delivery. So if the first twin is breech, the preferred mode of delivery is cesarean section. And obviously if the first twin is transverse, it has to be a cesarean section. The monoamniotic twins, I told you, it is again a cesarean section. Now when the first twin is vertex and the second twin is transverse, when the first twin is vertex and the second twin is transverse, this is the only modern day indication for internal podalic version. This is the only indication in modern obstetrics for internal podalic version. But please remember, internal podalic version can be done only in non-scarred uterus. Internal podalic version can only be done in a non-scarred uterus. That means IPV is contraindicated in previous cesarean section. IPV is contraindicated in a previous cesarean section. Now you'll have to excuse me for 5 minutes. It's not a break, right? I'm just going to be back in 5 minutes, right? All right. So that is about twins. What we're going to take up now is contraception. Most common is both vertex. The most common is both vertex, right? Okay. So now as far as contraception is concerned, we're going to take up things one by one, but I'm going to give you especially the things where you either get confused or it is given wrongly in the guides, or which I know are being asked nowadays, right? So the first thing we talk about is combined oral contraceptive pills. The first thing that you should know about combined oral contraceptive pills are that what is a low dose pill and what is a high dose pill. So any pill that contains more than or equal to 50 micrograms of ethinyl estradiol, more than or equal to 50 micrograms of ethinyl estradiol is called as a high dose pill. A low dose pill is one which contains less than 50 micrograms, and usually it contains 35 micrograms. Usually it contains 35 micrograms of ethinyl estradiol. And very low dose pills are which contain less than or equal to 20 micrograms of ethinyl estradiol. Now, there is Mala N and Mala D. What is the difference between the two? So Mala N contains 0.03 milligrams of ethinyl estradiol, and it contains 0.15 milligrams of levonorgestrel, right? So it contains, Mala N contains 0.03 milligrams of ethinyl estradiol and 0.15 milligrams of levonorgestrel, plus they will contain 7 iron tablets. So they will contain 7 iron tablets. And Mala D also has the same constituents. So the constituents of Mala D are also same. The only difference is that Mala N is distributed free of cost by the government of India, and Mala D is given at subsidized rates. So Mala N is free of cost, whereas Mala D is distributed at subsidized rate, which is approximately rupees 3 per packet as given by the government of India, right? Then if you talk about combined oral contraceptive pills, they are contraindicated in breastfeeding women, right? So we don't give them in breastfeeding women. In non-breastfeeding women, if you want to give it post-delivery, then these should be given after 6 weeks of delivery. If you want to give combined oral contraceptive pills after delivery, then they should be given after 6 weeks of delivery, because in the first 6 weeks there is increased risk of venous thromboembolism. I think it is fumarate and it is same in both. There is no difference. For this you'll have to check latest PARC if they give any difference in the iron content, because that is something which can change from one textbook to another, right? So to see which iron tablet, as far as I remember, it is fumarate and it's the same in both, right? So it is more than 6, in the first 6 weeks there is increased risk of venous thromboembolism, so we don't give it. Now, what is the most common side effect of combined oral contraceptive pills? The most common side effect is irregular bleeding. Right, so the most common side effect is irregular bleeding, which we call as breakthrough bleeding. So it is given a special name called as breakthrough bleeding. Then what do combined oral contraceptive pills do to PID? So they reduce the risk of pelvic inflammatory disease, but there are 2 infections, the risk of which is increased with combined oral contraceptive pills. These 2 infections are chlamydia and candida. So the risk of candida and chlamydia is increased with combined oral contraceptive pills. As with any contraception, they also reduce the risk of ectopic. Right, so that is true for any contraceptive agent that we say. Then the other questions are the role of oral contraceptive pills in various cancers, right? So what is the role of OCPs with various cancers? So breast cancer, we say no increased risk. There is no increased risk for breast cancers. For endometrial cancer, it is protective, that is, it decreases the risk. For ovarian cancer, again, it decreases the risk. For cervical cancer, we did that it increases the risk. And to be more specific, the risk is increased after 5 years. What about hepatocellular carcinoma? No increased risk. Although some earlier studies said that there may be some association between OCPs and HCC, but the latest studies say that there is no risk. What about GB cancer? Again, no increased risk. There is no increased risk of even gallbladder cancer with combined oral contraceptive pills. What is the main mechanism of action? The main mechanism of action for OCPs is inhibition of ovulation. So the main mechanism of action is inhibition of ovulation. If one pill is missed, there is no problem for 24 hours, right? If one pill is missed for 24 hours, there is no problem. The missed pill can be taken the next day. So next day she will take 2 pills instead of 1. The second is, if 2 pills are missed, then the female should use a backup method of contraception. She should use a backup method of contraception, because we say after missing 2 pills, the combined oral contraceptive pills are no longer effective. What are you trying to ask? What if ER positive female? What do you mean by ER positive females? All females have estrogen receptors. Please don't get confused. If it is breast cancer, as far as what you should answer, whether it is a risk factor or not a risk factor, it is not a risk factor, right? I'm going to come to the contraindications. Now what you are saying is something totally different, Gorakhpur, right? I'll tell you what you are saying. Then we come to absolute risk factors, absolute contraindications. Now absolute contraindications for the contraceptive agents is something which is being asked in every exam, right? So please take it down very, very carefully, because it is very confusing. The absolute contraindications is WHO category 4. Absolute contraindications are WHO category 4. These include uncontrolled hypertension. So hypertension alone is not an absolute contraindication. Uncontrolled hypertension, which has been described as more than 160 by 110, is an absolute contraindication. Venous thromboembolism is an absolute contraindication. Coronary artery disease is an absolute contraindication. Migraine itself is not an absolute contraindication, but migraine with focal neurological deficits is an absolute contraindication. Diabetes is not a contraindication, but diabetes with vasculopathy is an absolute contraindication. Known or current breast cancer is an absolute contraindication. Now this is what your question was, Gorakhpur. So if a patient is currently having breast cancer, then definitely oral contraceptive pills are an absolute contraindication. But if you are asked separately, what is the association? So as a consensus, we say it does not increase the risk of breast cancer, right? Then age per se is no criteria or no contraindication for OCPs, but if she is also a smoker and she is more than 35 years of age, then it is an absolute contraindication. So smoker and more than 35 years of age is an absolute contraindication. Pregnancy is an absolute contraindication. Undiagnosed vaginal bleeding is again an absolute contraindication. And finally, acute liver disease, by which we mean deranged liver enzymes. So please understand, cirrhosis which is compensated is not an absolute contraindication, whereas viral hepatitis would become an absolute contraindication. So acute liver disease, by which we mean deranged liver enzymes, is an absolute contraindication for combined oral contraceptive pills, right? Now, there's another drug which we have, and it is called as Saheli, or called as Centroman. Now it is important for us because it was discovered in India. So this drug was developed by CDRI Lucknow. So it was discovered by CDRI Lucknow. It was introduced in the year 1991. These are the kind of questions that DNB and AIPG are asking. It is the first of its kind. It is a non-steroidal contraception. It comes in the form of tablets, and each tablet has 30 milligrams. Each tablet has 30 milligrams of a compound called as ormeloxifene. It has 30 milligrams of a compound called as ormeloxifene. Basically, Centroman is a SERM, that is selective estrogen receptor modulator. It is given twice a week for first 3 months. So it is given twice a week for first 3 months, and then it is given 1 pill per week after 3 months. Then it is given as 1 pill per week after 3 months. The mechanism of action is inhibition of implantation. Inhibition of implantation. How does it do this? It makes the endometrium out of phase. It makes the endometrium out of phase, and that is why it inhibits implantation. The next we talk about is a mini pill, right? Next we talk about is mini pill. Now mini pill is nothing but a progestogen only pill. Mini pill is the other name of progestogen only pill. Now the POP is different from other contraceptive or other pills in certain ways. The difference is the main mechanism of action of a mini pill is alteration of cervical mucus. It is alteration of cervical mucus. There is something called as safe period for a mini pill. The safe period for a mini pill is 3 hours, by which we mean that normally the mini pill should be taken at the same time every day. But the delay which is allowed, for example, if she forgets it but remembers to take within 3 hours, the action will carry on. But if she remembers the pill after 3 hours, then the pill loses its effect. Now here two things are going to be different. Now you have to remember this very carefully. The only mini pill available in India, the only mini pill which is available in India comes by the name of Cerazette. It comes by the name of Cerazette. Cerazette has 75 milligrams of desogestrel. Right? So I'm going to write it. Cerazette has 75 milligrams of desogestrel. Cerazette is different from all other mini pills. If the question asks what is the main mechanism of action for Cerazette, then the answer changes to inhibition of ovulation. This is the only mini pill which inhibits ovulation. The second point of difference is that the safe period for Cerazette is 12 hours. So it is 3 hours for all other mini pills, but that for Cerazette is 12 hours. If we talk about mini pills or POP, it is the contraception of choice in lactating women. It is the contraception of choice in lactating women. And as far as POP is concerned, or as far as lactation is concerned, there is no difference as per the textbooks between best and ideal. This concept of best and ideal has been made by your guidebooks because they want to act safe. So what, they don't know the answer, so what they do is give one answer for best and the other answer for ideal, so that they are safe between two answers, right? There is nothing like an ideal contraception. It is always the contraception of choice. So the contraception of choice remains the progestogen only pills. As I said before, POPs only increase the relative risk of ectopic pregnancy. They do not increase the absolute risk. Therefore, POP is not contraindicated in history of previous ectopic. Right? So it is not contraindicated in history of previous ectopic. The most common side effect for POPs or any kind of progestogens are irregular vaginal bleeding. They are irregular vaginal bleeding. Oh, one thing I did not tell you about OCPs was return of fertility. So I'll tell it here together for POP and OCPs. So the return of fertility with combined oral contraceptive pills is 3 months or 90 days. Return of fertility for OCPs is within 90 days. Whereas the return of fertility with POP, it is immediate. The return of fertility is immediate for progestogen only pills or mini pills. Then coming to absolute contraindications. Now these two answers would remain same whenever you talk about progestational compounds. What two answers? The most common side effect, it is always going to be irregular vaginal bleeding, and the absolute contraindications. So if you talk about absolute contraindications, there are 3. Current breast cancer. Number 2, pregnancy. And number 3, undiagnosed vaginal bleeding. Undiagnosed vaginal bleeding. So these are the absolute contraindications for any progestational compound. Talking about DMPA. Now DMPA is what it is also called as Depo-Provera. It comes by the name of Depo-Provera. It is an injectable progestogen. Right? The dose is 150 milligrams given intramuscular. So the dose is 150 milligrams given intramuscular every 3 months. The main mechanism of action, even though it is only a progestational compound, is inhibition of ovulation. Why? Because the drug levels achieved by DMPA in the blood are high enough to inhibit ovulation. There are two problems in giving DMPA. Number one, it causes bone loss. It causes bone loss or decrease in the bone density. Number two, it causes delay in the return of fertility. The average time for return of fertility is 12 months, but it can be as high as 18 months. So the average time for the return of fertility is 12 months, but it can be as long as 18 months. The most common side effect would remain the same. It will be irregular vaginal bleeding. Right? There are two advantages as well. If there are two disadvantages, there are two advantages as well. It is preferably used in patients with epilepsy because DMPA has been seen to raise the seizure threshold. It has been preferentially used in patients with epilepsy because it raises the seizure threshold, and then it has seen to reduce the crisis in sickle cell anemia. So it is again preferentially used in sickle cell anemia patients, right? What does DMPA do to ectopic pregnancy? Not ectopic, that is decreased by everything. DMPA also reduces the risk of pelvic inflammatory disease. It also reduces the risk of pelvic inflammatory disease, right? Can DMPA be given to lactating women? The answer is yes, it can be given, but usually we don't give it. Can anybody tell me why? I'm saying it can be given, but usually we don't give DMPA to the lactating women. Anybody can come up with the answer? The answer is already there in the notes. You just have to think a little about it. Yes, anybody? It can be given, but I'm saying we don't give it. Are you all there, by the way? No response. All right. So I'm saying we usually don't give it. Yes, you're there. Thank God. Okay. The reason we don't give it is because both lactation and DMPA together will cause excessive bone loss. Lactation also causes bone loss, right? And DMPA would also cause bone loss. So we don't combine the two things and we don't give it in lactating women. But per se, it can be given, right? If you ask me the theoretical question whether it can be given or not, the answer is yes, it can be given, but usually not given. If somebody asks you what is the absolute contraindications, the absolute contraindications remain the same: pregnancy, undiagnosed vaginal bleeding, and current breast cancer. So again, we don't, or these are the absolute contraindications for even DMPA. Now, another important question, I said that it has to be given every 3 monthly. If the woman comes late, for example, today was her time to get a repeat injection, how late is allowed for the action to continue? So that is again called as the grace safe period, and that is 14 days. So even if she comes to me within 14 days, it is safe. The DMPA which was given earlier would still be in action. So the safe period is 14 days for DMPA. Now I'm not going to tell you about the progestational implant, right, which is Implanon. The reason I'm not telling you is there is an update with image, right, on the club that I have put recently. So you can search all image updates that I put if you type hashtag OBGY image, right? So go on the club, just write hashtag OBGY. Even if you write that much, you will be able to search all the image MCQs, right? And Implanon I have recently given in great details with the image. So that part you will see from there. We will cover the things that we have not covered anywhere else, right? So the next thing what we talk about is that okay? Will you go and see the Implanon? Yes or no? Yes, okay. So the next thing we talk about is going to be the vaginal ring, which was one of your questions in AI already seen. All right, thank you so much. So vaginal ring, which was one of the questions, and again AI PG 2014, right? So this comes by the name of Nuva ring. It comes by the name of Nuva ring. What compounds does it contain? Ethinyl estradiol, and it contains etonogestrel. Ethinyl estradiol and etonogestrel. The release rate is 15 micrograms per day for 15 micrograms per day for ethinyl estradiol, and 120 micrograms per day for etonogestrel. Now please understand, different question came in different set. In one question they asked the name, in the second they asked the compounds, and in the third set they asked the release rate. So anything can be asked, right? So the release rate is 15 and 120 respectively for ethinyl estradiol and etonogestrel. The mechanism of action for vaginal ring is going to be inhibition of ovulation, right? It is going to be inhibition of ovulation. The vaginal ring is inserted for 3 weeks. So it is consecutively put in the vagina for 3 weeks. And then 1 week is ring free. So for the 4th week, the woman removes the ring, and then there is going to be what? Withdrawal bleeding, right? Another thing about the vaginal ring is that the vaginal ring can be removed at the time of coitus. Okay, it can be removed at the time of coitus, but if it is removed, it has to be reinserted within 3 hours for it to be effective. So it has to be inserted within 3 hours if it has to be effective. Otherwise the patient will have to use a backup method of contraception. Another thing that we need to know is the transdermal patch. The transdermal patch has a dimension of 20 centimeters square. It contains ethinyl estradiol, but now instead of etonogestrel, it will have norelgestromin. Norelgestromin. gestromin. The release rate here is 20 micrograms per day for ethinyl estradiol and 150 micrograms per day for norelgestromin. Again, the mechanism of action, since it is a combined E plus P contraception, the mechanism of action remains as inhibition of ovulation. Right? It remains as inhibition of ovulation. A new patch is applied. A new patch is applied every week for 3 weeks. So every patch is a new patch is applied every week for 3 weeks, and then 1 week is patch free. 1 week is patch free. One of the side effects which has been seen more with transdermal patch as compared to a combined pill is venous thromboembolism. That is why the patch is not as, or has not become as popular as the combined pills. So there is increased risk of venous thromboembolism with the patch. The next thing we talk about is or are intrauterine devices. Now there are certain important questions that you are asked here. So the two intrauterine devices that you must know are copper T380A and Mirena. The copper T380A also comes by the name of Paragard. In India we just call it as copper T380A, but there is a brand name and it comes as Paragard. 380 represents the surface area. It is a T-shaped device where copper is present on the horizontal as well as the vertical limbs. Copper is present on the horizontal as well as the vertical limb. The A stands for that copper is also present on the arms. Then there is a bead and then there is a thread. The function of the bead is to reduce the risk of cervical perforation. And the function of the thread is identification and removal. Copper T380A is radio opaque because it has barium sulfate. So it is radio opaque. Then if you talk about Mirena, Mirena comes by the or is also called as LNG20. This is because it has levonorgestrel. This is how it looks like. It is also a T-shaped device where the vertical limb has the drug delivery system, right? It has 52 milligrams of LNG. It has 52 milligrams of levonorgestrel, which is released at the rate of 20 micrograms per day, and that is why it is called as LNG20. This is also radio opaque. The approved time for which Mirena can be used is 5 years. The time for which Mirena can be used is 5 years, whereas the time for which copper T380A can be used is 10 years. Copper T380A is the copper T which is available free of cost in all government hospitals. So it is available free of cost in all government hospitals. Now, if I ask you what is the mechanism of action of intrauterine devices? What is the mechanism of action of IUDs? Anybody? Come on, quickly. You don't want to answer now. So, the main mechanism of action. So, what you write? Yes, so all of you write, it is inhibition of implantation because of the foreign body reaction, right? But lately, all theories of IUD have changed in every book. The mechanism of action of IUD is now taken to be spermicidal. So if spermicidal is not in the options, then the next answer is inhibition of fertilization and not implantation. So I'm saying the best answer is spermicidal. If that is not in the options, then the answer is inhibition of fertilization. Inhibition of fertilization. The most common side effect is bleeding. The most common side effect is bleeding. Average blood loss with an IUD in situ is 80 ml, right? Whereas in a normal menstrual cycle, it is 35 ml. When there is an intrauterine device, then the average blood loss is 80 ml. And the treatment for this excessive blood loss is NSAIDs. The treatment for this excessive blood loss is NSAIDs. The most common side effect requiring removal. So the most common cause of removal is pain, whereas the most common side effect itself is bleeding PV, right? Now, as I told you when I was teaching you ectopic, that history of ectopic is not a contraindication. What are the contraindications or absolute contraindications? So number one would be any kind of infections like endometritis, genital TB or PID. So current infection, I put them together because they're all infections, right? The second is Mullerian anomalies. Would again be a contraindication or an absolute contraindication. Third, undiagnosed, I am telling you absolute contraindications, right? So the third is undiagnosed vaginal bleeding. Fourth, pregnancy. Fifth is specific for the two. For examples, Wilson's disease is an absolute contraindication for copper device. Wilson's disease is an absolute contraindication for copper device but not for Mirena. And breast cancer is an absolute contraindication for Mirena but not for a copper device, right? So these are the absolute contraindications. Now quickly tell me, what is the investigation of choice for a missing IUD? What is the investigation of choice for a missing intrauterine device? No, the answer is not X-ray. Again, the answer is going to be ultrasound. No, I'm asking you the investigation of investigation of choice. It is not uterine sound. It is an ultrasound. Now, the sequence of things we do if there is a missing IUD are the following. Whenever a patient comes with missing IUD, first we do uterine sounding or sounding of the cervical canal. So sounding, because a lot of times the thread is just coiled up in the cervix, right? If we cannot locate the copper T with this, then the next step is ultrasound. If you cannot locate it with ultrasound, then the next is X-ray abdomen, right? And when you do an X-ray abdomen, then it has to be done with a probe or a sound put inside the uterine cavity to look at the IUD. If you are asked treatment, so treatment of an abdominal IUD That means if it is perforated and goes into the abdomen, then it is laparoscopy. Whereas if it is gone inside the myometrium, so if it has buried inside the myometrium, then the answer is hysteroscopy. So those are treatments. They are not the investigation of choice for a missing IUD. The investigation of choice for a missing IUD is an ultrasound, right? Then they ask you, when is there a maximum risk of infection with an intrauterine device? So the maximum risk of infection with an intrauterine device is seen in the first 20 days after insertion. So that too is because of the method of insertion and not because of the intrauterine device per se, right? So the maximum risk of infection is in the first 20 days, and then almost all the books now say that there is no risk of increased infection after 20 days. So there is no risk of infection after that time. So only in the first 20 days is there a risk. And an infection which is specific to intrauterine devices is actinomyces, right? An infection which is specific to intrauterine device is going to be actinomyces. Now the next thing what we're going to take up is going to be emergency contraception. Okay, so they're asking me, now that is another reason why the investigation of choice in a missing IUD is ultrasound. Right? The answer to this I said was ultrasound. The reason is two. There are two reasons. One I said is it is non-invasive, but the more important reason is that we said that whenever an IUD fails, then at that time the risk of pregnancy being ectopic is very high. So ultrasound is going to do two things. One, locate the missing IUD, and number two, it will tell you that in case there is a pregnancy, what is the location of the pregnancy. Mirena would initially cause irregular bleeding as with any progestrogens, right? So what Karamsad is asking is, does it cause increased bleeding? So even with Mirena, the most common side effect would be initially irregular vaginal bleeding, but then you are right, over time Mirena causes amenorrhea. So initially Mirena presents with irregular vaginal bleeding, and eventually it leads to amenorrhea, right? Okay, so coming to emergency contraception. Now, emergency contraception which is most efficacious, is an intrauterine copper device. It is successful in preventing 95% of pregnancies. This is followed by mifepristone, which can prevent almost, they say, 67% of emergency pregnancies. And then comes the number of levonorgestrel tablet, right, which is successful in preventing 50% of emergency pregnancies. So this is the answer for most efficacious. On the other hand, if they ask you which is the one which is most commonly used, the answer is LNG tablet. Now please, again and again I am telling you, it is the LNG tablet which is used as emergency contraception. Levonorgestrel intrauterine device, that is Mirena, is not used as emergency contraception. Okay, it is not used as emergency contraception. So copper T can be used, but Mirena cannot be used, right? Now, as far as in general statements about emergency contraception are concerned, then all emergency contraceptions, all EC methods are effective up to 120 hours. All emergency contraceptive methods are effective up to 120 hours, whereas ideal situation is within 72 hours. So ideally they should be used within 72 hours, but they will be effective even when they are used up to 120 hours. This frequently comes as a question, and we all do it, or you all do it wrong by marking it 72. Multi-load would be second generation. It is not a third generation compound. Okay, it is third. And nowadays it has been withdrawn, so we don't get multi-load in the markets. But anyways, if you're asking me that, then it is a second generation. Another thing about ECs are that ECs are also called as interceptives. The another term we use for emergency contraceptives is interceptives. Also, when you talk about emergency contraceptives, you should know that they act by various mechanisms. Okay, they can act by various mechanisms, but they do not act, the key word is after. They do not act after implantation, because anything that acts after implantation is an abortifacient and not an emergency contraceptive. So I said that they have many mechanisms of action, but in case you are asked the main mechanism of action of EC. Now this is again which you would do wrong, but the main mechanism of action of emergency contraception taken universally is by delaying ovulation. But ideally it is not simply one method. They delay ovulation, they prevent fertilization, they prevent implantation. So they act at various levels, but they do not act post or after implantation, because that is the feature of an abortifacient. Right, so that is one of the concerns, because Mirena itself causes amenorrhea. So a lot of patients would think that they are pregnant, but then you have to counsel them and tell them that it is almost 6 months time after which the periods would completely stop. So it takes average 6 months for Mirena to produce amenorrhea. So it is your duty as a doctor to tell the patient that it is one of the effects of Mirena and not a pregnancy, right? But yes, that can be a concern, because then the patient would think that she is again pregnant, right? Now, talking about the methods which are used. What all can be used? Combined pills, those which contain estrogen and progesterone, can be used as emergency contraceptives. When used, the dose of ethinyl estradiol is 100 micrograms and 500 micrograms of levonorgestrel. This is given twice, 12 hours apart. So the total dose would be 200 micrograms for ethinyl estradiol and 1 milligram for levonorgestrel. Then LNG tablet. Now please understand, LNG tablet is also described as Plan B. So at a lot of places it is even sold as Plan B. So when it is Plan B, it is LNG tablet. What is the dose? 0.75 milligrams given twice, 12 hours apart. And we have told that before as well. ideally within 72 hours, but can be given up to 120 hours, right? So given twice 12 hours apart. There is another way in which LNG tablet can be given, and it is a single dose of 1.5 milligrams. And last year, I think DNB, they asked this, which of the two is better? Then the answer is a single dose. Simply because the patient takes it as a single dose, there are no excessive side effects, and it is equally effective. So the patient does not have to remember taking the second dose as well, right? Third is mifepristone, which is also used as emergency contraception. Now please, again I'm pointing out your mistake. It is mifepristone used as emergency contraceptive and not misoprostol. Misoprostol is never used as EC. And if you talk about mifepristone, then it is given in the dosage of 25 to 50 milligrams as single dose. So this is given as a single dose of 25 to 50 milligrams. A newer drug called as ulipristal acetate is also used as emergency contraception. And as far as ulipristal acetate is concerned, again the dosage schedule is 30 milligrams single dose. Next, drugs which can be used, danazol can also be used, although it is never practically used because of the side effects. It is given in the form of 400 milligram tablets, 2 doses, 12 hours apart, right? So if you are enumerating the drugs, then yes, it is a drug which can be used. And in India they say that even centcroman or Saheli can be used as an emergency contraception. Shift to right. What do you want to see on the right? Everything is visible on the right. Centcroman can also be used as an emergency contraception, and then the dose is 50 milligrams. The dose is 50 milligrams taken twice, 12 hours apart. 50 milligrams. Now, Gynae, you would never ask this question if you had listened to the previous points. Who is going to answer the query of Gynae? They are asking IUD to be implanted within how many days of for EC? Yes, as simple. I said any EC can be used up to 5 days or 120 hours. No, why are you again writing wrong answers? Why are you writing the answers as 3? अभी मैंने शुरू में ही तो बताया, all ECs are effective when they are put within 5 days, right? So the answer is going to remain as 120 hours, whatever agent you may talk, right? So they are effective up to 5 days. Yes, the ideal thing will be to use it within 3 days. But when you are asking it will be effective up till what days, the answer is 120 hours. Is it clear to all of you? Okay. The next thing what we talk about is sterilization. Now, sterilization is the most common family planning method used worldwide. For all practical purposes, it is considered non-reversible. So when you are telling your patient, you have to tell them that it is a non-reversible method of contraception. There is only one contraindication to do sterilization, and that is a current or absolute contraindication is a current pelvic infection. The sterilization can be postpartum sterilization. Now when you say it is postpartum, the ideal time to do postpartum sterilization is within 48 hours. Whereas It can be done up to 7 days after delivery. After that, it is contraindicated between day 8 to day 41. So, if a female wants to get a postpartum sterilization but she did not get it done in the first 7 days, then it is to be done after 42 days. Again, it was this year's AIPG or DNB question, I think. Then the method we use for postpartum sterilization is called as mini lap, because the incision that we give is very small, so it is called as a mini laparotomy incision. The length of the incision is 3 centimeters. It is 3 centimeters. The most common method used in mini lap is modified Pomeroy. Again, I have given images of modified Pomeroy and Pomeroy on the club as again hashtag OBGY update, so see that as well. Right, so modified Pomeroy is the most commonly used method. Please understand, laparoscopy cannot be used for postpartum sterilization. Laparoscopy cannot be used for postpartum sterilization, and that is why fallope rings cannot be used as postpartum sterilization. Fallope rings cannot be used for postpartum sterilization. Why is it contraindicated? Because after that days there is going to be uterine involution and there is changes in the anatomy and there is going to be higher risk of failure. That is why we don't do it. So either you do it completely after when there is complete regression to normal anatomy, or you do it in the immediate postpartum. That's the reason, right? So laparoscopy cannot be done in postpartum and fallope rings cannot be used for the same reason. Laparoscopy is usually used for interval sterilization, or it is used. Can we use IUD? Where? Kolhapur, what are you trying to ask? Can you use IUD in the postpartum time? I'll tell you that, alright? I think I missed postpartum IUD insertion. Yes, I will just tell you that. Give me a moment. Laparoscopy is used in interval sterilization, or it is used along with abortions. The most common gases used for laparoscopic sterilization are carbon dioxide and nitrous oxide. The amount of gas used is 2 liters. The intra-abdominal pressure generated is 15 millimeters of mercury, right? So the maximum intra-abdominal pressure generated is 15 millimeters of mercury. Now, Kolhapur, I'll answer your question after I finish with sterilization, okay? Then, which methods are most effective, right? So, the most effective ones are unipolar and modified Pomeroy. They have least failure rate. But unipolar cautery is not used nowadays. It can be life-threatening for the patient. We don't use unipolar cautery at all. For that matter, people have stopped using cautery at all for sterilization. So among the used methods, the most or the least failure rate is with modified Pomeroy. It is 0.25. For Pomeroy, it is 0.4%. Right? Which has highest risk of ectopic. So the highest risk of ectopic is again with bipolar cautery, and the least risk of ectopic is with again modified Pomeroy. Now, I did give you the reversal rates yesterday, so we are not going to discuss that now, right? So, reversal rate was maximum with clips, followed by fallope ring, followed by modified Pomeroy, followed by cautery, right? Then, what else about sterilization? Okay, at what site do we do the sterilization procedure? It is done at the level of isthmus. The segment of tube or the fallopian tube destroyed with sterilization, that is with ligation. So when we use sutures, the length of the tube destroyed is 3 centimeters. And when you use fallope rings, the length of the tube that is destroyed is 2.5 centimeters. Fallope rings are also put at isthmus. They are also put at the level of isthmus. Okay, now answering what Kolhapur has asked me, they are asking, can IUD be used as postpartum contraception? The answer is yes, it can be used. Ideally, if you want to put an intrauterine device postpartum, it should be put after 6 weeks, right? It should be put after 6 weeks. Now, there is also something called as post-placental IUD. Now, this is a special thing that is being done where we put the IUD, so the intrauterine device is put within 10 minutes of placental expulsion. Within 10 minutes of placental expulsion, that is post-placental. And when you are talking about post-delivery, then it can be put after 6 weeks of delivery. Now, even IUD can be used as in lactating women, but there is a theoretical risk of increased perforation rates with an intrauterine device when used in lactating women. Why? Because whenever the baby suckles, there is a release of oxytocin and the uterus undergoes contractions, vigorous contractions. And therefore they say that there is a theoretical increased risk with IUD during lactation, and that is why I stick to the answer of POPs. Also, it is said that progestogen only pills are 100% effective. They are 100% effective when they are used during lactation. Ideally, the progestogen only pills should be started after 3 weeks, alright, or after 6 weeks. Ideally, they should be started after 6 weeks, but they can be started as soon as immediately after delivery. So ideally, even POPs should be used after 6 weeks, but practically we are saying they can be started immediately after delivery. Another reason why POP is the contraception of choice is POP has been seen to increase milk secretion and increase the quality of milk as well. Progestogen only pills have been seen to increase milk secretion and also improve the quality of milk secretion. So for all these reasons, POP remains the best answer for contraception of choice among lactating women, right? Now what I'm going to do is give you failure rates, right? And I'm going to give you failure rates as given by CDC. Now whenever we give failure rate, we divide into perfect use and the typical use. By perfect use we mean the ideal way in which the contraceptive agent should be used such that it will have the least side effect. Whereas typical use is something which is casually used by couples, and then what will be the failure rate. So if you talk about combined oral contraceptive pills, the perfect use failure rate is 0.3% and the typical use is 8%. This will be true for all combined agents. For example, if you talk about vaginal ring, for that also the answer will be same, so 0.3 and 8%. If we talk about a patch, then again the answer is going to be the same, 0.3 and 8%. If you talk about progesterone only pills, what is your doubt? Lactational amenorrhea effective in? I'll come to it a little later. Let's write down this first. If you talk about progesterone only pills, 0.5% is the perfect use failure rate and 3% is the typical way use. I just told you, a perfect use failure rate means the ideal condition in which the contraceptive agent should be used. So we follow the exact guidelines, and when we follow the exact guidelines, it will have the least failure rate. A typical use failure rate is when the couples use the contraceptive agent casually, they do not follow every guideline. Then the failure rate would be a little higher. So that is why we have two different values. Then if you talk about the copper T device, that is 380, then it is 0.6% and 0.8%. 0.6 and 0.8. If you talk about the levonorgestrel device, or if you talk about the Mirena, it is 0.2% as perfect use and again 0.2% as typical use. DMPA 0.3 and 0.3. Implants have the least failure rates, right? So implants have the least failure rate, it is 0.05. Both typical and perfect use, 0.05, right? If we talk about female sterilization, then again it is going to be the same, 0.5 and 0.5. These are highly effective methods and their perfect and typical use rates are same. Male sterilization, again 0.1 and 0.1%. Then if you talk about, I'll just take up your queries in 2 minutes. If you talk about the sponge, the vaginal sponge, which comes by the name of Today vaginal sponge. For this we divide it into parous and nulliparous, right? Parous and nulliparous, perfect use and typical use. So in parous 26% and in nulliparous 9% for the perfect use, 32% and 16% respectively for the typical use. If you talk about diaphragm, 6% is the perfect use and just double that up and it is 12% for the typical use. Finally, the last one is the condoms. So male and female condom. For the male condom, perfect use is 2%. For the female, it is 5%. And the typical use is 18% for the male condom and 21% for the female condom. Yes, now let me see what are the queries are you asking me. So Allahabad is asking for how long is there 100% contraception after delivery. Now please understand that women, so for this I'll give you two statements, remember those two statements. Contraception should be started in non-lactating women by 3 weeks Contraception should be started in non-lactating women by 3 weeks and in lactating women by 3 months. 2 more things I'm going to give you. Average time for return of menstruation. Average time for return of menstruation in non-lactating women. Answer is 6 to 8 weeks. Average time for return of menstruation in non-lactating women is 6 to 8 weeks. Another statement, ovulation can occur as early as 3 weeks. Ovulation can occur as early as 3 weeks after delivery. Alright. Any other doubts from contraception part? Anything else you want to ask me? Okay, then as of now we wind up the session and I'll say we are done with it. Okay, so you're asking me method. No, your question is wrong. You're asking me method of postpartum contraception in a decompensated cardiac patient. If a patient is decompensated, then the contraception is not the idea. You have to wait for the patient's condition to improve, and then the best answer for what is the ideal contraception in heart disease, the answer is intrauterine device. No, the best answer is sterilization. So let me write it down only. So if it is, there is nothing much in vesicovaginal fistulas. There are just 2 questions that are there. What is the investigation of choice? I'll just come up to that. First, let me answer what they are asking. So, in a patient with cardiac disease, the best method is sterilization. And the second best method is intrauterine device. Now, all of you who think that IUD raises the risk of infection, it is wrong. So much so that the American Heart Association and ACOG say that there is not even a need of giving antibiotics when you are putting the intrauterine device to prevent infective endocarditis, right? So there is, so this should be the order. The best answer is sterilization followed by an intrauterine device. Yes. Now what are you asking me? Oh, you are having a discussion on your own. Now what else are you want to, yes. So you were asking me about VVF. There is nothing much in VVF. When you say VVF, the test done to diagnose the type of fistula, alright, the test done to know what type of fistula it is a 3 swab test. In the 3 swab test, you keep, as the name suggests, 3 swabs in the vagina. Then you ask the patient to move about, and then you see which of these swabs are getting stained. If the upper 2 swabs are stained, and this you do after you inject methylene blue into the bladder. So if the upper 2 swabs are stained, it is a vesicovaginal fistula. If the lowermost swab is stained, then it is a urethrovaginal fistula. Whereas if it is only the upper swab which is wet but not stained, if it is only the uppermost swab which is wet but not stained, then the diagnosis is ureterovaginal fistula. So this is the 3 swab test to diagnose which type of fistula it is. Once you know it is VVF, then the best investigation is cystoscopy. Why? Because it tells you the exact location of the fistulas, the number of the fistulas, and the kind of surgery you would have to do, right? So this is about VVF. Also, what is the most common cause of VVF? In developing countries, it is obstructed labor. In developed countries, it is surgeries, gynae surgeries, followed by radiation therapy. Right? What else? I told you, Kolhapur, I've given you those things that what you're asking. That we are saying it is the ideally it should be used after 6 weeks, right? But theoretically or practically it is given immediately after delivery. So those people who say that the ideal is 6 weeks have now been refuted, and people say it can be immediately started after delivery, right? Prolapse you study on your own. You just need to know the names of the surgeries. Or do you want me to give the name of the surgeries? There is nothing to be known about acardiac twinning. It is not asked in your exams. It is an anomaly which develops where one of the twins does not develop the head, right? There are not many topics that you have to study on your own. You are just naming the topics. Prolapse, yes, I would say read it. RH, negative pregnancy, I've given it on the club. Even if you know those 15 points, you will be able to answer every question from RH negative pregnancy. At least go and write down those 15 points here. I'm telling you, those 15 points are all MCQs, and in total they will form around double the number of MCQs. So there will be 30 MCQs on those in these 15 points. Right? So read it. You've given it on the club. Please ask about the blood testes barrier to the anatomy teacher. It's not my domain. What are you asking me? Any other topic? No. We've covered anything and everything that I teach even in Delhi. Alright? So, we've given you almost we've given you everything what I am teaching in Delhi classroom courses, that to regular batches only, right? So we don't teach this much even to any other batch. So yes, but prolapse is one thing which I could have taught, so that you can study on your own. If you have doubts, all the VSAT students, so I give you a special leverage. If you have any doubts on questions on prolapse, you can all inbox me. I ensure that I will answer every query of yours on the inbox. All you have to write is VSAT Gynae, and I will know that it is a talk between us. Right? Right? And if you have any other doubts, if you still have doubts on prolapse, then read it on your own. Ask me doubts. I will solve each and every student's doubt on inbox. I promise you that. Just write VSAT Obs and Gynae. Right? और अगर फिर भी आपको मुश्किल लगेगा, then I'll give you an update. अगर फिर भी मुश्किल लगेगा, तो I will take the class. Right? Anything else? Alright, so it was fun teaching you all. It was a pleasure. You are an intelligent batch. Just keep studying. Treatment of PID is not what you are supposed to know, what is NACO giving. So there are those kits which the derma people are going to teach you. You should know what are the what are the constituents of the kits that are given by NACO, right? So that would be taken up in dermatology. They are more aware of it than us. So because it comes to us directly from NACO, and all we do is distribute, right? Which book? Study the notes. Along with notes, try and combine types of MCQ books, by which I mean take one AIPG book, take one DNB book, take one AIMS book, and do the subject questions from those books rather than doing the subject wise guide, right? करम सर परेशान मत हो यार, नोट्स बहुत सारे हैं, उतना तो पढ़ो पहले, ठीक? एटलीस्ट गो थ्रू व्हाट आई हैव टॉट यू, And then if you want to study more, then there is no limit. We can still have, see, obs and gynae, you can't do it if you think you can do everything in, even in how many hours we give. We study obs and, you have been studying obs and gynae for 5 years, right? Or 2.5 or 3 years. So read the notes. Yes, they will be. At least go through the notes and try and answer the questions, and you would know yourself whether notes are enough or not, right? Williams, Belgaum. Really? You think you can read Williams? अच्छे लोग Williams नहीं पढ़ पाते. And a very good example is the guide which comes for obs and gynae. The interpretation of Williams is something which only a person who is learned can do. It is a very complicated book. It gives everything in the form of studies, and it doesn't give a consensus. So you have to be smart enough to read Williams. All right? Okay, on that note, good night. Thank you so much. Any of your doubts, put it on the club. I'll solve them. How to contact me? On the Facebook club. I am there. On the DAMS exclusive club. Contact me.